So good morning, everyone. I welcome you all on this Sunday morning for the last day of the IPCI 2021 meeting. Like the past 2 days, today the final day of the meeting, we have a presentation about coronary physiology and also the imaging in complex coronary lesion subset. In addition, we do have two interesting sessions, one about the complication and another about imaging exotica. For today's session. So let's start the first session about the coronary physiology and the complex lesion subset. Let me invite Chairperson Dr. Praveen Chandra, Dr. Barua, Dr. Mohit Gupta, and Dr. Hiramat. May I also request panelists Dr. Kaparthi, Dr. Hemant Madan, Dr. Prakash Chandwani, Dr. M.S. Sandhu, and Dr. Sajan Narayan. And I request the chairperson and also the panelists to have a discussion at the last so that we can complete the session well in time by this Sunday afternoon. So let me invite Ranjan Sethi, who's going to have an online presentation for the pre-recorded talk. And Ajay, are you going to coordinate the same or Ranjan is there?
Dr. Ajay, you're muted.
I don't think Ranjan is there. I think Dr. Madan can take over, sir. He's there. I see him on screen, and Dr. Hiramat can help me. Hi, sir. Good morning. You're muted.
Yes, Ajay, morning. Can
morning,
you hear
morning,
me?
Sir. Yes, I can hear you.
I don't see Dr. Hiramat around. Sure, we can
there.
start off with the...
Dr. Hiramat is there, sir.
He's there. Dr. Hiramat is there.
Okay, hi, Dr. Hiramat. So why don't you kind of start,
Yeah, I think the first part of the meeting, beginning, is really interesting. And we are all going through a phase where we are learning the complexity in physiology assessment. And from this angle, we have a first presentation by Dr. Ranjan Shetty, and he will be talking to us on resting indices for the assessment of intermediate lesions in cath lab. Is there a way forward? Over to you, Dr. Shetty.
Good morning, IPCI, and thank you for inviting me. Thank you, Dr. Rajesh, for having me here. I will be talking about resting indices. We all know that today angioplasty is not as simple as it was before. We need to produce physiological changes, especially in stable heart disease. And it is a physiology guided PCI, which is shown to have morbidity benefit, mortality benefit, and probably that will be the only way to do angioplasty now and in time to come. Most of the guidelines do recommend FFR as well as IFR, because it's very important that if there is no objective evidence of ischemia, it's important to follow one of these. And there's a lot of data with FFR. FFR is now available in most of the cath labs, but it's not widely utilized for obvious reason. One is obviously the cost. Second is the discomfort of the drug. Third, it's most of the time for a borderline lesion. Borderline lesion can be managed medically also. Whenever you decide to do angioplasty, the procedure of FFR itself is much more prolonged and more expensive than a stent. So it doesn't work that way. You're trying to save a stent of 30,000, but the procedure now is 60, 70,000, and it takes 30, 40 minutes, whereas angioplasty could be 20 minutes. So definitely there's a need for a simpler procedure, a quicker procedure, and procedure where you're doing without doing multiple intervention. So that's where the resting indices come in picture, and we all understand that. There are many types of resting indices. There are different companies which produce this resting index. There are indices which use whole cycle like DP by DA. There are or the RFR of about vascular. Then there are very specific. It could be diastolic, it could be wave period or absence. So these are all the ways which different resting indices are measured. But fortunately for us, they behave almost same, and their collaboration between among these is almost very nearly one. That means you could use either of the indices which is there. Now, non-hyperemic indices believe in a concept that even during non-hyperemia, we are able to measure significant, physiologically significant region. So this graph tells us that if it is RFR, it involves the whole cycle. If it is PDPA, again involves whole cycle. If it is IFR, it will involve the wave period, whereas DPR involves the most of the diastolic period. So let's look at IFR, because this was the first to come and this is the one with lot more data. So in IFR, it is believed, see, basically, if you look at the concept of FFR, it's about resistance, and resistance being it's constant and not getting altered with cardiac cycle. Initially, when FFR came to do this, we had to give drugs like adenosine or some other alternative drugs. But later, when you divide the cardiac cycle, it was realized this period of the diastole after the incisura, this period after the dicrotic notch, actually this period the resistance is naturally constant and it does not vary much beat to beat or during a cycle, and this could be used as an alternative to using a drug. And this period, if you analyze, you could get the right physiological value. So wave-free period is a portion of diastole which is where the resistance is independent of heart rate, blood pressure, CAD, as well as location of the artery. So this works extremely well. This is exactly what we are trying to do by adenosine. You're trying to paralyze the your microcirculation. If that is naturally done, it's independent of lots of variables, that works extremely well. So how do you do IFR? Almost exactly like FFR. It's the same wire which is passed. This is the software of one of the companies. So it's of Volcano, which is now bought over by Philips, and the console is little different from the FFR console. Adenosine is easy, but then there is always controversy about adenosine. There are also times where you have false positivity in case of caffeine effects with adenosine, and asthmatic patient become very symptomatic, and sometimes the stable patient is made unstable by adenosine and the heart rate dips 5. So since the hypothesis generated here is if you are able to have a constant resistance, you can use this. So the resting wave, it was found that in the resting wave period, this period, actually the resistance in the coronaries at that time at microvascular period is exactly like FFR. Hence, if you restrict your measurement to that period, you don't have to do the FFR. Now, the next question what we need to answer is the concept right? Yes, concept is right. Is it studied in multiple trials? Yes, we have trials which looked into this and understood that it is okay to do that. And if you do that, the correlation between FFR and IFR is reasonably good. It's not absolute, but it's reasonably good and it works well. So the defer trial and treat trial for FFR actually says 0.80 as the cutoff. Initially it was 0.75, but the FAME cutoff has become 0.80. Now we know this cutoff is for most of the resting indices, almost all of them, the cutoff is 0.89. So if it is 0.89 or below, that is fine. You don't need the grade borderline zone. This works well. But we do see a good R square. R square is the way you see the correlation between the two parameters. We see a good R square comparison between FFR and IFR, but it's not absolute. That means there will be around 20% cases where one of them will be positive and the other is negative, and we need to understand what to do. But the common question is asked, is the data for IFR is enough? It's actually enough, because if you look at defined flare and Sweden heart, these two, the combined number of patients is much more than the FFR studies, because FAME2 and FAME1 actually have much lesser patient compared to defined and IFR. So it makes sense, and you could use IFR or any of the resting indices as an alternative to FFR. So let me quickly go through these two trials. They are randomized trials. Just a quick look. Here, the IFR in both this trial was actually compared with FFR, and they had, they had two arms, FFR arm and IFR arm. One was based on FFR, you defer or perform PCI. Again, the same thing. You based on IFR 0.89, you defer or perform PCI. So it's similar to the other trials of FFR which you have, but bigger sample size, and it works better, and it was done for intermediate group. And what we find is number of stents used is almost same in both the group, not too much different. But total adverse event are again, it was the physiology-driven angioplasty was it was quite effective, and IFR guided PCI was safe, and the results were comparable to that of FFR guided PCI. So if you see that everywhere the p-value between the two group, whether it is IFR guided or FFR guided, there was no increase event in deferred patient. And the advantage also is significantly less number of patients were revascularized with IFR. So less stents were done, less procedure was done, but it did not correlate with more adverse outcome. So that is what is good. The same thing is seen in Swede heart trials. So both are comparable. So today's era, you could use FFR or you could use IFR. But when you use IFR, it's much simpler, much quicker, and the risk factor is easy. Now the cutoff for FFR today's era is 0.80. Cutoff for IFR almost, just stick to 0.89 as the cutoff, and that's a good cutoff which works well, and it can be checked. Now, we could do the hybrid approach also whenever it is in doubt, but most of us now what we do is we use the resting index. If it is positive, we go ahead. Only when you have doubt or when there is a lot of clinical difference, then FFR is used. So lesions like this, it's very difficult to pick up which is significant, but with IFR you can do. And also the advantage of IFR is the pullback. FFR pullback requires IV adenosine, more expensive, more difficult, whereas IFR pullback is very straightforward. So stick to the algorithm of 0.89, more than 0.89 leave, less than 0.89 treat. There is also co-registration which looks like this, so you know exactly where the problem is, and you could also do what we known as virtual stenting. So if you do stenting from here to here, you know the IFR gain, and post IFR also is easily done. So advantage of IFR, no adenosine, very quick. FFR, the data. What do you do with discordant? In discordant, actually, you have to go take it clinically. If you do both IFR, FFR, if it is discordant, if it is a discrete lesion, treat it. If it is diffuse lesion, leave it. It's all risk versus benefit. So as a dictum, if there is discordant, if you think your angioplasty procedure is not risking the patient, you treat it. Now, let's do the other newer resting indices. We have RFR, we have DPPR, and we have other indices. But I'm just going to show you one slide that any other indices you take and you compare it with IFR, their correlation is beautiful. It's almost unity. So use any of them, they will work as good as IFR, and it should be okay to use any of them. So across all these different newer indices, the area under curve is still great. So you could use any of the indices, but data is little more with IFR. For lack of time, I think I'll stop my talk here. Thank you for very patient hearing. Just to summarize, resting indices are here to stay. Any resting indices is fine. You don't need to use adenosine. Procedure is very, very quick, and you can get over it. Thank you.
Yeah, thank you, Dr. Ranjan. I hope you're staying with us right till the end of this session. We now invite Dr. Ajay Swami, and he will be talking to us under acute setting, that is FFR versus resting indices in ACS. Over to you, Dr. Ajay.
Thank you, sir. Am I audible?
Yes, very well.
Yes.
My screen is visible?
Yes.
Yeah.
Right. So before I begin, am I full screen yet? I should be.
Not yet, sir. No, sir. Can you go to the slideshow at the bottom?
Is it
Yes,
full
sir.
screen now?
Yes.
Right. So before I begin, my salutations to my teachers, some of whom I see in the audience and some of whom are not. We have the daunting task in the next 10 minutes of looking at FFR versus resting indices in acute coronary syndromes. We'll just look at a case. This is a 76-year-old diabetic hypertensive dyslipidemic, recent inferior wall with elevated troponin. This is what his RCA was like, a subtotal occlusion. And you can see extensive disease in the left system with diffuse proximal disease in the circumflex, which is a quite large disease, large vessel, and in the LAD as well, proximal to mid segment, heavily calcified and diseased. This is another case, 62-year-old dyslipidemic hypertensive, second day of MI, but continuing ongoing chest pain. And you can see that there's STEMI 1 flow in the distal LAD. Multivessel disease in STEMI is always associated with a poorer long-term prognosis. Earlier recommendations was only to do the culprit vessel revascularization, but newer trials suggest better outcomes. The Americans say selected patient revascularization, and the Europeans say routine revascularization prior to hospital discharge. This is seen in up to 50% of patients with ACS, especially STEMI. The culprit lesion is obviously very often very clear. There's a clear recommendation for the culprit lesion to treat. But the non-culprit lesion is not so straightforward. How do we assess this? Angiography, physiology, imaging, functional, astrology, whatever.
Dr. Ajay Sami, we seem to have lost your audio.
Yeah.
Ajay, you are not audible.
Could you mute and unmute yourself once, sir?
Is it audible now?
Yes. Yes, Ajay.
Yes,
go
sir.
ahead.
Yes, sir. You're back on.
Right. So the questions remain as to the type of assessment. Is it angiographic, physiological, imaging, functional, astrology, timing of the assessment? When do we do it? Do we do it at the time of the initial intervention? Is it a little later? What about the timing of the PCI or the intervention? At the timing, primary PCI, staged procedure before discharge, 4 weeks. Can physiology help? That's what we need to answer. And that's what we're going to look at. There are many other techniques, but physiology is what we're going to look at in the next 10 minutes. My previous speaker has made it easy. Just one takeaway from this slide. Essentially, FFR is the ability to measure the gradient across a lesion after resistance caused by microcirculatory disease has been removed. That means at maximum hyperemia. That's what it means, that we have eliminated the microcirculation and we're getting a true gradient across the stenotic segment. Whereas the IFR says that let the microcirculation remain. Coronary microvascular resistance is constant during diastole. Most of the flow is in diastole. And since this resistance is minimal, PDPA ratio during this particular interval is a surrogate marker of coronary flow. And so this is a surrogate marker. It's not really a true marker. And this is a basic difference to appreciate. These are all the indices which he's already spoken of. I'm not going to go through them. Now, what happens in acute MIs or in ACS is that this microcirculation kind of misbehaves. And there is a problem. There is a increased non-culprit coronary resting flow due to multiple mechanisms, either because of increased local vasoconstriction in the non-culprit flow. There's a blunted hyperemic response. The ability to take away the resistance is not as good as it is in a stable CAD patient. And there's microvascular compression created by remote edema and increased LV-EDP. That kind of makes it more difficult to eliminate the microvascular resistance that we try to remove when we try and induce hyperemia. In summary, this is what it is: local vasoconstriction, elevated CRP, raised LV-EDP, structural alteration of microvasculature caused by embolization and distal embolization in both culprit and non-culprit vessels. Now, what's the natural history of, or what are the methods available? One is the conventional angiogram. The CFR, which is extremely interesting, but very, very cumbersome to measure. This does not discriminate between epicardial and microvascular disease and is a summary of the total amount of resistance offered by both. There's a difference in the hyperemic and the resting traces, and that's what the ratio is going to look at. The FFR that we've just spoken about, the advantages are it is recommended and has been validated to guide revascularization in stable patients. But as we've spoken of, in the presence of microvascular disease, may underestimate the non-culprit lesion severity in the acute setting. The IFR, the problem is that it may actually overestimate because the microvascular resistance is actually more. The PDPA are the same, and the QFR, which we'll not speak of today. I've chosen this study for the simplicity which it shows. They looked at 101 patients with acute MIs and looked at the FFR and the non-culprit lesions and repeated this after a mean of about 35 days. In 14 patients, they measured the IMR as well, that is the index of microcirculatory resistance. The values were not significant at both these time periods, But in 2 patients, they had a higher than 0.8 at index and a less than 0.75 at follow-up. This is in a small number of patients with no difference in the corrected TIMI frame count, the percentage stenosis in the MLA or the IMR. And up to 10% of lesions actually crossed the clinical cutoff values. That means what they measured at day 0 and at day 35 were not the same in up to 10% of patients, which reached clinical significance. So this tells us that it's not perfect to do it right at the beginning. There is a natural history involved. What about the IFR? This has been shown that IFR is low numerically at the acute stage, and it does not change so much. And the FFR, as we've spoken, is actually high initially and then comes down later. Thus, IFR overestimates and FFR underestimates the NCL. This is a slide which shows the natural history of what happens to the CFR, the FFR, which actually slightly decreases, and the IFR, which actually slightly increases. So this shows us that over time, none of these values are going to remain the same, and it makes it slightly more complex to analyze. If we look at meta-analysis of randomized trials of 7,000 patients, 3,000 multivessel PCIs, underwent culprit vessel only versus this one, there was a lower risk for reinfarction, cardiovascular mortality, and repeat revascularization in patients who underwent complete revascularization. Definitely, multivessel PCI is safe. NCL, when addressed, decreases revasc. Only one large trial has mortality benefit. The meta-analysis actually only shows benefit with respect to revascularization rather than mortality. But can we make more precise decisions? Let's look within. The studies that looked at angiography versus FFR guided are these: the PRAMI and the culprit only angiography guided. The FFR guided were dynamic, compare, and complete. And if one looks, there is a consistent decrease in the PRAMI, culprit, dynamic, and compare up to 1/3, 9% versus 23%, 10% versus 21, 13 versus 22, 7% versus 25. Only the complete showed not so much of a difference, but it still showed a benefit of complete revascularization. Out of these, as we've spoken of. Now, when do you defer? What about PCI deferral? Can we defer it safely based on our physiology? Yes, we can. In fact, what it shows us is that the safety of deferred PCI based on physiology is almost the same in stable angina versus acute coronary syndrome. Does the FFR of the non-culprit lesion predict long-term events? This also, it scores full marks that if one does have an FFR of less than 0.8, which is untreated, our survival figures, event-free survival, is much less, out to 24 weeks. So definitely it does predict the occurrence of long-term events. In summary, FFR versus angiogram, angiography guided alone, in 31% of dynamic and primal T, they did not need PCI, and 44% of compare acute did not need PCI when FFR guided. But surprisingly, the hazard ratio is similar whether we use angiogram or we use FFR in these large trials. Thus, FFR guided strategy produces similar results with fewer lesions intervened. Clearly, complete revascularization reduces the need in the short and intermediate term. What about IFR? Randomized data is absent, to be brutally honest, but there is this study which was presented in EuroPCR, which was a multi-center observational study, 356 patients with 472 culprit lesions. They looked at the cutoff of 0.89, excluded cardiogenic shock and imperfect results in the culprit regions from the analysis. What did they find? The MACE at follow-up was basically 9% at 22 months with 1.4% cardiac death and 3.4% MI. The events were similar in the group with an IFR greater than 0.9 and deferral versus those with less than 0.89 who underwent revascularization. And there was no difference in the subgroups between NSTEMI versus STEMI, which means that this strategy is perfectly safe in the short term. Whether it's the right one, we need a little more data. In summary, physiology in ACS, if we use IFR, 1 in 3 of those treated non-culprit lesions would not have been significant at 30-day follow-up. Whereas if it's based on FFR, 1 in 5 would be significant at 30-day follow-up, that is when we defer. So to rule in, IFR overestimates, and to rule out, FFR underestimates. That is the take-home message that we get. There is an additional variable in terms of imaging, which has shown us that in patients who have got TCFAs, as shown in the FFR OCT combined design, there is a decreased incidence or an increased incidence of adverse events in case people have TCFAs, regardless of whether they're physiologically significant or otherwise. Thus, the addition of imaging to physiology is an intuitive and extensive, it gives more interesting data. It clearly adds to risk stratification. CT, biochemical marker, NIRS, and thermography might help. This has reignited the debate on vulnerable plaque versus vulnerable patient. When do we assess? At the index event, at initial hospitalization, or staged? The jury is still out. What we do at our lab, I'm going to show in our 2 patients. When do we intervene? Again, there seems to be multiple approaches across the world. At index procedure, before discharge or stage. We prefer staged, if possible, before discharge. 4 out of the 7 trials have done it before discharge. In complete, the good thing is that the staged, the benefit of complete revascularization was independent of the timing, whether it was done before discharge or done up to 40 days out. And there were very, very few events between the index procedure and the non-culprit region revascularization. So this strategy appears to be safe and must be tailored to the local available resources and protocols. In risk benefit analysis, in hemodynamically unstable patient, we must individualize. In stable, we just do the culprit lesion. For unforeseen complications, risk is little higher and it's tolerated less well in the acute situation. So it's a good idea to do it later. Often many of these cases are done out of hours. So prudence is important. If it's critical, we consider at primary PCI or pre-discharge. Complicated lesions definitely stage. All others need to be individualized. What happened to our patients? This is revealing. We finished with the RCA and then look at the left. You can see that there's diffuse disease in the LAD and the circumflex. The FFR of the circumflex and the RFR were negative. FFR wire could not be placed in the LAD because it is so diffusely diseased and calcified. The OCT catheter wouldn't cross either. So we did a plaque modification with a rotablation and then did an OCT post-rotablation. For the sake of time, I'm going to show you that we did have some cuts. Maximum thickness of calcium was still 800 microns. So we opted for a cutting balloon thereafter. We did the entire lesion, and post-cutting balloon, one can see that the cuts are a little more extensive and more full thickness. And we felt that we could stent at this time. That's what we did. And then did an OCT again after a post-dilatation. Still, we found one particular place with a little bit of under expansion around 30 millimeters. And this was post-dilated with an NC balloon. And that's what we got. We remeasured the FFR and the RFR and the LCX after doing the LAD, and it wasn't different at all. It was pretty much the same. So we left it alone. These are our final views of the circumflex. The second case that had the lesion in the LAD, we performed after finishing his angioplasty acutely. We brought him back to the table after 4 days since he was perfectly stable. This was the initial angioplasty. Final result looks all right. We brought him back after 4 days for an OCT plus a functional assessment of the OM2. The functional assessment of the OM2 was negative. Both FFR and RFR were negative. When we did the RFR to the LAD, to our surprise, it was borderline, 0.89. And we went ahead and did an OCT, and we found that there was a distal edge dissection, which I'll try to show you. There, you can see a full thickness edge dissection right across. And so we went ahead after sizing it, put another small stent, and then remeasured the RFR, and now it was 0.97 along with the pullback. We also did an FFR. This was just for our research purposes, which was also negative. And the OCT, which was perfectly good with good areas. And that's our final angiographic result. So complete revascularization is definitely beneficial. The timing is governed by the baseline risk. The timing of intervention is covered by the risk and cost plus expertise. Physiology is an extremely useful guide, but with an eye on the baseline risk. FFR is valid within limits. IFR initial data is encouraging, but we need much more data before we make hard decisions based on IFR. Plaque characteristics stratify risk significantly as per recent data. More data is required in this particular area. Thank you for your attention.
I think that was a wonderful overview of, physiology in acute MI for non-culprit lesions. Dr. Ajay Swami, this was really educative. So do we have time for discussions, or we move on to the presentations?
Sir, at the end of the session, sir.
Okay, fine. Okay. So next presentation, I think we can have, who's the next in line?
Dr. Srinivas Reddy, and he will be talking to us on IFR evidence-based expert opinion.
Dr. Reddy, could you unmute yourself, please?
Yes. Can you hear me now?
Yes.
Yes. Very good morning to everyone. First of all, I would like to thank the organizers of the IPCI and especially Professor Rajesh for inviting me to share my talk. And I'd be talking about IFR and evidence-based expert opinion. I hope you can see my slides. We know that FFR is the gold standard of testing for coronary physiology, especially in the intermediate lesions. But as of now, we have got the non-hyperemic pressure indices, of which IFR is an important tool to assess the lesions in intermediate lesions. So how to do a decision making using IFR from the data from the different player and IFR SPIDA trial, one of the largest trial which was based on which has come into the guidelines. It has been clearly shown that in these two trials that the IFR was non-inferior to FFR in patient with stable CAD, and in the defense trial and IFR SPIDA trial in patient with stable CAD and ACS patient when performing the non-culprit lesion. It was in both the trials the IFR was non-inferior to FFR. So in a patient with when a patient comes with stable CAD, how do we utilize this IFR in our scenario? If the symptoms are stable, then you can just keep the patient on medical therapy, and if it does not have any relief of symptoms, you can go for any ischemic stress testing, and if symptom still does not relieve, you can go for coronary angiography, and on table you can assess if the stenosis is more than 80% perform PCA. Borderline lesions, you can perform IFR. If IFR less than 0.89, you can go ahead with PCA, and if IFR is more than 0.89, you do not perform PCA and defer the revascularization. So what is the data regarding the deferral of revascularization based on IFR and FFR? From the pooled patient analysis of the defined flare and the IFR SPIDA trial, it has been shown that there was significantly less revascularization was performed based on IFR versus FFR, and outcomes in deferred ACS patients were similar in both the IFR and FFR arms. So what about the safety of using these two tests, these tools in the acute coronary syndrome setting? So from the pooled analysis, again from the pooled analysis of the defined flare IFR SPIDA trial, they had 440 ACS patients. The outcome was that FFR was associated with a significantly worse outcome compared with the deferral patient in ACS as compared to stable angina. But IFR yielded a similar outcome among deferred patients regardless of the clinical condition. So now with this large data, it has found into guideline that for the IFR is recommended for functional testing by ESC guidelines to assess the hemodynamic significance relevance of the intermediate stenosis. It's a class 1A indication. So now with this background data, let's look how to apply this in our clinical scenarios. So this is a 66-year-old female patient who was hypertensive. Who had chest pain in November 2020 presented for last 3 hours. She has been diagnosed to inferior MI. So this is the angiogram of the patient. You can see in the left system LAD and LCX were normal. There was around near significant lesion in the ramus, and RC was the culprit lesion at that time. And the patient patient was performed a primary PCA to RCA, and the non-culprit lesion after 5 days of the primary event, he was taken up for assessing by physiological assessment. You can see that this lesion IFR was performed here. This was the stage pullback, and the values were significantly less than 0.89. This patient underwent OCT guided stent implantation. There was on the OCT there was only more of a fibrolepid rich plaque, and this patient underwent a PCA based on the physiological assessment of the non-culprit lesion. In this second case, she is a 60-year-old female patient who was hypertensive and again presented for chest pain for 3 hours. This was in July 2020. Diagnosed with inferior and complete heart block, and after this was the coronary lesions. You can see from this angio there is a mid L6 there was a discrete lesion, and LAD there was a borderline lesion prior to the bifurcation, and RC was the culprit lesion for which primary PCA was performed, and the patient was taken up for after a week. The patient was taken up for assessment by physiological assessment. You can see the pullback IFR was performed in L6. You can see the IFR was 0.77, and the same region, FFR was 0.77 and IFR was 0.73. So you can see from here, both the testing IFR less than 0.89 and FFR also 0.77. So both the tests were concordantly, they were positive. So this patient underwent a PCI to LCX, and what about the assessment of LAD? So for the LAD, mid-LAD lesion, FFR pullback was FFR was taken from the main LAD. It showed an FFR value of 0.83, and from the diagonal it was taken. It showed a FFR value of 0.84. But you can see here the both the FFR was around borderline negative, but the IFR was coming positive, less 0.83 and 0.84, which was positive. So you have a IFR which was positive and FFR which is negative. So we have a discordant result. So what do we do? So so when you have a like this scenario, non-hyperemic pressure ratios versus FFR, what do we do with such type of discordant results? So, so initially perform any one of the FFR or any one of the NHP or non-hyperemic pressure ratios, and you can do a preferable IFR. Then do a second index if the test is negative and if you have a high clinical suspicion or symptoms related to the lesion, or if it is borderline lesion like the FFR coming as 0.75 and 0.85 and or NHP are coming 0.85, 0.93. So if it is negative, you can defer the reverse lesion. If it is positive, if it is discordant, then you have to do either if it is too complex, you defer the reverse lesion, or perform based on the intravascular imaging to assess the lesion complexity, morphology, and the characteristics of the lesion. So in this case, we have performed IVUS. You can see in this lesion there is a in the middle there is a significant stenosis with the MLA coming close to 3, and there was a calcium around 90 to 180 degree calcium specs were then. So this patient was based on the lesion morphology, we have kept on clinical follow-up and was advised that he would require a PCI in the near follow-up. So looking at the in tandem lesions or diffuse lesions in IFR pullback pilot study was done, which comprised 39 patients by Dr. Nizar. You can see from this, you can take in a diffuse lesions, you have a step up like this. Focal disease, it will be straight upright step up. In diffuse disease, it shows a gradual decline. So you can calculate how much is the instantaneous IFR fall per distance traveled. So with this now, although the lower diagram shows the virtual PCI where you stand the proximal region and try to predict what is the likely FFR post PCI. So this is actually cannot be incorporated into clinical studies because this is only done offline post PCI. So my other case is 72-year-old male patient, hypertensive, who had unstable angina, and he was taken up for angiogram. You can see here there is a diffuse disease of LAD, calcific from the ostium to the distal, and LCX significant stenosis. And RCA, this was mild disease. So this patient underwent IFR pullback. You can see here there were 2 diffuse lesions. The IFR, the whole length came around 0.61 and 0.62. So we don't know clearly because we didn't take the motorized pullback. So this patient underwent a PCI to LAD by IVL and OCT guided. And after stent implantation, we have taken the IFR again. You can see from here both the values are come 0.8 and less than 0.89. So we fixed the distal lesion also with the other stent, and this was the angiogram following the performance of the LAD and LCX PCI. So similarly, Dr. Ajay was also pointed out that we have got a new IFR 4 registration, although it's not available with us. This gives you the instantaneous drop pressures across the lesion. So it can give you whether it's a focal lesion, diffuse lesion, or focal in diffuse lesions. So my take-home message would be that FFR remains the legacy for coronary physiology index in common daily practice. IFR is an alternative because it's quicker and avoids unpleasant side effects of chest pain and other complete the heart blocks. Emerging data supports that IFR may be superior to prognostic tool in comparison with FFR for differing non-culprit lesions in patients with ACS. And again, the real-time correlation with the IFR pressure with with the coronary angiogram changes the paradigm of functional issues assessment and helping us in guiding PCI. Thank you for your kind attention.
Thank you, Dr. Reddy. I think again, this was a wonderful presentation on again physiology. Going into the depths of physiology, I must say, and really, IFR. I think IFR and RFR both are one of the first steps most of us are doing these days before we embark on the FFR thing. Because it is the same wire, and takes less time, and of course we can get so much information. So the next presentation, Dr. Hirimat.
Sir, you're muted, sir.
Okay, we move to Dr. Madhusridharan, and he will be talking to us on battle of resting indices are all the same. I think this is one area where most of us struggle. So let's hear from Dr. Madhusridharan which way to go.
Dr. Madhu, you're muted.
I think you're still muted.
Okay. Is it? Am I audible?
Yes, sir, you are.
Sure. Morning, and thanks for the organizers for giving me the invite, and it's an honor to be presenting in front of Dr. Koo. Yes, so we'll be talking about the battle of resting indices are all the same. Coronary physiology in perspective, it's an important tool that can guide management decisions for intermediate lesions and multiversal CAD. It's amongst the most important additions in the armamentarium of interventional cardiology, yet remains significantly underutilized. Let's look at the first study, the one which paved the way, that's the DEFA. And you look at the cardiac death in MI after 5 years, it's significantly less in the DEFA group as compared to the PERFORM. And here they used a FFR of 0.75. And it remained even after 15 years of follow-up, which showed that deferral of lesions is safe. And there's a FAME which showed physiology in multivessel disease. And at 5 years, it showed that survival of free of MACE at 5 years was significantly lower in the FFR guided group. And you have the data, you have large amount of data for FFR with the DEFA, FAME, FAME2, Dynamic 3, Premalty, Compare Acute. And it all showed the same thing, that FFR guidance is superior to angioplasty with angiography alone. It improves outcome, it reduces the risk of MACE, reduces risk of death and MI, and it results in function class equal to or better than an angio-guided PCI. And it makes economic sense, which is more important as well, with 30% fewer stents, and it saves expenses and reduces contrast. So that is what with FFR, and then came IFR. This is a validation of IFR versus FFR. You've got lots of data, we've advised, verified, the PARC group from Korea, Resolve, Advise, and all of them showed that you have a cutoff now. It's FFR, it's come as 0.8, and it's IFR is 0.89. More than 0.89, you defer, and less than 0.89, you intervene. This is from the Advise and the Resolve study group. So this is the validation of IFR. The values of IFR and FFR are closely correlated. It's a good diagnostic accuracy to predict FFR of less than 0.8. And it's validated against myocardial ischemia by perfusion imaging and PET with values of the area under the curve similar to that of FFR. CFR is more strongly correlated to IFR than FFR, which is one of the reasons for the discrepancy between the two. You got large amount of data, outcome data with the resting indices. This is the defined FLAIR and IFR sweetheart, the 2-year data which show the primary outcome, death, non-fatal MI, or unplanned revascularization were essentially the same for FFR versus IFR, as well as the individual components. So there was no significant difference between an IFR guided and an FFR guided strategy. But what is more important is that the number of patients deferred were more with the IFR. So you have lesser number of stents used, lesser number of people treated, but still you had the MACE, which is the same. So IFR, you could defer more patients with the same results as that of an FFR guided strategy. So what are the advantages of resting indices? For the patient, it's better comfort, no adenosine. You don't need to have any specific vascular access and reduces the procedure time. For the doctor, you have large amount of RCT showing that's non-inferiority. It reduces radiation, reduces time. It's better in tandem lesions, which is, with FFR, it's more difficult. You can interrogate multiple lesions without increasing time. And with an integrated system, you have the option of a virtual stenting and an accurate assessment of the stent length. And for the healthcare, it reduces time and reduces the cost. But you have disadvantages as well. What are the disadvantages? That you don't have any independent superiority study to show improved outcome. Even IFR had been compared to FFR in Defined Fair and IFR Sweetheart. The outcome studies were conducted in relatively low-risk patients. You have a false negative IFR in proximal large coronaries in left main proximal LAD in up to 30%. The hyperemic gradients are 2 to 3 times larger than the resting gradients. So avoiding adenosine reduces sensitivity of the test, and the drift is more, and post-PCI physiology cannot be assessed by the resting indices. So physiology, you have huge evidence of data for FFR as well as for resting indices. It is safe to defer. You have benefits of physiology-guided revascularization. There's equivalence of IFR and FFR despite a mismatch of 20%, which is seen in all trials. So it is not the intakes, but the adoption of physiology that's important. So this is the currently available physiological indices that we have. The non-hyperemic wires would be the whole cycle, which is PDPA or the RFR. And you have the diastolic subcycle, that's IFR, DFR, and DPR. You also have the angiography guided, the QFR, and outside the cath lab CT guided, which we are not talking about. So these are the non-hyperemic indices, which you're going to talk about. So what is the difference between the various resting indices? In IFR, you take the PDPA in the diastolic wave-free period. This is the period that we take, that is 25% into diastole and stopping 5 milliseconds before the end of diastole, and the cutoff is 0.89. You take 1 beat, and it is by Phillips. GFR is the diastolic hyperemia-free ratio. Here is an average PA, and PA is in the downsloping part. This is where you take this part of the diastole, that's the DFR, and this is the Boston one. Again, it's 0.89. DPR is the diastolic pressure ratio. That's PD by PA over the entire diastolic period. This is the DPR where you take the entire diastolic period. And again, it's 0.89. You take an average of 5 cycle, and it's with options. PDPA is a PD by PA of the whole cycle, and you take an average of 5 cycle. Here it's 0.92, which is not really used. And then you have the RFR, the resting full cycle ratio, which is the lowest PD by PA at any point in the entire cardiac cycle. So at any point in the cardiac cycle, which is the difference, and it's again 0.89, and the single lowest value from 5 cycles is taken, and this is with Abbott. That's a RFR. So these are the 5 resting indices that we have. And what is the comparison of the different diastolic indices to IFR? All of them were compared, and this is a trial which is in 2014, and the comparison of diastolic indices. You have the DPR 25 to 75, DPR mid, at the single point in mid diastole, the IFR 50 milliseconds, and IFR 100 milliseconds. That's looking at different parts of diastole. And what do we have? You have absolutely the same between all the resting indices, whether it's accuracy, sensitivity, specificity, positive predictive value, negative predictive value, all are almost exactly identical at the cutoff value of 0.89. And this is again, which shows it's a class effect of the NPHR, which is almost unity with the area under the curve of more than 0.99. So you have specific ones, so DPR in comparison with IFR, which is presented at EuroPCR 2018. And they show that the wave-free period does not provide unique properties. I mean, there is nothing specific about the wave-free period, and in any part of the diastole is the same. It probably does not exist. And the resistance during the wave-free period falls by 150 to 200% with adenosine. So what was initially thought about was the wave-free period. There's nothing specific about the wave-free period. Any part in diastole would be the same. And you don't need the dicrotic notch or ECG gating, which for DPR as compared to the initial ones of IFR. And all versions of DPR provide numerically equivalent values to IFR, and there's physiological bioequivalence between DPR and IFR. So this is with DPR, and then you have the validate RFR, which is again in Europe PCI 2018, which is looking at the resting flow reserve, resting PDA and RFR as compared to IFR. It is again exactly the same. So RFR in comparison to FFR, the RFR demonstrated a high accuracy of 94% with the hybrid approach, and a sensitivity of 93.5 and specificity of 95 for identifying lesions, with FFR less than 0.8, and 80% accuracy with the binary approach. That is what we normally use, a binary approach of 0.89. Less than 0.89, you treat; more than 0.89, you defer. So there's a comparison of IFR with of all the resting indices with IFR, whether it's DPR, DFR, or RFR, or resting PDA, all of them have essentially the same AUC. And this is why it's come in the ESC guidelines as well on functional testing, that IFR is recommended to assess the hemodynamic significance of intermediate grade stenosis. And if it's IFR, it can be all of the other diastolic indices as well. Only FFR is in the ACC guidelines, but the non-hyperemic may be incorporated in the new ones to come. So in conclusion, all diastolic indices are equivalent to IFR. All indices have the same agreement with FFR as a reference standard, with a diagnostic accuracy of 76 to 77%. All these resting indices can be used interchangeably. All cutoff values, clinical recommendations, and guidelines are directly applicable to any of the diastolic indices. So yes, the battle of resting indices, are they all the same? I think probably yes. Thank you for your attention.
Thank you, Dr. Reddy. We move on to the next presentation. And this is multi-lesion may look similar, but all are different subsets. We request the next presenter,
Dr. Hazra, sir.
Dr. Hazra. Dr. Hazra to give FFR in multivessel Pci. Dr. Hazra.
Hello.
Yes, sir.
Okay, so multivessel lesion may look similar, but all are different. And we know from the previous lecture. And before that, pranam to Dr. Hidema, Dr. Chanda, and good morning to everybody. Pyramid of diagnostic accuracy of FFR multivessel PCI, when the Sons did the first catheter, it was by 50%, because 50% was the cutoff for angiography. So by chance of flip of coin, accuracy 50%, then the Grunjig made it to 65% on the angiogram. Then the PDPA made it to 80%. Now, if you have adenosine and a hyperemia, we can make it to 95%, but 100% the gold standard for one particular patient. Now, this is a story of Dolph Bachman, the first patient of Grunjig, and he had repeated interventions, and he's still alive, and 38 plus 40 years. And if you follow his angiogram in the history, up to 23 years, he had a balloon angioplasty. Again, he had angina, and in September 2000, he had another stenosis of the LAD, and this time FFR was 0.83, and the Barney Meyer, who was the main operator of this patient in follow-up because of Grunjig, died, and he ignored FFR, and he did put a bare metal stain, the dark gluten stain, and saga goes on, story goes on, and still alive. So it's not necessary that all patient needs FFR. You can believe your own eyes, you can go ahead. And we do FFR and want to minimize miss by minimizing mistakes using angiographic coronary evolution. That's why we do FFR. And we also miss ambiguous lesions in the angio in many trials that has been proved. You use many vasodilators, but so far from contrast media to your coronary occlusion, papaverine adenosine is the gold standard and most validated by randomized clinical trial. If you really want to do multivessel PCI FFR, you can use just a single bolus dose of long-acting adenosine, which is not validated, but it's a new concept. It is so good that everybody loves it, and all the intervention cardiologists loves it. Even the bodies likes it because it is so effective in reducing the cost of the nations, NHS cost, everything. So Emperor got the new clothes, but if you go to the FAME NEGM table plus ACS 2009, many water has flown in the river of Ganges. You have Cypher Texas era. Now we are living in Apple 13 phone. Now the penetration of FFR is less than 6%, in 2017. It is less than 8% in 2018 because of the cost. The size matters. You know, this FAME2 study, nobody stopped OMT group to have PCI when FFR was 0.8. It's not rocket science to understand that who has got a significant lesion in FFR 0.8. We'll go ahead and you'll go ahead and fix it. It was prematurely stopped, 888, small size, main driver of primary endpoint is urgent repeat revascularizations. And you'll be surprised to know that even having PCI in FFR group, 10% in PCI group had residual angina, had to undergo repeat revascularizations. And it is only clinical. There is no stress test, no CPKB in 2009 to prove your point. And what was the hardest point to prove? MI and death. It was not statistically significant in the FAME2 trial. And what harm you do? You also do harm putting a wire and can produce dissection. Even the surgeons started loving it. FAME2, graffiti, save it. But in surgical trial, FFR or no FFR did not make any difference. Even then, it is class 1A indications. And there are a lot of good information, as I told you, in the previous speaker has made it very simple for me. But there is a lot of ugly truth, and it is pouring now. Now, what are these ugly truths? This complete trial, Ffr AMI trial 2021, ischemia analysis by Greg Stone, EuroPCR meta-analysis 2021, and last month, the Ripcord 2021. But it is reached by DIFA, FAME1, FAME2, these all old trials, and syntax. Syntax is another damn squid in the FFR because syntax trial, nothing to do with the syntax score. It was done with the cipher stent and taxa stent, and FAME2 mainly the old thicker cipher stent. Now we put a lot of ultra thin stents with the bioabsorbable polymer, and we also see Mona Lisa better nowadays with imaging. But in this trial, FAME1, FAME2, whatever the trial you do, if you randomize after having angiogram, you always have a bias because whatever has been seen cannot be unseen in a trial. So there are a lot of bias, and there is no improvement in the angina, and there is a contamination of primary endpoint by urgent revascularization, which is obviously arbitrary and may vary from person to person. It may be facing a lot of bias. So saga continues in 2020. Sweetheart says FFR is better. So there is topsy-turvy course of this journey. Now the basic question whether it can be gatekeeper in multiversal PCI. You may agree with me, you may not agree with me, but in certain cases it should be selective. It should not be routine, like thromboaspiration trial has failed us to show benefit and harm. Now there are a lot of trial which was done without FFR in the multiversal PCI medical therapy. Now we have entered here FAME2 orbital ischemia. The penetration of FFR is very low. The FFR negative PCI, there was no harm of death or excessive death if you do PCI in FFR negative. It was only 1/3. And in this trial, the penetration, as I mentioned, is very, very low, and people have continued. Now in the field of culprit versus non-culprit multiversal PCI, we know these are the trials for 2010, 2021. And what we have seen that 0.75 to 0.8 was the cutoff. Now we take 0.75. But you'll be surprised to know that complete trial completely forgets FFR, only penetration is 1%, and 99% patient had angiographic conclusions that complete revascularization is better, and it should be done at the stage or index procedure. In Ffr MI, Ffr guided PCI do not change death MI revascularization. Again, it is a visual functional mismatch. So go by angiogram. So there are a lot of comforting myths, I would say, but there is a lot of unpleasant truth. The truth has come from Ripcord 2 trial, Ffr MI trial. So I'm repetitive here. So Ripcord 2 has concluded the routine system in FFR does not make any difference to the quality of life at 1 year. So what may happen if one treats FFR negative angiographic borderline lesions in PCI CVG, ischemia triad-like patients? The sealing of vulnerable plaque may prevent a non-fatal MI in the future, may prevent ischemic cardiomyopathy. And nowadays, things are so easy, the good DAPT, so there is no concern of stent thrombosis. What you actually you lose more contrast, more stent, and more radiation and more cost. And FFR, IFR should not be done or does not make any sense in a higher total of coronary lesion, 99% lesions, 50% left main lesions. In young patients, proximal LED more than 75% lesions in young symptomatic ISR, slow flow lesions, and culprit ACS and TB2 flow. Doing FFR in young means doing more stent in 15%. It is okay for elderly. So this is the recent trial, recent data from 2020 in Euro PCR. Even if you pay more, like FFR means more money do not improve quality of life. If you talk about US and Europe, US has got more money than Europe. Even then, the quality of life is not different from the European counterpart. So paying more money, investing in FFR does not improve quality of life, even in the rich country, and the penetration is only 8%. So we have moved further. We have gone into the Syntax 2 trial. Again, Syntax or Syntax 1 or Syntax 2 trial, nothing to do with the Syntax score because the randomization was done between taxes and surgery. So FFR was taken here. And again, the same truth in the Syntax 2 trial that many lesions, if you fix, like left lesion, if you fix, there will be some angina relief, repeated vascular history will come down, may prevent future event. There's no role for FFR in multivessel PCI when one or two arteries have CTOs. They have a problem with left pen with the tandem lesion downstream. Now, this is the recent analysis by Greg Stone in the ischemia trial. If you just go by angiographic analysis, it is much more effective in reducing the death, myocardial infarction by putting a stent, which is very, very surprising. And if you go by FFR, there is no difference between your medical therapy and interventions. There's again analysis in Euro PCR, and this is from this recent PCR concluded PCR trial. There is a 21% death reductions with revascularization. Many of these trials are done without FFR. Many trials are done with FFR. So FFR or no FFR, if you analyze individually, there is no difference. So you do a good job by best stent, best imaging, best pharmacotherapy, and selective FFR. Maybe we are barking on the wrong tree by hemodynamically significant lesions. You have to take help of all the informations like good visualizations of the coronary, the flat panel, good imaging, OCT, need spectroscopy, vulnerable plaque. Ultimately, you have to put them or bring them to operating suites, the table of wisdom, and the cardiac cath lab decision is yours. Each patient is different. So good judgment and good skill can take your patient on the other side. Thank you very much for your kind attention.
Well, thank you, Dr. Hajra. I hope you're going to stay with us till the end when we have the group discussion. We move on to the keynote lecture by Dr. V.K. Key. And this would be on culprit or complete revascularization, the physiology way. Over to you, Dr. Koo.
Okay, so thank you, Mr. Chairman.
Let me have the opportunity to introduce Dr. Boo. Dr. Boo is the professor and director catheterization lab at Seoul National University Hospital. He has the expertise and a lot of research paper publication on the bifurcation lesion and coronary physiology and its imaging. He is also the associate editor of JACC Cardiovascular Intervention and the president of Korean Bifurcation Club. He is also the co-director of TCT AP. So over to Dr. Koo for his presentation, please.
Okay, so thanks for the kind introduction, and it's my great honor and pleasure to join in the IPCI 2021, and it's my great pleasure to hear the very relevant and excellent presentation for the imaging and physiology in the session. So today I would like to talk about the complete or culprit vessel only revascularization. So as this is a kind of keynote lecture, so there should be some overlap between mine and the presentation of previous speakers, so please understand that. So we know that this issue is clinically very relevant. So in previous literature, in the setting of STEMI, 30 to 50% of patients had additional lesion in non-culprit vessel. And in the setting of non-STEMI, it's higher, 40 to 60%. So we have to start to understand that this issue, whether we perform a complete revascularization or infarct-related artery only revascularization, is a clinically relevant issue. So why this can be an issue rather than stable multivascular coronary artery disease? Because we know that in the setting of acute MI, clinical condition is generally unstable and vulnerable. as well as the plaque vulnerability. And plaque is more associated with rupture and thrombus. And in addition to the clinical condition and plaque condition, we all know that the inculprit lesion and culprit vessel myocardial territory, myocardial damage occur and microvascular dysfunction. What makes things more complicated is that not only the culprit vessel territory, but also non-culprit lesions and territories can have this kind of ugly and unique features of acute myocardial infarction. So that's why the fixing even for non-culprit lesion, non-culprit vessel can increase the risk of the PCI or procedure. So let's review the old guideline. This is 2015 ESC guideline. As you can see here, guideline recommends that the primary PCI should be limited to the culprit vessel with the 2A level of evidence B indications. And for the non-culprit artery PCI, it is class 3. So you shouldn't do non-culprit, non-infra artery PCI at the time of primary PCI. So this was a quite old guideline. However, we know that as elegantly shown by the previous speaker, there have been some accumulating data to propose that having PCI during the index procedure for non-culprit vessel performing angio-guided complete revascularization can improve the outcome. So PRAMI trial, from England, so whether small cases, however, it is shocking to see the hazard ratio 0.35 with the preventive PCI or angio-guided complete revascularization versus infarct-related artery only PCI. And also another study from England, COPRI trial, with the primary endpoint of all-cause death, MI, heart failure, ischemia revascularization significantly reduced with the complete revascularization. And for this, complete revascularization was performed during the index or the in-hospital period. Anyway, hazard ratio was 0.45. So we are accumulating more evidences that suggest that the angio-guided complete revascularization may or can provide the complete benefit, clinical benefit over the IRA only PCI recommended by the guideline. So in 2 years, the previous guideline made quite dramatic changes. So previously it was 3B recommendation for non-infarct related artery PCI at the time of primary PCI, and now non-infarct related artery PCI should be considered in STEMI setting and recommended as a 2A level of evidence A indication, so that there was a dramatic change in recent years for the guidelines related to the non-infarct related artery PCI. And now we have the largest trial in this issue, so that angio-guided complete revascularization versus infarct-related artery PCI, it includes more than 4,000 patients and randomized. So it is interesting to see that this study has eligibility criteria, so 70% or more, or in case of between 50 to 70%, they recommended to use FFR to define the functional significance and to give a green light for the complete revascularization. However, in this study, FFR use was only 0.7%. That means that this complete trial included angiographically very significant patients, and mean percent diameter stenosis of this type, the trial was 79, almost 80%. So this number is very important in understanding trial. Anyway, for the first co-primary outcomes, cardiovascular death or myocardial infarction, and second co-primary outcome, cardiovascular death MI or ischemia-driven revascularization, there was a significant benefit with the complete revascularization in comparison with the culprit lesion only PCI. So in comparison between angio-guided versus IRA PCI, I think the mission has been now completed with this complete trial. So I would say that with several recent trials, non-infarct related artery PCI in multivessel AMI patients can improve patient outcome. So then let's think about the FFR guided approach. So this already elegantly demonstrated by the previous speaker. FFR requires maximal hyperemia, and it depends on the myocardial mass. So assuming that this in this stenosis, FFR was around 0.6, but at the time of myocardial infarction, large territory infarction, resistance decreased, flow decreased, pressure gradient decreased, so that with the same stenosis in the acute setting, FFR gets higher. And during the recovery period, as myocardial function recovered, FFR gets lower. So this is the reason why FFR in the culprit vessel, sometimes non-culprit vessel, can be higher than in the non-infarct situation. So what about non-hypertonic pressure guided approach? So it's more complicated. So there is a two-way chances of both increase and decrease. So as myocardial damage increase, resting flow decrease, so it will increase the non-hypertonic pressure ratio. But at the setting of acute myocardial infarction, patient anxiety and clinical instability, increased heart rate, will increase the resting flow, so which will increase the pressure gradient. So it's not a true resting status, so non-hypertonic pressure can get lower. So that this is a quite tricky situation, but we have to understand there are positive ways and negative ways of FFR and non-hypertonic pressure ratio. And during recovery, it's all the same. As there's a partial recovery, myocardial resistance decrease, so that the non-hypertonic pressure can decrease, but as clinical instability decreases, non-hypertonic pressure ratio can increase, so that during the acute setting and during the recovery period of the culprit and non-culprit vessels in case of using non-hypertonic pressure ratio, you have to understand all these complex interaction before you decide whether you go PCI or the medical treatment. And this was also shown by the previous speaker. So for the non-culprit lesion, this study done by the Bernard de Bruyn's group. So in acute coronary syndrome patients, around 75% STEMI patients, they measure the FFR and in some cases IMR in non-culprit vessel, and they repeated the same measurement at the time of mean one month interval. So as you can see here, there's some ups and downs. So we have to admit that the FFR measured at the time of index procedure and 1 month follow-up, there can be changes. But by average, there was no significant differences, and only 2% has a crossing point between 0.8 to 0.75. So I would say in general, it's stable, but I cannot say it's stable all the time. So what is interesting is that in very small number, they measured the microvascular resistance, and they found that in 14 cases, there was no significant differences in non-culprit vessels in IMR between acute phase and during the follow-up period. So for solving this issue, several years ago, we did an animal study. So in this study, we make an artificial myocardial infarction in this pig model, in the model where we have artificial stenosis in both LAD and circumflex, so that we define in this study as LAD culprit vessel and circumflex non-culprit vessel, and making a myocardial infarction in the LAD with the microsphere injection. So here is a pathologic example. In the circumflex territory, there should be no microvascular injury. But in the LAD, while shooting the repetitive microsphere injection, you see that lots of necrosis and acute myocardial infarction. And this was represented by index of microcirculatory resistance, as myocardial infarction increases the resistance. So in the normal case, IMR was 17, but in the artificial MI case with the microsphere injection, IMR increased 31 and CFR decreased from 3.4 to 1.5. So we tried to assess the changes in culprit vessel in the setting of MI. So we repetitively making more and more microsphere injection, causing more and more myocardial damages. So according to the increase in myocardial damage, IMR increase. It's natural. And for that, FFR also increased. So we know this very well in the setting of MI. This is the reason why culprit vessel FFR underestimates the lesion severity. So then what about the non-culprit vessel? Fortunately, there was no changes in IMR, no change in FFR throughout the whole repetitive artificial myocardial infarction. So this illustrates, even from this small animal study, that the measuring FFR in non-culprit vessel may be reliable, but there should be a lot of limitation in that. And we also know from the FAME sub-study where they divided the multivessel cases into the stable coronary syndrome versus acute coronary syndrome, they found that even though ACS patients have a higher risk than the stable coronary patients, but the FFR guided strategy was significantly reduce the risk of the MACE in comparison with the angio guided strategy. Another very interesting study was that in the famous non-STEMI study, which was done by the England colleagues, Keith Oldroyd, and they show that when the operators blindly measure the FFR and ask them to set their treatment strategy and repeated the question again after the non-disclosure of FFR, they found that the FFR disclosure can cause a significant changes in treatment plan, 1 out of 5. So that this, even in the setting of non-STEMI multivessel, use of FFR can influence the treatment strategy selected by the operators. So let's go back to the initial question. So the complete revascularization versus IRA only in the setting of STEMI multivessel disease. We know there has been 2 quite large studies, medium-sized, Dynamic 3 pre-multi study and Compare Acute study, which compare that the FFR-guided complete revascularization versus IRA only PCI. And both studies show the benefit of the FFR-guided complete revascularization in terms of hazard ratio of 0.56 from Dynamic 3 pre-multi study and hazard ratio of 0.35 in the Compare Acute trial. So I would say that the physiologic index guided non-infarct related artery PCI can also improve the outcomes in multivessel AMI patient. So the next question is naturally, what about the comparison between physiology guided or FFR guided versus angio guided? So in this meta-analysis published in 2020, when they compare the outcomes or the benefit of complete revascularization between the FFR guided and angiogram guided, they found no interaction. So that in this meta-analysis suggests that the FFR guided can be beneficial and also angio guided can be beneficial. But this is just a meta-analysis. And recently we had a results of this randomized study, which were designed to answer this question, FFR guided versus angio guided in the setting of the multivessel myocardial infarction patients randomized trial. So this study enrolled 1,170 patients. The primary hypothesis was that the null hypothesis was no difference, but it was designed to show the benefit of FFR guided strategy as the comparison between 9.5% estimated event rate of FFR guided strategy versus 15% angio guided strategy. But as you know well, the results was in contrast to the primary hypothesis, so that there was no difference in the primary outcomes. And when you see the numbers, there were several red flags suggesting that the FFR guided can be harmful, like in a future trial, so that the composite outcome 5.5% versus 4.2%, non-fatal myocardial infarction 3.1% versus 1.7%, and unplanned revascularization 2.6% in FFR guided group and 1.9% in angio guided group. So that the authors failed to prove the benefit of FFR guided strategy in the setting of STEMI multivessel disease. And what is more is that numerically, more events were observed in FFR guided group. So in comparison with angio guided PCI, we have only one big randomized trial. And I would say that FFR guided strategy failed to show the benefit in comparison with the angio guided strategy. However, I am not quite sure whether I can say that there should be no role for FFR like in the editorial for the FLOW MI trial. And let's see more about the numbers, so that the hazard ratio 1.32, statistically insignificant, but numerically, angio-guided strategy is better. But if you see the non-fatal myocardial infarction, 3.1% versus 1.7%, it's mainly due to the peri-procedural myocardial infarction, 7 versus 2 in FFR guided versus angio guided respectively. You know that how difficult it is to define the peri-procedural MI in the setting of STEMI. And also it is difficult to understand why peri-procedural MI was higher in FFR guide group despite less procedure. And one good thing is that even in the setting of STEMI multivessel disease, there was no serious adverse event with the FFR measurement, and success rate was 96%. And procedure time was similar between FFR guided versus angio guided group. And what is more important thing is that the stent number was significantly reduced around 30%, like in all previous trial, by using the FFR guided group. So even there was no difference in outcome, but it is important to understand the procedure time is quite similar and no adverse event related to FFR measurement, and stent can be reduced by 1/3 when FFR guided strategy was performed. So I would say that the physiologic index guided strategy is safe and can reduce unnecessary PCI. So in conclusion, ladies and gentlemen, how I understand and interpret physiologically in recent trials which investigated the benefit of complete versus culprit vessel only revascularization, I would say that the non-infarct related artery PCI is generally recommended and can be performed during the index procedure or as a second stage procedure according to the patient clinical condition. And angio-guided PCI may be good enough for severe stenosis as shown in complete trial, for example, more than 80% stenosis. And if you decided to perform a physiology-guided PCI, generally it is recommended for intermediate stenosis, and that procedure will reduce unnecessary PCI without increasing the procedure time and the risk of the procedures. Thank you very much for your kind attention.
So we've had a very extensive discussion for last hour or so on FFR physiology, mostly in acute setting and probably related to non-culprit lesions. So anybody has any questions from the panel?
Can I ask you a question, Dr. Poot? This is Dr. Hemant Madan here. I wanted to know if if the presence of cardiogenic shock or hemodynamic compromise would change the strategy for an approach of physiology-guided non-culprit vessel PCI.
So I think that clinically a very important question, but in case of cardiogenic shock, I think it's beyond the area of physiologic assessment. So we should be physiologic. The operator should be physiologic, but the applying physiologic index at the time of cardiogenic shock has definitely increased the risk of procedures, and also it's very difficult to interpret. So you can still use it, but I would say just follow your clinical experience for the decision making.
Well, I would feel the reliability, despite doing the procedure safely under this setting where patient is in cardiogenic shock, the reliability will not be the best. So I would probably, anyway, most of us like to do a more complete revascularization for a setting of cardiogenic shock. So I would probably want to do it and do a more complete revascularization and not worry about doing FFR on this setting.
Yeah, but Dr. Hiramat, interesting, we have this new study which we have on cardiogenic shock on completeness versus doing complete versus incomplete revascularization. And the data, I'm sure you're aware of that. And according to this new information, I think, it is appropriate to do a culprit only revascularization in cardiogenic shock.
That's right.
Yeah. So anyway, I think, we have to really, it all says that we have to
Yeah, the
make our
jury, I think the
decisions
jury is
individual.
still,
Yeah,
the jury is still out on this, and it's very difficult to go either way. Hemodynamic compromise in acute MI really changes the whole, and it also changes physiology assessment, so to say.
Right.
What
So
I'm
not
trying to
only
say
the
is,
coronary physiology
whenever there is a
influences
cardiogenic shock, we are more towards doing more complete revascularization. Only in one study lately, it has got a little bit of a challenge. So I would probably feel that doing more complete revascularization under these settings is much simpler, much safer than trying to do a physiology assessment.
Yeah, so as somebody already said that we have to still wait and see, and one has to make individual assessments and make a choice about revascularization, because of course we now realize that renal failure is one of the issues which happens in these patients if you do too much of intervention at that time, because you don't know what exactly is the renal status, how much so I think we'll have to wait and see for actually, if you have to look at the data, we'll still have to wait for that.
Probably all our trials look at large populations. I think we need to look at more at our individual patients.
Dr. Reddy?
We can't hear you.
That's Ajay, I think. Ajay, you'll have to
Ajay.
mute and unmute yourself again.
Yeah, am I audible now, sir?
Yeah, better.
I feel that all the trials actually look at large populations, and although there is a lot of stress on evidence, we shouldn't sacrifice common sense. And somebody who has got an RCA infarction and comes with shock with a proximal LAD 90%, it makes sense to revascularize the LAD. And somebody who's in shock, who's come say 48 hours later and has got a 70% lesion, and you're just trying to get away with what minimum you can. I think the situations are different. To lump them all together is probably not the right thing. I think
so Ajay, you are saying the same thing. Ajay, you are saying the same thing, that we have to individualize. That's what it is actually.
Absolutely.
So right now, we have to come to this
we
point.
are not talking of 90% LED lesion. I mean,
that's why I'm saying, so we have to individualize.
That is my
based
problem.
on the severity of the lesion.
What we are talking is lesions which are sort of yes or no. Borderline lesions, and to do during acute setting or no. That was the question which we are discussing. We are not talking of 90% lesion.
Unfortunately, the trials lump them all together, and that is the problem with interpreting the data. They just look at STEMI associated vessel. They're not going to look at whether it is 70% or 80% or 90%. They just look at the presence or absence of disease. And that is my problem with the trials. We need to make the decision based on the individual patient and not on the data that is skewed in one direction.
Yeah, Ajay, I think everybody is saying the same thing right now.
Yes, sir.
So
I think that's
we can
perfect.
move on. Yeah.
Thanks very much. I think Dr. Hiramanth, if you can just summarize and we can move to the next session.
Yeah, I think you had very exciting discussion around FFR and the other physiology assessment. Then initially we had this discussion whether to do a complete job or leave the non-culprit vessel. And then we moved on to Dr. Ajay's presentation and then Dr. Reddy's discussion on FFR and the other physiology assessment. Actually there we need to make also an assessment whether post-stenting we should do an FFR assessment. And then we had Dr. Hajra's and Dr. Pool's presentation. So I think we had a very complete discussion on physiology assessment for the under acute setting. Thank you indeed for attention and attendance.
Thank you, Dr. Hiramanth, and all the chairperson and panelists. Thanks to all the speakers for very elegantly describing the role of physiology in complex lesion. Let's move forward to the next interesting session about the complication bailout by use of imaging. And let me invite the chairperson, Dr. Chris Raphael, Dr. Sanget Velu, Dr. Gambhir, Dr. Arun Chopra, and Dr. V. Sujata for the same. And may I also request expert panelists, Dr. Anil Potera, Dr. Pani Grahi, Dr. V.C. Chauhan, Dr. Ranjit Nath, and Dr. P. Balaji to chair and panel the session. May I request Dr. Sanketwelu to go ahead for the proceeding, please?
Thank you, Dr. Rajesh. I think now we'll invite Dr. Praveen Chandra to start his talk on imaging on OCT in thrombus situation. Please go ahead, Dr. Praveen.
Okay, so thank you, Dr. Singhatwale, and I must thank Rajesh and his colleagues for organizing this wonderful program. And the first session was really quite educative. So now I moved to one or two cases on thrombus and imaging. And this is interesting patient, young patient, 27-year-old, and you can see that he came with a non-QMI, and his coagulation profile was normal, and there was a RCA which was normal. The left anterior descending LAD was having huge amount of clots, as you can see here. Although the vessel was flowing, so at this stage we wanted to make a decision: should we do now a primary angioplasty, or we do a thrombolysis, intracoronary, or what kind of plan we should take. So we decided that it's a young patient, looks more like just pure thrombus. So we decided to thrombolize with TPA, and thrombolysis was done. And post thrombolysis, the flow became much better, as you can see. And the thrombus was largely, at least more than 50% lesser. And there was some small portion distally also. So at this stage, then again, the idea was what to do now, whether to do angioplasty now or just leave him on low molecular weight heparin or NOACs. So this was within 24 hours. So we said, okay, let us re-thrombolize him because he's a young patient. There is no big risk of thrombolysis. And so same dose was repeated. And then after this, the patient was discharged on low molecular weight heparin for 7 days, and then NOACs and with triple therapy. And 45 days later, we did another angiogram to see where we are right now, whether we still need to put a stent or not. So here you see that the artery is flowing well. That is, most of the thrombus is gone, but there is some haziness in the middle of the artery. So at this stage, this is the comparative. You can see that there is the first angiogram, there is the second angiogram, and this is the third angiogram. So this is the comparative of these angiograms. And so now what to do? So the question was whether to continue medical therapy or to do, now again, some imaging at this stage. So we decided that let us do some imaging and find out what exactly is happening inside the artery. So OCT was done. And you can see that in this OCT examination that the distal vessel is okay, but now you start seeing some recanalized artery like a honeycombing, which is very typical. I think Singhatwale also published one paper on honeycombing of these arteries on recanalized vessels. And so this was, and of course there was some suspicion of a plaque rupture in the middle of this artery. So now again, the question was whether to do a medical therapy or to do an angioplasty and stent. So we said, okay, I think it is time now, maybe that we should do a stent here because whatever has to go and whatever remains has to be kind of stented. So we decided that we should stent him. And this is the detailed evaluation of this OCT. As you can see, from the distal landing zone to the proximal landing zone, there was some ectasia in the proximal area. However, in the middle, you can see that suspicion of a plaque rupture and then honeycombing of the vessel. So we decided that yes, we should stent it, but the patient was so fine. I mean, he said that he still wants to wait. And although the plan was to put a 3x38 stent, 3.25x38 stent, and then expand it proximally going up to 4.5 or so. So that was the plan. This is the lesion which was left, and the patient is still doing fine, and he has not come back for a stent implantation, although that's what we recommended. Another patient, a quick one, and this is a patient again came with the ACS, and you can see that there was a suspicion of a plaque rupture and a thrombus over here in the proximal part of the LAD. In the RA portal, it is not so much visible, but in the LA portal, it is quite clear. So imaging was done to really clarify how much of what is happening inside the vessel. So you can see this, plaque rupture along with thrombus. And so this, and of course, in the proximal part, there was a lesion here as well. So we treated this vessel with the stent implantation at the same time. And this is the stenting done in the proximal part and followed by a OCT evaluation of this same vessel. So basically it was easy after imaging as to what should be the strategy, that this patient did need a stent implantation right away. And we went ahead and did the stenting of this vessel. So as OCT did, help in these two cases to identify and make our plans much more correctly. So thrombus, to conclude, thrombus is best characterized on OCT. Decision making whether to treat or not to treat is of course a multifactorial thing, but imaging does play a good role in deciding that. We can differentiate between the white and the red thrombus. Stent selection becomes easier, and of course, post-stent optimization is an additional advantage when we do imaging with OCT in these patients. So with this, I think I'll stop sharing and then we can carry on. Thank you very much.
Dr. Praveen. It's a nice case. I think thrombus, I think it's very useful to detect by OCT. But again, it's very important to image not immediately with so much of thrombus load. I think you run the right thing, not to image immediately. You would not have seen anything. But generally, it would be good to image about a week or 10 days because you could see the pathology very well. Particularly if there is any erosion on a young patient like this. It could be plaque erosion or a spontaneous coronary dissection, which we could have seen yearly. But then late imaging could clearly show the organized recanalized thrombus. And maybe even FFR can help in such situations to decide whether we need to revascularize or not. I would request Chris to give his comment. Chris, good to see you, Chris. It's very nice to have you here.
Oh, good to see you, all of you as well, albeit from a long distance. Very nice cases, I think, particularly the first case. I think the lysis was a good thought, and really learning from all of you the way you do it in India with intracoronary lysis. We've started doing a little bit of intracoronary lysis, and I know that works very well. So I think that would have been another option. And then you keep them on some anticoagulation for a number of weeks. I agree, sometimes early imaging is good to see what the acute pathology is, because after a few 4, 5, or 6 weeks, with healing, you may not understand whether it was a plaque erosion or a rupture. And I think in the first patient, we're still not sure. All we know is there was a big thrombus burden, which the body has recanalized. And I think, probably the patient made the right decision to say no stent. And I agree with you, if you're unsure, an FFR might be quite helpful in that regard. And I must say, I have tended also, even in this situation, if there's good flow and the patient is asymptomatic, to medical therapy works very well, because we know, stents as well come with its own problems. So the first case in particular was an excellent demonstration of good medical therapy followed by imaging and guiding management.
If there are any comments from other chairpersons or panelists?
Dr. Chandra, excellent cases. Just wanted to ask you, did you use intracoronary lysis?
Yes.
Okay, both times.
Both times. The first time, definitely, we went ahead at the same time. And the second time also, when we did the angiogram, then we took that decision. So both the times it was intracoronary.
So is there a possibility it was a spontaneous coronary artery dissection, which could have led to the whole...
As we discussed, it's difficult to decide at this point of 45 days. I think coronary dissection, one has to clearly demonstrate where you have an intimal disruption. So intimomedial discontinuity should be there. And for that to be, it is not clearly seen because it was 45 days old, but maybe earlier imaging with thrombus resolution could have identified whether it was a spontaneous coronary artery dissection. So I think thank you for the nice case, and let's move on. I think Dr. Jabir.
I have only one question, sir. Yeah. I have only one question. See, vulnerable plaque, we don't have definite data for stenting, but when a vulnerable plaque has caused an ACS, should we wait? That is what, because in a thrombus containing lesion, we can't identify a plaque erosion or rupture.
Okay.
We can wait, but should we leave him on medical management? It is one question.
Let me answer that. I think we discussed that. So when you have a late presentation with a recanalized thrombus, that recanalized thrombus itself can cause hemodynamically significant lesion stenosis, needing a stent. So that is why we were discussing it. They could stent, you can leave at medical management. If you are in doubt, FFR would really tell you whether you need to stent or not. But I think stenting definitely is an option, because this recanalized thrombus can also cause reduced flow.
And what about the oral anticoagulation? Should we continue on dual antiplatelet and oral anticoagulation? What do the data say, sir?
Not needed. Once he has put a stent, you only have to take
before that, for the first case, I would like to know what was the antiplatelet anticoagulation strategy.
Dr. Praveen, after your thrombolysis, how did you manage this patient?
Yeah, so once the patient was discharged, he was put on triple therapy. As you already asked this question, 2 antiplatelets and anticoagulation. Initially, he was put on low molecular weight heparin, then we switched over to oral anticoagulation along with dual antiplatelets, because the risk of bleeding was very low. He was a young patient, so we were quite happy to continue triple therapy. Yeah.
I have one question. How should you deliver the thrombolytic agent intracoronary? You just give the injection, or would you like to give it through a perforated balloon over some period of time?
Okay. So basically, you can give it either way. There used to be a balloon where there was actually a mesh through which the drug could be given initially about 15 years back. But now we typically give it through because it is a straight flowing vessel, so there is no problem. The thrombolytic agent will actually flow in. But in those patients where it is a complete occlusion, you still want to give it. You can give it through a perforated balloon also, or through a catheter. But the problem is, if you do all that, there is a chance that the thrombus will actually embolize this. Yeah. Okay.
Good. I think. Yeah. Thank you, Dr. Praveen. Dr. Jabir, can you please proceed? Thank you, Dr. Jabir. Please proceed.
Okay. I think I'm audible and the slides are visible, isn't it?
Yes, very well.
So, good morning to the chairpersons as well as the panelists. So I'll be showing 2 cases where the OCT has helped me. This 63-year-old man had an acute coronary syndrome 10 years ago, and an angioplasty was done to RCA with 2 stents, and he presented after 10 years with a progressive Ffr angina. And his angiography of the left coronary system, it was normal, and the right coronary system, you can see the diffuse ISR. Maybe the lesion is a little progressing beyond the stents also. So we thought of doing an imaging. And you can see in the imaging of the OCT, there is extensive neoatherosclerosis, significant narrowing, significant atherosclerotic burden, which is due to the neoatherosclerosis. I say this is neoatherosclerosis because you can see microchannels, you can see the calcification, and you can see the fibrofatty lesion. So this is a neoatherosclerosis which has to be dealt like the athyroma, native athyroma. So this was ballooned, lasted very well with high pressure balloon dilatation, followed by a 3x48 drug-eluting stent, followed by post dilatation with a 3.5 millimeter balloon. And after that, we did the angiography. We could not find, there is some haziness that is distal to the stent. We thought that landing zone was safe with the OCT. There was a triple layer at that landing zone. That's why we didn't take up to the distal part where the vessel seems to be normal. But here, after the stenting, there seems to be a hazy lesion just distal to the stent. So what is it? Is it only a negative? Is it a dissection? Is it a thrombus? Again, we thought an OCT only can give an answer. We did another OCT. And this shot clearly, it's basically an extensive dissection that is distal to the stent. And it's doesn't seem to be a dissection which can be left alone. When we look at the dissections, all dissections seen in OCT may not be dealt with, may not be stented, but this is a dissection which, as per the recommendations, are extensive. It is more than 60-degree arc and a longitudinal extension of more than 2 millimeter, and it is distal to the stent. This really increases the risk for adverse event, and this has to be stented. Another stent, 2.75 into 23 drug-eluting stent, overlap post-dilatation, and finally an excellent result. The second case, this the post-stenting OCT, the dissection is well covered, and it's a well-deployed stent without malapposition or tissue prolapse, or no lumen problems or no edge problems. The case 2, it's a 74-year-old female diabetic who presented with the ACS, and there was a long segment LAD disease with calcification. Left main appears relatively normal, so we thought, considering age, we go ahead with an angioplasty. We initially went through the radial route and put an EBU catheter. It was very difficult to hook with the radial through the radial with the EBU, so changed over to femoral and used a gel catheter. But it was extremely difficult after pre-dilatation to track a stent. Despite a balloon anchoring, the stent was not going in. So we did the PCI to the LAD with a guide extension catheter, and then completed the angioplasty with a decent result. There was a doubt of a haziness in the left main. We looked in various views, and this was towards the late evening. And we thought there is nothing, it seems to be fine. Angiographically, patient is stable, no pain, electrocardiogram normal. So we thought, okay, fine, we are done. So we sent the patient back to the CCU. And the next day morning, this patient complained of chest pain with significant STD pressure. So patient was taken again into the cath lab. We did the angiography, the stent is patent. We thought, could it be a stent thrombosis? But the stent appears patent. There is a haziness in the left main. So only an imaging can answer what it is. So the imaging showed the OCT revealed an extensive dissection in the left main, and luckily the patient gave us time overnight. She didn't crash. It's I think it's the luck of the operator and luck of the patient. And this is what you can see, the extensive dissection. It is all this dissection, though proximal, it's a left main. This has to be dealt with. Another 3.5 into 28 millimeter test flared with a stained stent balloon and post-dilated with a 4 millimeter balloon, and final result. And the patient became pain-free. She became all right. So there are situations where we can have ambiguous coronary angiography finding de novo or following a device placement. And in these two cases, we desperately wanted to know what it is. And coronary angiography could not give us a definite diagnosis. The OCT really helped and changed the management. And the OCT was one thing which really saved the day. Thank you so much for your patience.
Dr. Chris, please go ahead.
Sorry, I was my muting was off. The second case, I think, in particular, was a very instructive case. That I think the take-home message is that if there's any ambiguity about the left main, imaging really is mandatory and certainly saved the day here. And I think you're lucky. The operator and the patient were both very lucky here. But that's life. The first case, I wonder what the mechanism of the aggressive restenosis was. At least to my eye, it looked like the deployed stent through a lot of its mid-segment may have been a little bit smaller. Did you measure what the stent diameter was of that first stent to see if it was maybe slightly underexpanded?
Yeah, the first stent was slightly underexpanded or undersized. It could be. It was
undersized,
it was a 2.75 millimeter stent. Then we changed over to 3 millimeter and post dilated with a 3.5 millimeter. In fact, we selected the landing zone based on the OCT finding, but even then it ended up in a dissection. Probably there might have been some amount of atherosclerotic burden or plaque burden in the area where the stent.
You're right. There was a little bit of plaque there, but that's difficult. You can never find a normal segment sometimes. But I think the key is under expansion or a smaller size stent is probably the biggest marker of stent failure. And you can see it went from a 275 to a 3.5 NC, so that was probably the right size to begin with. Yeah, good cases again.
Thank you, Dr. Jabir. I think we'll move on for the sake of time. So the next topic would be dissections and thrombus spelled out by imaging. Dr. Deepak Davidson, please.
Well, good morning to all of you. Can you see my screen?
Yes, very well, Deepak. Please go ahead.
Yes. Good morning to all of you. First of all, it's my privilege to be here with you all. Thanking Dr. Rajesh and team IPCI for having given me the opportunity. Over the next 7 minutes, I shall share with you 3 short cases wherein OCT was immensely helpful for us to make decisions. Well, this is the first case. An elderly lady who presented with an acute coronary syndrome was taken up for an angiographic evaluation, had a mid-LED critical stenosis. The lesion was extending right from the ostium of the LED way down into the LED. We dilated, we stented. That's the stent being positioned. You could see that the stent is positioned right at the ostium of the left anterior descending artery. We also had a wire inside the circumflex artery, and then that's the stent being implanted. Now we deployed the stent at 16 atmospheres, and I could see that the flow in the left anterior descending artery is quite good. The STIMI3 flow in the LED, the diagonal as well as the circumflex artery, and we did post dilatation. And following post dilatation, you could see here in the second frame, you could see in the second image that there is a haziness at the left main bifurcation. On the roof of the left main, there is a hazy lesion over there. So that happened following post-dilatation. We're not very sure whether this was related to the guide catheter getting deep sucked into the vessel that produced the dissection over there. So we're not sure what exactly was the reason for that haziness over there with contrast stain in the roof of the left main. So we were a bit worried to go ahead with an OCT run because we're not sure whether it was a dissection. The hydraulic pressure injection might further propagate dissection. So we decided that we'll have a look at the haziness with an IVUS run. So with the help of IVUS, we were not able to make out anything. So we decided that we should go ahead with an OCT run. So this frame shows you that the positioning of the stent was exactly right at the ostium of the left anterior descending artery as seen in the longitudinal image. And as we rotated the image, you could see here that there is some amount of intramural hematoma over here. This is actually the stented segment. And this happens exactly at this particular area. You're seeing an intramural hematoma. As we rotated the frame, we made out that this intramural hematoma was actually extending into the left main, which can be better appreciated in this particular B mode. You could see here that this is the stented segment. You could see here at 4 o'clock position that there is a small perforation into the intramural space. You could see here that there is an intramural hematoma, and this hematoma is actually extending way back into the left main. This is the ostium of the LED. Now we are coming to the left main, and now as you look at the left main, you could see here that this is the intramural hematoma that's actually extending way back into the left main, and the origin point was inside the stented segment. I shall show that image once again. You could see here that at 4 o'clock position, there is an entry point over there. That's the entry point there. And you could see as we are slowly coming back into the left main, there is an intramural hematoma. It's actually seeping back into the left main from inside the stented segment way back into the left main. That's ostium of the circumflex, ostium of the LED. And now again, you could see that as we come more into the left main, you are seeing the intramural hematoma over there. So what is the reason for this particular hematoma, intramural hematoma? You could see here that in the first frame, as we were post-dilating, the balloon had ruptured. You could see that in the first image, the balloon had ruptured, and whatever perforation had happened, it has actually gone into the it is perforated into the inside the stental segment into the vessel wall, which has actually seeped back into the left main. So we're not sure whether we should go ahead with a stent implantation into the left main, because we identified the reason that this was primarily inside the stented segment. The entry point was inside the stented segment. We waited in the cath lab for almost 20 minutes, and that whatever staining was there, it disappeared, and we called it a day. We didn't go ahead with a repeat stent implantation. So this is how the OCT helped me out in this particular case, wherein I was not really able to pick out what exactly was the problem in that particular situation. Now, the second case is a 76-year-old gentleman, 45. He's been a diabetic for 45 years duration, post-renal transplant, almost 11 years ago, on steroids, cyclosporine, lot of proximal myopathy, had rest angina, and this was the lesion. Our plan was to go ahead with stent implantation of the LED D1. Diagonal was hardly 1.5 millimeter vessel, but then he had severe left ventricular hypertrophy, and that diagonal, it supplied a huge territory. So somehow we wanted to save that diagonal also, even though it was an 1.5 millimeter vessel, and there was a significant amount of calcification over there. So we decided on image guided angioplasty of this particular vessel. We went ahead with rotablation 1.5 millimeter burr, and then did a saline OCT. You could see here that we were debating whether we should go with an IVUS or an OCT, but then ultimately we decided on a saline OCT. The vessel sizes were identified, and you could also see in the lower frames that there was 360-degree arc of calcification. There were thinner areas, there were thicker areas. At 12 o'clock position, you could see that there were thin areas, which made us happy that following balloon dilatation, we'll be able to crack that particular area. So went ahead with a cutting balloon, that is a cutting balloon being used, and following that, you could see that a second OCT run with saline flush. Again, you could see that there are multiple areas of fractures of the calcium over there. Then went ahead with stent implantation. We again used ultra low contrast. Stent contrast was not injected at all. With the help of wires inside the diagonal and the circumflex, the stent was positioned, the stent was implanted, and following stent implantation, the ECG was good, the patient was stable. We rewired into the diagonal branch before post dilatation, and once we rewired into the diagonal branch, we did a post dilatation with 3.5 millimeter balloon. Till then, the patient was stable, and once we did the post dilatation, the patient started developing angina, started developing a little bit of pulmonary edema, because the LED was supporting the right coronary artery, a bit of pulmonary edema, angina, and you could see that the monitor showed ST depression. So we thought that the diagonal flow was not good, so we dilated the diagonal with an 1.5 millimeter balloon. In spite of that, he was not better, so we thought that we should take a contrast injection. So we went to caudal view and took a contrast injection. You could see that the wire inside the diagonal branch, there is no flow inside the diagonal branch. Moreover, you could also see that the flow in the LED is also very sluggish at that point of time. That was only TB2 flow, and there was haziness at the distal half of the stent. So we decided that we'll do a kissing balloon dilatation. Because of the haziness, we decided that we'll start him on tirofiban. So tirofiban was given, intracoronary cocktails were given, nitroprusside was given, and then slowly the ECG settled down, patient settled down following the kissing balloon dilatation. And that was the last OCT run. This OCT run was done with a contrast. It was not a saline OCT run, and you could see here that the flow in the vessels are good. Now, what we made out with OCT was, you could see that there was significant amount of thrombus there in the distal half of the stented segment. You could also see the wire going into the diagonal branch over there. There appears to be clots over there. Again, you could see in this particular view that in the second half of the stent, distal half of the stent, you're seeing some clots over there, and you could also see that the diagonal ostium is very well open, and now it made us feel that it's just the clot that created the trouble. We decided that we wouldn't go further with further with post dilatations. We stopped the procedure there, gave intracoronary nicorandil and nitroprusside, and then with tirofiban the patient settled down. So this was how the patient OCT helped us to manage this particular patient. And probably we thought that IVUS would have definitely given us a lot of information compared to OCT. IVUS would have given less of information compared to OCT, wherein we made out that the ostium of the diagonal was patent. We made out that the clots were very clearly seen. So that is how this particular case was managed. This is a very short case. I'll stop within 1 minute. A patient who had an infemoral myocardial infarction underwent a primary angioplasty for this. right coronary artery. He also had lesions in the circumflex, and that was also stented in a different setting. We made out that there was some amount of haziness in the left anterior descending artery. You could see that there is some amount of haziness in the left anterior descending artery in the caudal view. In the cranial view also, we felt that there was some mild disease over there. Because he was a very young chap, we thought that we should evaluate that particular lesion in the left anterior descending artery with an FFR, and we did physiology, made out that it was a very significant lesion at the left anterior descending artery. And something interesting that happened was we were not able to wire that particular lesion with the FFR wire. The LED was wired with a lot of difficulty, and it turned out to be positive. So we decided that we should have a look at the lesion with OCT, and we made out that there was a significant amount of recanalized thrombus. It was an old occlusion. The recanalized thrombus was seen over there, which was never picked out in the angiography. And this OCT, you could see that there is honeycombing, the lotus root appearance. So we made out a diagnosis that it was the recanalized thrombus stented, and finally we were able to achieve a good result. And the final IVUS was good, the OCT, final OCT was good, the FFR was good. That's how, again, in this particular case, OCT helped us to save the day. Thank you so much for the patient hearing.
Thank you. Fantastic cases, David. Congratulations. I think the first case was very interesting. The only thing is there was a wire artifact, unfortunately, not clearly showing the entry exit at the left main level. But we could clearly understand what you said. It's very interesting. And again, the second case was a thrombus. Again, not more than that. The last case was very interesting because FFR really point out the problem, and the OCT clearly showed a recanalized thrombus. Very good educative cases. Would any other views from other panelists or chairpersons, please?
Yeah, I agree. The first case in particular was because when you see those that little evidence of a dissection into the left main, we get very anxious, and the reflex says, "Oh, we need to fix it." But I think the imaging here very elegantly showed the problem that happened prior to the stenting, with that big dissection into the media that extended into the left main. But the stent actually covered that dissection, and of course, it's a perfectly placed stent. The second comment is that the old Eagle Eye IVUS, which is 20 megahertz, probably in this day and age is now, a little bit dated, I think, for good assessment of intravascular imaging, and even compared to our 40 megahertz IVUS catheters, apart from sizing the vessel and showing gross malapposition, it probably is not going to be able to show those subtle things like a dissection that even a 40 megahertz IVUS would. But great cases.
Absolutely.
Dr. Christo, would you think that in this particular situation, the first case, would a 60 or a 40 megahertz IVUS would have made a difference? Would it have really identified what exactly was the problem as we made out with OCT?
No.
I think while it may, the 60 certainly is very good, certainly a step up from the 40, but at the least what those IVUS technologies can show you is that there's nothing terrible going on. Whereas with the 20 megahertz, you really have no idea what's going on. You know what I mean? And so while it certainly wouldn't have given you the same details as the OCT, I think it would certainly have given you enough to be comfortable to say, look, there's a bit of staining, but there's nothing gross in the lumen that we can leave it.
So Davidson, if you have done an IVUS after the OCT, then you could probably appreciate it with a 60 megahertz. But to make out in the beginning, it's very tough because unless you concentrate on that area and look at it very carefully, it's difficult to identify.
Agree.
Yeah. So let's, thanks, we will go to the next case, which is underexpanded stent detection by imaging. Dr. B.D. Shah, please.
So just press F5.
Yeah,
You go to the first slide. Yes, sir.
Yeah. So thank you. Good afternoon, everybody, and thanks for this opportunity. So my topic given to me is under-expanded stent detection using imaging. Of course, for the last 3 days, we have been covering this topic, and I'm going to take you through some of the slides, some of the latest literature on this, and with a couple of examples, show you somewhat modified view of what under-expanded stent detection we have been discussing. So we all know that stent size is one of the predictors of stent failure, the most important predictor, I would say. And here it shows that less than 4.5 square millimeter is one of the strong predictors. Malapposition, in contrast, is not the predictor of stent failure as much as the other parameters like distal reference narrowing, distal edge dissection, proximal reference narrowing are. So what is stent under expansion? Stent under expansion was previously defined as the failure to achieve a minimum instant diameter greater than 80% of the average reference segment diameter. Mind well, this was possibly pre-imaging era when things were on QCA and angiography. And the angiography has its own limitation to evaluate the extent of stent under expansion. Right, so this is it. This is angiography. This is a stent boost. You can see the under-expanded or the unexpanded stent over here. You put an NC balloon, you put a high-pressure balloon, you put an IVL, and later on followed by that with an NC balloon, and you see this. But it's difficult to quantitate this, and therefore, even in the latest data on the ultimate trial, a 3-year follow-up has shown that IVUS imaging is far better than angiographic guidance for detection stent under expansion. And the predictors were stent MLA of an optimal PCI was stent MLA more than 5 square millimeter, 90% of the MLA at distal reference segment, and plaque burden less than 50% at both the edges, and no edge stent dissection. So under expansion contributes to early and late stent failure. This is one of the earlier studies in 2017 where cutoff for almost 4.5, and you can see here that both less than 1 year and more than 1 year, it predicted that. So what are the IVUS and OCT criteria? Unfortunately, both are different. And in the IVUS, we see that the latest generation stents is somewhere around 5.3, 5.4, and the OCT, although is less than 4.5 square millimeter in the Illumin 3, OCT MSA less than 5 square millimeter was found to be in 1/3, and the IVUS and OCT around 30%, and therefore this is what they defined. OPN, okay, so this is under expanded stent. You can see here on the stent boost also as well as on the angio, and you use a high pressure balloon to get maximum dimension, and you can see on the stent boost, and therefore imaging exactly gives you the area of the expanded stent. And now there are enough studies to show that imaging helps to improve PCI outcomes. So not only in detection, in therapy, and afterwards, once you achieve better MSAs, it has shown both in the IVUS XPL and the ultimate studies that it has shown it improves the PCI outcomes. The only probably unfortunate part is the definition of under expansion. It varies from study to study, trial to trial. Sometimes it is 90% of the average. Just a second, let me change to laser. Yeah, so sometimes it is 90% of the average reference lumen area or 80% of the average reference lumen area, sometimes on the distal reference lumen area, and so on. So this has been a bit of a problematic thing as to what defines. So depending upon the study you may, but by and large, it is accepted that at least it should be 80% of the reference lumen area or the average reference lumen area. But recently published ADAPT-DES trial sub-study showed that if you have an MSA of less than 4.5, but the residual plaque burden is less than 38.9, or let us say less than 40%, then the MACE rate is fairly okay. And if the residual plaque burden is more, despite your MSA more than 4.5, then it is slightly high. So it is better to achieve a more than 4.5 and a less than 40% residual plaque burden. And I think this possibly should be put into more into practice. Let us go. What are the causes of underexpansion? Procedural techniques, lesion-related factors, taking an undersized stent, post-dilating with an undersized balloon, the inflation pressures may not be adequate, and therefore you fail to get a full stent expansion. Possibly the most important causes are the heavy plaque burden, dense fibrotic tissue, or calcification, which avoids vessel wall distensibility. So in calcium, we all know that plaque fractures or the calcium fractures, they predict the outcomes, and therefore as many calcium fractures are related to the outcomes, and therefore one tries to get as many fractures as possible, which you can appreciate on imaging, in this case the OCT. There are various scores given both on the OCT as well as on the IVUS scoring points, which says that if you have a calcium score of 4 and possibly if you don't get fractures, then the end result would be not so good, and there will be stent under expansion. So this is classic example of a 2 points, 1 point, you still get expansion without any modifying device. But if you have calcium score of 4, 360 degree, 5 millimeter in length, and then you can get this kind of under expanded stents. Now there is another subset also where under expansion has been defined, and that is in 2-stent bifurcation technique. So when you use 2 stents, the chances of stent under expansion are more, especially studies have shown in the left vein. So you have various criteria from the Asian sub-study from Kang, then from the Excel, and from the Nobel also, where they have defined in left vein bifurcation the areas to achieve, so that you can get good, better results. So now just 1 or 2 examples of what this is. So this is a calcified, you can see a lot of calcium over there, both in the LAD and the circumflex. There is ostial disease, there is proximal disease, and there is mid-LAD, a functional CTO sort of here in this case. And so after rotablation and IVUS was done, and you can see the distal reference landing zone which we had. This was the best we could have. Just proximal to that, we had this post-rota. You can see 360 degree arc of calcium over here. This is post-rota, and then this is just proximal to that, where there was some good zone, and you can see here that the areas were around, the EL was around 3.5, and this is just after the ostium, where the areas, I mean, the ELs are like 4.3 and 5.5, and this is the ostium of the LAD. You can see the circumflex here, and 270 degrees of arc of calcium over here. So after rotablation, we did the cutting balloon. The NC balloon was a waste, and therefore we used a cutting balloon which yielded, and after that we post-dilated with a 3.5 NC balloon and put in 2 stents. Okay. But trying to achieve the areas of 3 and 3.5, that is 9 square millimeter and so on for a 3 or more, one may tend, and this was an OPN used to correct that waste or seen on the stent boost, and we had a perforation over here wherein we had to put a covered stent. So, and this is post-covered stent. I was over there, so the area came down to 6.5 from 9 in that. And of course, the ostium, we spared the ostium from the covered stent where the area was 9. So that's why I think that we should adapt to what ADAPT DS told us, that have a good lumen, at least more than 5, but residual plaque burden less than 40%. And
Dr. Shah, can you come
to
the
I finish it. So one can make the use of IFR and DPR also post plasty. I'll just skip this case to show you that there was a residual plaque burden of less than 4, almost 3.91 on the IVUS in spite of post dilatation at high pressure. So I took the help of FFR, RFR, both were normal. I left this alone. So I think sometimes it is pragmatic to use and these adjacent parameters. I'll just finish this last slide. So stent under expansion, detection and treatment by imaging, and also I would add physiology. Angio and stent boost routinely, IVUS or OCT. IVUS OCT with co-registration more appropriate to find out the exact site of under expansion. NHPR and FFR as endpoint can be taken if you're not satisfied with the above. In the future, we will have QFR as endpoint also. We will have combined IVUS OCT with physio catheter. We will have IVUS OCT derived physio parameters and a combined IVUS OCT physio catheter. So that is how it would help us in our intervention. Thank you very much.
Thank you, Dr. Shah, for this extensive, elaborate discussion. So I just want to add on to one point. The expansion, I think we have been discussing about it. The one thing we have to look into is relative expansion. We also talk about absolute expansion, but absolute expansion, as we know, the vessel size is totally different from proximal, mid, or distal portion of the vessel. So one needs to consider the branching. So we know that the vessel tapers. We know from the Finnett's law, the vessel significantly tapers for every branching. So we need to take that into consideration. And when you use OCT, we can use the dual reference method and split the arteries up to the areas of bifurcation. In that way, we will be able to adequately assess the expansion, and we may not be over ambitious to over expand the artery and get into problems. And secondly, when some situations when we have a protruding calcium, despite adequate post-dilatation, it might not be able to achieve the required expansion, and we should be able to accept it to avoid sometimes a disastrous complication. I think with these two messages, any other comments by Chris, we will move to the next case. Please, quick comment from Chris, and we'll go to the next case.
Yeah, I completely agree. We've got the historical numbers of 5.3, 5.4 with DES, but when you actually look at the area under the curve, it's like 0.67. Now, if you have a diagnostic test with an area under the curve of 0.67, they'll throw it away. What that shows, as you said, is that it's not an absolute number, but based on that individual and that individual's tapering and so on. And I think the MSA is still probably our best goal to try and achieve an overall MSA of over 80%. And interestingly, when you look at even the clinical trials, the number of percentage that weren't able to achieve that is quite high. So in this context, imaging, I think, again, is very helpful.
Thank you, and let's move to the next case. Thank you, Dr. Shah, for good discussion. Dr. Shivakumar,
Sir, Dr. Shivakumar will do it next, sir. We'll go for the keynote lecture now.
I think it's a great honor to invite Dr. Juniashite for this keynote lecture on step-by-step approach to left main bifurcation using imaging. So,
can you hear me?
Yes, we can.
And see my slides?
You can very well see slides, and really thank you for being part of this IPCI. We're really honored. Thank you. Please go ahead.
Okay, thank you very much. So thank you very much for inviting me. It is my honor to introduce my lecture. The title is about step-by-step approach to LM bifurcation using OCT. This is my disclosure. As you may know, in OCT guided PCI, there is a slogan, MLD max. For pre-PCI, OCT shows MLD. M means tissue morphology, and L means lesion length, and D means lesion diameter. For morphology, OCT characterizes tissue components, fibrous plaque identified as homogeneous high intensity, and calcified plaque is clear border, heterogeneous, and low light attenuation. And the lipid plaque is unclear border, low intensity, and high light attenuation. This is an example of LM calcified bifurcation. You can see the calcium in here by OCT. If there is a calcified plaque in opposite side of carina, carina shift may happen after stenting. In this situation, rotablation recommended before stenting. So we have done the rotablation using the 2.0 millimeter bar. You can see the aberration effect in here, and the stent expansion as well, and no carina shift happen. So lesion preparation is very important, like this situation. Also, if side branch angle is narrow like this and carina is protruding to main vessel, there is a high possibility of side branch occlusion due to carina shift. Side branch protection procedure such as a gel balloon or a gel corsair is recommended. I think OCT predicts side branch occlusion after stenting. For lesion length and lumen diameter, OCT auto lumen profile display shows coronary lumen profile in all scan area. It will guide stent landing zone and help to decide stent length and diameter. It is a coronary map. Anyway, how we implant stent in LM bifurcation. This is a schema of LM bifurcation, and there is a vessel size difference in LM and LAD, so stent diameter should be primarily adjusted to LAD diameter. And remarkable malapposition happen in LMT, you know. In this situation, if you want to recross the guide wire to the side branch, there is a possibility the guide wire outside stent. And also due to the straight form of the stent, it is difficult to recross the guide wire distal cell. And if the guide wire recross the proximal cell, after KVT, gel strut remain at distal carina. If you do the proximal optimization treatment pot with bigger balloon inflation, stent malapposition disappear, and due to the gap of the stent, it is easy to recross the guide wire to the distal cell. In this situation, after KVT, all the stent shifted to the circumflex and get the optimal results. In LM bifurcation, stent diameter should be adjusted to LAD diameter, and the pot balloon should be adjusted to pot LMT diameter in here. And also stent length and pot length should be precise using OCT information. For post-PCI, OCT shows max, M means stent edge medial dissection, and M means stent apposition, and X means stent expansion. This is the example of giant Sierra 2.75, 38 implanted. And you can see the apposition condition in here, and also expansion condition was there. You have to treat only the red area, no apposition, malapposition. However, under expansion exists in here, so you have to only do the post-dilatation in this lesion. And you know, 3D OCT gives image information such as stent cell figure and location of stent link in relation to side branch orifice, and also guide wire recrossing position. And we understand stent link disturbs side branch opening. If the stent link did not locate at side branch orifice, we call it link-free type. Optimal guide wire recrossing point is distal cell cross to carina. After KVT, these stents shifted to the side branch side, and where open, we can get optimal result after KVT. So I would like to show OCT case used in LM bifurcation. This is a LM circumflex long disease in here. And OCT lesion length is very precise. If we understand from here to here is 38 millimeter length. So we decided implant stent 3.5, 38 from LMT to the circumflex. And just size for LMT to circumflex. After implantation to the LM to circumflex, recross guide wire to the LAD, we check the recrossing point by 3D OCT. And the 3D OCT show this is a stent link is here, and the guide wire recross in this cell. You can imagine by this situation, KVT shows a crushed stent and cause a harmful effect. So ideal recrossing point is here, but this space is very narrow. So we have done the port using a 5.0 millimeter balloon, just the proximal of carina. And then recross the guide wire to the LAD again and check the recrossing point. Previous guide wire recrossing this cell, but now this recrossing guide wire is a distal cell across the carina. You can see this is a before port and after port. This space becomes wide due to the port. You can see the importance of port in here. And then the KBT 3.5 and 2.5 in here. This is final angiogram, show the beautiful result. This is after a KBT, this is the entrance of LAD and high lateral branch. No gel strut remains in here. 8 months follow-up show no restenosis. And the OCT show well enantiomer coverage in Archman stent. And here comes a high lateral branch and LAD orifice. No restenosis like this. I think proximal optimization technique POT is effective to open the distal cell if distal end of POT balloon adequately placed close to carina. This is another example of LAD osteal disease in here. It's a very complicated disease. So we decided implant stent from LMT to the LAD using a 3.5 80 millimeter length stent. After implant stent, recross the guide wire to the circumflex and check the guide wire recrossing position by OCT. And this is a proximal and distal guide wire recrossing this cell. This is a linkage here. So ideal recrossing point should be here. In this situation, if you want to recross the guide wire in different cell, double lumen caster is useful. The first guide wire is here and double lumen caster is here. In this situation, you can make sure this double lumen caster goes through the stent or not and put it back. And second guide wire go to the next cell. No more double lumen caster goes through the stent. You can make sure. So this case, now you can make sure that the double lumen caster goes through the stent and then putting back the double lumen caster and aim to recross the guide wire more distal cell like this. And then no more double lumen caster cannot go through the stent. That is a sign two guide wire go through the different cell. And then remove the first guide wire and check the second wire recrossing position by OCT. Now this time guide wire recrossing distal cell, previously recrossing proximal cell. So this is the ideal recrossing point. We have done the KVT. And the final angiogram show the beautiful result like this. No more gel strut at side branch orifice. 4 months follow-up show no restenosis. And OCT show well enantiomer coverage. And intermediate branch comes and circumflex branch comes. Looks like a beautiful result. If you want to recross the guide wire in different stent cell, double lumen caster is useful. If the two guide wire goes through the different cell, DLC cannot go through the stent. That is a sign we can make sure. If the stent link locates close to carina, we call link connecting to carina type. It is difficult to remove the gel strut by KVT. This is an example of side branch orifice. Stent link is located at center of orifice. Guide wire recrossing this cell after KVT, this stent crashed. And also by putting effect by balloon, this stent put into the proximal and no stent zone happen like this. In this situation, you can see KVT causes a harmful effect in this case. This is example of also linkage here and guide wire recrossing the distal cell. After KVT, this stent crashed and also no stent zone happen by putting effect by balloon. If you recross a guide wire proximal cell, of course, there is a metallic carina remains in here. So if you see the stent link located at the orifice of the side branch, we sometimes try the novel push-forward method for removing the side branch stent. The concept is if the stent link is here, intentionally recross the guide wire to the proximal cell, and while ballooning inflated, push strongly to forward the stent to the side branch side. You can see the stent is bending to the side branch side. After KVT, a wide open of the side branch is obtained. This is actual case. Diagonal branch orifice is here and stent link is here. Intentionally recross the guide wire to the proximal cell and wire bottom inflated and push strongly to forward the stent to the diagonal branch side like this. After KVT, you can see this stent folded and well covered like here. This is another case of LMT bifurcation. And OCT show this stent link is here. So we intentionally cross the guide wire to the proximal cell in here. And then wire bottom inflated to the LMT stent lesion and push strongly to the inflated bottom to the circumflex like this, using the anchor bottom technique to get the strong backup force. After this, we did a KVT. This is before push, and this is after push. You see this stent shifted distally to the LAD and well open of the side branch orifice. This is the effect of push button method. I think button push technique under the 3D OCT guidance is feasible and useful for removing the gel strut over side branch orifice if the stent link is located at carina. Final issue is the most difficult situation is NMT bifurcation with eccentric calcified severe torture LCX orifice. Rotabration with push force has a high risk for perforation. This is an example of both LAD orifice and circumflex orifice disease. You can see the calcium in the small curvature side of circumflex orifice. And rotabration 1.5 was tried to open this circumflex orifice because no device could not through this lesion. And then also these are calcified lesion, rotabration was done. After this ST depression happened, you see the no flow at the LCX and LAD also. We like to make sure that what happened in this situation using OCT. This is LAD pullback. You can see the narrowing of LAD orifice. Hematoma is here. Orifice of circumflex still extended hematoma to the LMT like this. So this is a static image. LMT, this is a hematoma in here. And this is orifice of dissection in the near the circumflex orifice. Due to the rotabration and dissection happened. And the hematoma extended to the LAD distal like this. We decided to implant stent from LMT to the LAD and we store the flow in here. And OCT show the LAD lumen is gained. And this circumflex orifice is here, like here. And we check the guide wire recrossing point. This time, the guide wire recrossing the proximal cell like this. So we aim to recross this cell and succeeded in recrossing this cell guide wire. But still remain the stent strut in here. So applied, we do the push forward method balloon. Wire balloon inflated anchor to the LID and inflated balloon circumflex push strongly like this to the prototic stent shifted to the LID. Now cross the circumflex and KVT was done. And final angio show still remained stenosis in circumflex, but we succeeded in bail out this difficult condition. And OCT showed circumflex orifice looks okay. So no J strut at side branch orifice like this. I think in this situation, orbital atherectomy, diamond back with pulling back has a less possibility of perforation. This is another final case, very tortuous circumflex orifice in the calcified disease in both lesions. And also distal NMT distal LMT proximal to the bifurcation, there's a stenosis also. And the spider view show orifice of circumflex, there is also a severe stenosis. So we have done the primary glide assist and succeeded in cross the lesion by dynamo back and stop ablation by pulling back maneuver until the orifice of circumflex. And then we have done the load ablation 2.25 at orifice of circumflex. And then balloon inflation was done to the orifice of circumflex. This is immediately after orbital atherectomy, low speed, ablation effect was seen at the orifice of circumflex, high speed, and load ablation, and balloon inflation. You can get wide open the circumflex orifice. And then primary done the load ablation to the LMT to the LAD because this is a straight form. And the giant stent implanted, crossover to the circumflex, and guided recrossing point, this looks okay to the circumflex. This is immediate after load ablation. Ablation effect was seen in there, post-cutting balloon, stenting, post-KVT, wide open the circumflex orifice, like this. This is the final angiogram, show a little bit dissection was observed, but OCT finally looks okay. We can safely finish this procedure, open the circumflex orifice. The message is for eccentric tortuous Kashmir lesion, full back orbital atherectomy may be effective to make an incision in Kashmir lesion. Aggressive foreign rotation may lead optimal lumen gain. So my conclusion is step-by-step 3D OCT will guide your LMT bifurcation stenting. Thank you for your attention.
Thank you, Doctor. Very excellent overview of bifurcation step-by-step using OCT, particularly 3D OCT. Fantastic, and the pushback technique, which you mentioned, it's very interesting. But do you think the stents can deform? And very important to make sure there is no absolute good apposition proximally. There is good part done before we do this. And is there any incidence of stent deformation when you push a stent like that?
Yeah, it's a very important point. Before push, pulse should be done because protruding stents should be shifted to the side branch side, then push is very important because there's a possibility to reverse to main vessel size. So port is important. Primary a little bit bend it to the side branch side and then push. It's very important.
So, Dr. Chris.
And would you, after you've done the push, do you finish off with a pot?
Actually, after push and then KVT,
yeah,
and hopefully final pot also required, I think.
Yeah. I see. Now, traditionally, we've always said, left main IVUS is maybe better because OCT clearing of blood and so on. But on your images, the OCT images are just fantastic. So do you mostly use OCT now for left main bifurcation stenting?
For left main bifurcation stenting, 100% OCT.
Wow.
You can get a clear image, a 3D image. And I think for circumflex is very important, not the side branch, both main branch. So to get the optimal result is very important for this case.
Do you use contrast or saline? Because I had seen that at least you do about 5 or 6 times OCT during the procedure to assess the side branch, pre-procedural, post-procedural. So do you use contrast or saline?
We use a low molecular dextran. Okay. But maybe you can use a half contrast, mixed with saline and contrast. And you push strongly by 20 cc syringe just beside the Y connector and push strongly, you can get a clear 3D OCT image LMT.
Dr. Sujata, Dr. Arun, you have any questions?
Just wanted to ask you,
yeah.
What size balloon do you use for this push technique, and to what pressures do you inflate it before pushing?
Yeah, it's a very good point. The balloon size is just for side branch size. If the side branch 2.5, we select the 2.5 balloon. But the pressure is a little bit low average load pressure is 4 atmosphere. So 3 to 6 atmosphere. Primary, we do the inflation 6 atmosphere. And if you cannot cross the lesion, decrease the pressure to 4 and push.
So the other thing is, if you want to do a one stent technique, if you do a push, you might land up with another stent because it might injure the ostium of the circumflex. So do you always stent the circumflex after the push, or you even leave it with one stent if in some times?
My primary selection is a one stent crossover with KVT finish. And if we want to do the two stenting, we mainly use a curotte technique because a curotte stenting is easy to understand the decrossing point by OCT. DK crash sometimes confusing to understand the decrossing position. But it depends on the situation that if the difference of main vessel and side branch is very large, maybe DK crash is better.
My question is, will this push technique cause injury to the proximal circumflex needing a stent?
I'm sorry?
No, by doing this pushing technique, can we cause injury to the proximal circumflex, ostium of the circumflex, needing a stent and necessitating a stent which was previously not planned?
No stent, I think.
If there is no strata across the circumflex, would you do nothing? Like don't do a kissing, don't do a port side port, just leave it alone if there is no strata cross?
Yeah, of course. If you see the 3D OCT findings, no strat at the side of orifice, no need to do it. But if you find the vessel size difference in the proximal and distal main vessel, you should do the port. And if you do the port, more possibility no stent remain at the side branch orifice.
Because the imaging use is only 40% in even a EBC main, and they did kissing in about 82%. So maybe we do imaging, we could even forget to do a KBI and port side port if there is no strata cross. If we use more imaging.
Yeah, it's a good point. So in Japan, we are happy, fortunate we can use imaging modality with reimbursement. So we can do almost all the cases of LMT bifurcation. I think it's maybe bifurcation, especially LMT, we should use imaging modality.
I think there are no further questions. I think thank you very much for an excellent lecture. So let's move to the last talk by Dr. Shivakumar, if he is ready. Is Shivakumar ready? Yeah, Shivakumar, good to see you. Please go ahead. Shivakumar, you're muted.
No, sir. Actually, he's not muted, but I don't know which mic system. No, Dr. Shivakumar. Can you select the mic on the laptop? Now you have muted it. Unmute. Can you try it, sir? Now?
Am I audible?
Yes, sir.
Yes, now you can, Shivakumar. Go ahead.
First of all, very happy to be part of IPCI. It's a successful fourth edition. A special thanks to Rajesh Devargia for personal invitation. And I also appreciate the hard work done by other course directors, Dr. Sangatwel, Vijay Kumar, Ashok, Matthew Samuel, Ajit Muller, sir. My talk is OCT ACS with a stent fracture. Hope my slides are moving and it's seen there.
Yes, we can see it very clearly.
Stent fracture is defined as a complete or incomplete separation of the strut, either by fluoroscopic image or you go ahead with an imaging, either IVUS or an OCT, where you demonstrate a gap at least by one slice. The incidence is somewhere between 1 to 20%. It is basically underestimated because it could be an asymptomatic or they present with an ST, acute MI, so your thrombus burden, all that makes not appreciate, or they end up in a very bad state, so we don't get clinically represented. So the median time interval from implantation to detection of this fracture ranging from a week to 620 days. So this is basically, you need to have this insight of every ISR case which you come across, where after meticulously improving the flow, if it is a ST, we need to take care of the thrombus. If it is an ISR, you need to make sure, if you suspect, particularly in an RCA, mid-RCA, if you think you have high degree of suspicion of a fracture, you need to have that insight to look into this. So basically, this is of 4 types. Type 1 has type A and B. Type 1A is just a single strut fracture without a gap, whereas type 1B is there are gap between 2 struts, which is more than 2 times of the 2.5 mm cell. Type 3 is a transverse fracture, but there is still at the lower part, on one part of the strut, that is still connected. So it's a kind of a V gap. Type 3 is a complete transverse separation without displacement, and type 4 is there is a complete transverse gap with displacement. There are various groups. This I felt very simple to appreciate. Regarding predictors, it could be from anatomical perspective, as I said earlier, highly angulated vessels, chartreuse vessels, long lesions, bridging vessels, complex lesions like CTO, change in vessel angulation after stent implantation. I think many a time, Sangeetwell has even reported stent concertina. Those kind of incompatibility between the stent and vessel, and RCA repetitive distorting forces, particularly in the mid-RCA, that too on top of a calcified nodule, this can cause a fracture. And depending on the stent factors, it's more reported in sirolimus group of stents, probably because of the cipher, which had a rigid flow cell structure and decreased stent conformability to the vessel, and technically over expansion either by the balloon or by the stent itself, and long stents getting overlapped, particularly the overlap site, and crush technique. Even Junior Said was mentioning about the default of decay crash, where sometimes when the optimal cell cross was not done properly, it can really create a fracture. So the other predictors could be abnormal myocardial contraction, mechanical stress between the sternum and dilated aortic root can cause osteal RCA stent fracture, and for an unknown reason in CKD. So this is one paper which was showing most of the cases were seen in RCA 56%, LAD next 30%, circumflex was the least 10%. Even cases were reported in saphenous vein graft, and LM was the least. So the clinical presentation could be asymptomatic, like I said, type 1A isolated strut fracture, recurrent exertional angina, ISR due to poor distribution or interruption of drug delivery as a result of strut fracture. When you fracture, it is drug evolution kinetics become disturbed. So you invite an ISR, and it could be, as I said earlier, stent thrombosis, acute coronary syndrome due to contact of fractured metal structure with vessel lumen. Diagnostic modalities, conventional fluoroscopy has a poor sensitivity. Stent boost has to be placed. I think stent vessel vis when you inject with a stent boost as an added stent boost, maybe sometimes with a good radio effect stent one can appreciate. IVUS being resolution only 150 microns, echoes due to artifact, difficulty in passing IVUS catheter may be also an issue. Whereas an OCT being a high resolution as close as 10 microns. Now the micro OCT is also upcoming. I think the days are becoming brighter for us to diagnose this. So OCT is being a high definition imaging modality with a lesser artifact is the imaging of choice. This is one particular paper which was involved by Deepak Bhatt and group, as Rajesh Vijay specially requested stent fracture within ACS, where it was 90, involved 289 stent fracture patients, where 95% of the time it was a cipher. STEMI was around 10% and NSTEMI was, so totally the ACS kind of situation was around 35 to 40%. So in the case of ACS, ST also, apart from an ISR where you generally suspect, this group also one should have a great insight to begin with, then only you will be keep applying your imaging in that perspective of to diagnose this. The dilemma hung between 2B3 inhibitors, DAB and DAS, particularly when there is stent thrombosis. OCT is essential to solve the problem, to determine the modality. And I think the very reason why somebody has to diagnose a strut fracture of a serious variety is, here the jab will not work, simple POBA will not work. You need to, even if it is a focal, if it is strut fracture with a significant gap, one need to look for an additional stent. So the use of DAS heterogeneous for restenting the stent fracture is an important decision. the foundation of which is definitely has to be laid by an OCT. So quickly, let me take you on a case, a 60-year-old male with a history of hypertension diabetic, underwent stenting to LAD twice, 6 years and 1 year back with the sirolimus eroding stent. The later DES stent was placed within the edges of the former DES, leading to 2 layers of DES in the mid-LAD, presented to a hospital this time with an anterior MI. Angiography revealed total thrombotic stent occlusion of the mid-LAD. So that's what it is. So the crossed with the conventional wire and it showed instant stenosis of the mid-LAD. So ISR on top of ST presented as STEMI syndrome in a patient who had a stent earlier twice overlapped in the overlapped mid-segment. This was the scenario now. This is a classical OCT picture now showing complete separation of the DES stents with multiple stent fractures at multiple levels in both overlapping stents. And there is, you can appreciate in 2 different views how it is getting separated, and there's a gap, there's a fractures at multiple levels. And this is a 3D with the stent rendering with the stent only mode, where this is clear separation, type 3 separation without much displacement. Clearly, so this kind of an advantage we don't have with an OCT. You are seeing stent rendering where there is in between the 2 fracture sites. You are seeing in a vessel without a stent rendering, and it is equally seen in stent only mode also. There is clear transverse complete separation without much displacement. So went ahead with the pre-dilatation and additional, as I said earlier, if you demonstrate this strut fracture of a serious variety, then there is no point in considering non-DES methods of fixing it. We need to go ahead with the additional stent, and this is a final check angiogram. So, dear friends, to conclude, re-intervention was associated with a significant reduction of MACE for patients with symptomatic strut fracture presenting as ISR and ST. The recommendation for re-intervention for strut fracture induced ISR or ST was that new generation of DES should be selected as a first-line option. Various studies have reported significant increase in MACE, TLR, ST, and MI after implantation of Ffr stent for symptomatic strut fracture induced ISR. The use of intravascular imaging OCT in our case was immensely fruitful as it helped to design the treatment strategy, iterating its need in all such cases of complete occlusion with instant restenosis. With this, let me conclude my presentation on this. Let me stop sharing, and I'm open for discussion.
Thank you, Shivkumar. Wonderful discussion. So when do you think the stent would have fractured in your case? After the procedure, after the second stent, how long you think it would have happened?
I think it was down the line of somewhere between 6 months to 1 year after the second stent. When the first stent was done 6 years back, the second was done just a year before. Probably the second stent, when got overlapped with the earlier stent, that interaction between the second stent and first stent in the mid-LAD made this fracture to happen. And
which stent fractured? The old Ffr stent or the new generation stent?
It involved both the stents. It involved both the stents at the overlap site, extending proximally into the earlier stent as well as to the. Your second stent was, I think, endover. The first stent was Ffr.
So the other thing is, stent boost can clearly identify this, isn't it, Shivkumar? If it's going to be class,
this was not on day one. This was not on day one. It is on following days. Yes, you are right. So what we generally do, whether it is in any case of an ISR, whether it is an under expansion or any kind of, whenever you suspect, particularly mechanical, there are 2 types of ISR now. Mechanical, biological. Forget the biological part. Mechanical part, it could be under expansion or strut fracture. The first step when I would recommend, for at least for the benefit, I think senior operators will do. Take your balloon, make sure whether balloon is crossable. Once it crosses, don't inflate the balloon. Take a help of stent boost. It will now tell you is it under expansion or it is a gap or fractures. So until otherwise, you have a high degree of suspicion, because one will not miss mechanical ISR, one will not miss biological ISR, one will not miss mixer ISR. But this strut fracture, until otherwise, you need to have a high degree of suspicion, as rightly said by Sankatvelu, park the balloon, take the help of stent boost. Now, two things are answered, whether it is an under-expanded stent with the intact strut or it is a strut fracture, which kind of strut fracture it is now to go ahead. Because it is going to ultimately change our treatment strategy. If it is simple under-expansion, we can get away with balloon or a deb, or if it is a strut fracture, then obviously, even if it is focal, the answer is additional stent.
I would like to ask Dr. Chris, could it be a sunflower artifact? The OCT picture, I thought it was too much insight. Could it be a sunflower artifact, which Dr. Shivakumar showed?
Junior Said can answer, and Dr. Chris also, please.
Yeah, Dr. Said, you can go ahead. So I think that the 3D reconstruction was very informative in this situation, and often sometimes is more helpful than the actual cross sections of the OCT imaging. It's almost like you know, a more sophisticated stent boost, the 3D reconstruction of the OCT. But you're right, sometimes you have to be a bit careful. Is it artifact? But generally the 3D reconstruction is, if it's done well, is a lot more helpful in identifying whether it is truly a stent fracture.
And in this type 3 fracture, I think Shivakumar would have also definitely confirmed with the stent boost. So it's obviously
absolutely, yes, yes.
Clear separation.
Yeah.
Okay. Thank you. I think it was a good talk, Shivakumar. Let's move to the next session. I think Dr. Rajesh, I think we're already running late. So request Rajesh to take over.
Thanks to all the speakers, chairperson, and the panelists for the wonderful session on complication, and it's a bailout management by the imaging. And let's move forward to the next interesting session about imaging and physiology in the special situations. And let me invite Dr. Akasaka, Sarachandra, and Dr. Hiraman to chair the session. And along with this, the expert panelists include Dr. Arun Srinivas, Dr. Ajit Mehta, Dr. Safik, Dr. Parminder Singh, and Dr. Basant Kumar. So let's.
I take this opportunity to welcome Dr. Akasaka. It's a great pleasure to have you again in this forum. And congratulations for becoming the General Secretary of Asia Pacific Society of Cardiology. And we are really honored to have you.
Thank you very much for kind invitation. I really appreciate your kind invitation this year again. Thank you.
So let's move to the first presentation by Dr. Ankush regarding OCT guided zero minimal contrast PCI. Ankush, please.
I believe my slides are visible.
Yes, it's visible and you are audible as well.
Good afternoon, everybody. I would like to thank IPCI for having me here and to give me opportunity to present this zero contrast OCT, our work on it. We just heard Dr. Sankatvelu asking Dr. Junia about doing saline OCT, whether he has used saline OCT for multiple runs. And last week I saw Dr. Ajit doing a beautiful case of saline OCT in a patient with CKD. Let me show you our work that we started around 3 years back, and we got some good publications. So whenever we think about OCT, the major concern is again the large amount of contrast that may be required for flushing the coronary arteries and the risk of contrast-induced nephropathy in the high-risk patients. Efforts are being made to look for a contrast-saving alternative as a flushing media. Low molecular weight XN has been used, and it has shown that the imaging quality is at par with the contrast, but it has got its own limitation of availability, cost, and risk of anaphylactic reaction. Saline has been used as a flushing media in preclinical animal studies, and they have shown that we can get a decent image with the saline OCT. This led to our hypothesis that saline may be used for coronary OCT, and we did this study by the name of SOCT PCI study. This was a prospective feasibility study in which we examined whether saline can be used as a flushing media for coronary OCT. In this study, we enrolled 27 patients and we analyzed 118 runs, and all the runs were categorized into good run, clinically usable run, and clinically not usable run. Good runs were those that were at par with the contrast. Clinically usable run were those in which the blood swell was there, but all the information that is required for PCI optimization was there. And clinically not usable run were those in which there was no information available as far as PCI optimization is concerned. In associative PCI study, we analyzed 118 runs, both pre and post PCI. We observed that there was no hemodynamic changes observed during saline OCT, and there were transient ECG changes that was normal, and there was no rise in CKMB level 12 hours after saline OCT. So all the coronary morphologies, be it a normal coronary artery, intima, media, or adventitia, thin cap fibroatheroma, fibrotic lesion, multiple stent layer, ISR, red thrombus, dissection, calcium arc, calcium nodule, or maybe intimal vasculature or cholesterol. So all were well visualized with the saline OCT, as we can see with the contrast. So associative PCI study, we found that 61% were good run, 27 were clinically usable run, and 11% were clinically not usable run. When we combined good run and clinically usable run, the success rate of associative PCI study was 88%. So this was the first human study that showed us that saline can be used as an alternative to contrast and dextran for coronary OCT with the success rate of 88% and with the image quality as good as that of contrast. And all the coronary lesions close to the histology are very well seen with the saline OCT. So after this associative study, the major concern in our mind was what is the effect of saline on the measured vessel parameter? Because whenever we are using OCT for PCI optimization, we not only see the morphology, we have to see the proximal reference diameter, we have to see the distal reference diameter, we have to use the vessel dimensions. So this led to our next study in which we did head-to-head comparison between saline and radio contrast to see what is the effect of saline on measured vessel parameter. So in this study, again, this was a prospective study in which we enrolled 9 patients and 26 runs were analyzed. We did a hand injection in all the patients. 20 ml of Leolog syringe was used for contrast and 30 ml for heparinized saline. Before each run, we gave 100 microgram of intracoronary NTG, and the sequence was NTG, intracoronary NTG, followed by contrast run, then again intracoronary NTG, followed by saline run. Approximately around 20 ml of saline was required for left coronary system, and around 15 ml was required for the right coronary system. This is how actually it looks like when you do both saline and contrast OCT. The sequence was NTG, contrast, NTG, and saline. So we compared 13 pairs of contrast and saline OCT. We did the quantitative comparison between both the runs in the form of minimal lumen area, proximal reference diameter, distal reference diameter, and percentage area stenosis. As we all know that coronary vessels may vary in length with the cardiac cycle. So to make ourselves sure that we are measuring the vessel parameter at the same anatomical point, we use a number of anatomical landmarks, like we use side branches, macrophages, calcium dissections, and for post-PCRN, we use stent edge and the mid-stent. The idea behind this was to measure the coronary artery at the same level in both contrast as well as in the saline run. So let me show you one example. Above is the contrast run and below is the saline run. You can see all the lesion that one can see in the contrast. Everything is visible with the saline run. And you can see we made every effort to make our measurement at the same level, be it the contour of the vessel or calcium nodule or be it a TCFA. Let me show you another patient. So this was the case in which we placed left main to LED stent, and we compared it with the saline, and you can see even the rendered stent view, even the 3D reconstruction and side branch opening is very well seen with the saline OCT. So even if you are doing provisional stenting or two-stent strategy, you can see the side branch ostin. You can see your from where your wire is recrossing. This is another example in which we did the head-to-head comparison. We can see that we have tried to measure the vessel parameter at the same level, be it a contour or fibrotic lesion or 360 EL to EL. This is another example of a comparison between contrast and saline, and we went up to even a calcium thickness at the same level, so that we are having vessel measurement at the same level. This is again example from left main to LED, and one can see that everything that can be seen with the contrast is very well visualized with the saline also. You can see the side branch ostem. You can see whether it's a link-free carina or a link-connecting carina. This is another example in which we can see, dissection. We can see the recanalized thrombus, white thrombus. We can see the layer of macrophages. So even this we went up to macrophages level to measure the vessel at the same level. So let me show you what we got. So when we compared the minimal lumen area with the saline, we got with the saline to that of contrast. The highlighted one is sometimes we got a vessel parameter slightly more than that of the contrast, and sometimes it was less than that of contrast. So the preclinical study that I just mentioned that showed that was done in a rabbit aorta that showed that saline may give us OCT measurement that are less as compared to contrast, but in our studies, the few measurement was slightly higher and few were slightly lower than that of the contrast. This is the difference. This is the comparison between the proximal and the distal reference diameter. You can see sometimes it was more than that of the contrast and sometimes it was slightly lower. So when we compared it statistically, all the three things, MLA, proximal reference diameter, distal reference diameter, and area stenosis, everything, when we compared saline with the contrast, there was no statistical difference between them, and there was no actual difference as far as PCI optimization was concerned. And so when we did a blind Altman plotting to see the agreement between the saline and contrast for the measurement of coronary dimensions, we came to know that they showed a good agreement. So the take-home message with these two studies is that saline OCT is feasible and safe with good success rate of around 88%. All lesion morphology can be seen with saline OCT, and saline does not affect the major vessel parameter for PCI optimization as compared to contrast. But the limitation with the second study was the small sample size. So my tips and tricks for saline OCT is to start with RCA, align the guide catheter, use manual injection so that you can control your amount as well as pressure of saline that is required to take a good run. Use 30 ml lower log syringe. Always give anti-G before the run, and while taking pullback, keep an eye on the OCT console to give appropriate pressure and volume of the saline. And this study we got published in CRM, but again, the major limitation of this study was the small sample size, and I think we need a study with a large sample to confirm our data. Thank you very much.
Dr. Akasaga, any comment about the modification factor which is required to have a comparison between saline versus contrast, as there is a density which is different for the saline vis-a-vis contrast, and you have a good work on DEXA and also on the saline use during the OCT imaging.
Yeah, thank you very much. Congratulations, good result, Professor Gupta. Yes, you did a wonderful job. I think when we think about the right refractive index, the measurement may a little bit change, but clinically no problem at all. So generally speaking, in our clinical daily practice, there are no effect on the measurement, and also the right coronary. It's quite easy to get a clear image by saline injection. However, if you try to do the LED, it might be better to use an extension catheter close to the LCX. because we can focus on the LAD, and also at the same time you try to do the across the LAD to the CX. If you try to get an CX image by a saline, it's one of the technique to obtain the clear image by saline injection. But anyway, the good result, and congratulations. Yes.
Thank you, Dr. Alpasar.
So if there is no further question, let's go ahead for the next presentation by Dr. Bahulian regarding OCT and FFR combination for the PCI. Dr. Bahulian, please.
Yeah, thank you very much. My slides, are it visible?
Yes, it's visible and you are clearly audible.
Yeah. Thank you very much, the IPCI organizers, and then especially Dr. Rajesh for giving this opportunity. And I'm supposed to talk on what's the current placement of investigations like FFR and OCT in the cath lab. Now, regarding the FFR, pivotal trials like DEFER, what has it shown? It has shown that it is safe to defer PCI in FFR negative cases. Patient level analysis from FAME2, Dynamic 3 Primality and Compare Acute, has revealed sustained reduction in composite endpoints of death, MI, and urgent revascularization by PCI in FFR positive stable lesions compared to medical treatment. Now we have data from United States where in the real world situations of use of FFR in revascularization of intermediate coronary lesions has shown that Ffr guided revascularization in more than 18,000 patients, Ffr guided revascularization has resulted in a lower mortality of 2.8% versus 5.9%. On the right hand slide, it shows another data. Adherence to the generally accepted FFR threshold of 0.80 for PCI and its impact on the MACE. You will find that when the FFR is less than 0.80 or equal to 0.80, that is ischemic level, if you perform PCI, it results in good result compared to no PCI. Whereas non-ischemic lesions where the FFR is 0.80, medical treatment fares better. Now, pullback pressure gradient is another new metric of functional assessment in the cath lab. It simply is obtained by pullback of the pressure wire and identifying the FFR gradients because of the epicardial resistance. And from that, you can classify the relations into focal coronary artery disease, diffuse coronary artery disease, as well as combined coronary artery disease. And from this, you can derive an index known as PPG index. And the PPG index is expressed in terms of a unitless value of 0 to 1. Closer to 1, as it is shown here, closer to 1, it indicates a focal coronary artery disease. Closer to 0, that means lower the value, it indicates diffuse coronary artery disease, and in between you get combined coronary artery disease. And putting this into angiographically identified coronary extent of coronary artery disease, it has been found that roughly about 1/3 of patients get reclassified from angiographic classification. And you will find that many of the diffuse lesions will have a focal lesion, which could be stented, resulting in benefit for the patient. And vice versa, angiographically, you may think that it is a focal disease, but it may be a long lesion which require a longer stent. So I think this is the advantage. This is a new metric which is being worked out, and probably we will start hearing that will come to practical use. Now, what is its clinical impact of this PPG index? You will find that this pre-PCI FFR study, you will find that when I pull back, there is a focal step up in the FFR gradient. This is because this is the area where the translational gradient is maximum, and therefore the lowest FFR of 0.71, highly ischemic lesion. And if that patient is stented, it gets a good result in the sense of 0.71 pre-procedural FFR level goes to 0.96. That's an excellent result. The ischemia correction is going to be maximum, patient benefit is going to be maximum. Whereas in diffuse coronary artery disease, the gradient is slowly coming up and at a longer length of the lesion. And in that case, if you stent, The 0.71 pre-procedural effort get corrected only at 0.81, just above the ischemic threshold of FFR. The ischemia correction may not be good. Residual ischemia is more, patients' symptomatic improvement, and long-term MACE rate may not be as good as in the case of focal lesions. Now, another thing with FFR, we look at the post-PCI FFR. We have found that post-PCI FFR is higher, the better the results. And what do we have the data on post-PCI FFR? This study has shown that when the post-PCI FFR, if you get more than 0.90, the MACE rate as well as the TLR rate is going to be much less. And in clinical practice, if routinely if you do post-PCI FFR, you will not find that 0.90 achieving is that easy. Very time we don't achieve that. But at least achieving more than 0.80 as shown here, post-PCI FFR, you will find that the result of TLR is 2.5% at the end of 22 years compared to a post-PCI FFR still remaining less than 0.80. And it has been found that 1/3 of the patients or even more than still remains to be less than 0.80 even after an angiographically successful PCI. Now, I think we will go to the OCT. I'm showing you just a case of LAD diagonal lesion in the mid portion. It is the usual case which we come in the, or common case which come across in the catalog, not any complex cases or something like that. But the lesion seems to be intermediate. So in this sort of cases, we first do an FFR. Of course, now resting indices have come, but FFR is the standard one, and then we used to do the FFR. There's value is 0.74. It is highly ischemic lesion, so we have to do the PCI. And now to optimizing PCI, we have started using OCT, not only in complex cases as it was shown in the conference now, we started using in routine cases also, where we find that it is useful. And the higher resolution OCT pictures, this is the image. We have the long axis view, you have the lumen profile, and you have the cross-sectional views, and these are the automatic measurements. These are all, convenience obtained from an OCT. And application of MLD match starts from here by looking at the reference diameters, the proximal and the distal reference diameters you can make out from the EL. If the EL is not visible adequately, then you put the lumen size. You get from the distance from the proximal and the distal landing zone as the length. In this case, this is 24 millimeter, and you also find about the morphology of the lesion in this case. In this particular case, based on the distal reference of the vessel, on EL measurement, a 3 millimeter stent and a length of 24 millimeter has been selected. Morphology, nicely, the previous case shown that the morphological appreciation can be excellent because of the resolution of the OCT, as shown here in sporty calcium, and then you have the calcium arc. Well, of course, quantification of the calcification is very well accepted from OCT. You will find that the arc is less than 180, the thickness is also less than 500 microns, and then you will find another is the lipid-rich plaque. This is also can be quantified from OCT, and you can avoid landing into a large lipid-rich plaque. And calcium management, different algorithms have been worked out by the OCT, and new Altion to the artificial intelligence-based algorithm incorporated in the OCT gives much more information so that the pre-PCI as well as post-PCI. These spaces could be managed by a balloon-based technique. The stent has been placed 3 into 24 millimeter, and certainly the post-PCI OCT has to be taken to look at the MLD max component of optimization part of the stenting. You will find that the white line, the apposition index from proximal to distal, there is no apposition issue. The distal edge dissections are not there. And most important point is the expansion. The proximal and the distal expansion, you will find that the distal expansion is around more than 100%, is around 4.4 or 4.5 millimeter square, and the proximal one is 5.8 millimeter square, is 96%. This is acceptable from the current criteria of a well-expanded, well-opposed stent without dissection. And one of the advantages of OCT, which has been discussed, is that we will be able to select an appropriate stent for the given lesion. We will be able to get the maximum diameter, MLD, of the stent chosen. So that will probably contribute to a higher FFR, post-PCI FFR, and that may be the reason why we are getting better outcome of usage of OCT, even in less complex cases. So I think we are going to use more and more of OCT. Now, as usual, we did a post-PCI FFR in this case. You find that 0.84, not very great, but it is non-ischemic level. Maybe we haven't done a pullback in this case. Ideally, one should do a pullback and find out what is the reason for this residual ischemia or relatively lower FFR. You may find focal reasons, and that could be corrected. In this case, we have it done, and this is the importance of looking at the post-PCI FFR. One, you assess your perfectness of procedure. Second, if there is a suboptimal PCR, you can try to address that issue by making a pullback and finding out the areas where you can put a stent or other expansion. If it is a diffuse disease, leave it to the medical treatment. Now, we have several data to support the OCT usages. Most of them are from the registry studies supporting the OCT, but we have the recent Light Lab OCT study which used the MLD Max algorithm systematically. That workflow is excellent to be taken up into the cath lab for our own work. And then ACR also, the angio registration also has been used in this particular study, which will enable us to place the stent excellently, exactly in the lesion, which we decide to do. And this study has shown that when you use OCT, the decision making and the angioplasty strategy has been changed more than 88% compared to an angiographic decision. So that is why it should not stop with only a post-procedure OCT to see that you are done excellently well. Should start from pre-procedure, and pre-procedural OCT informations guide you through the rest of your angioplasty procedures. So I would conclude that FFR is the key in decision making of PCI, and post-PCI FFR identifies residual ischemia and pressure wire pullback can detect potential causes for the same, which could be addressed to get a good result when you leave the lab. For PPG, that is pullback pressure gradient, and PPG index are new physiological indices which could help to differentiate focal from diffuse patterns of coronary atherosclerosis, which is important and may have bearing on therapeutic implications. With the greater evidence of the benefit of intravascular imaging, the use of OCT will become routine for PCI procedures. So at the moment, it is not evidence-based, but I think the evidences will come. We are waiting for the Lumen 4 results to come, but that is not again going to address the usage in the routine cases. Synergistic use of OCT and FFR are integral part of precision PCI. Thank you very much. Thank you for the patient listening.
Precision PCI, that's something great about using both imaging and also the FFR post-stenting to look for the optimal results. So, Dr. Bolian, what's your recommendation? Should we have the FFR more than 0.9 post-stenting or expansion more than 80%, or both of the parameters should be there in each and every PCI?
I think, Rajesh, it is maybe difficult in all the cases, but our intention should be that when you do the angioplasty, if you could get a post-PCI FFR of 0.90 and above, the short and long-term MACE rate are probably the less. And the patient gets the maximum benefit of your procedure. We now know that even after the angiographically successful angioplasty, which we say that it's okay, 25% at least have got angina. That is because of the residual ischemia. And we seldom use the post, although I said the benefit of post-PCI FFR, the practical way of looking at it is much less in almost all the labs. It is difficult because now operator fatigue comes, especially when you do a complex case and then you wanted to take the FFR wire again and then do the post-PCI. But it is worthwhile doing that and looking for that, because if you find a low FFR at the end of your procedure, you better make a pullback and try to find out the reason for that. Many a time it has been shown that with IPCI and other trials, it has been shown that it may be a stent-related issue. It may be an underexpanded stent, which may not be visible from angiography. Well, you may find that optical coherence tomography or other intravascular imaging showing up. Even then, OCT sometimes will not be showing a diffuse under expansion. And then, you will get that, there is some areas where you have to do a higher pressure balloon or a higher size balloon inflation. So I think OCT helps you to have the minimal stent area obtained at the procedure more than 80% or 90% of the corresponding references points. But I think this should be done. And this is going to be a change. It's not the quick work which you expect from the operator in the lab. You take your own time in that case, do these things and get the best results so that the patient will not come back to you for again repeat procedures. That's why I said this is going to be well accepted in the cath lab procedures.
Thank you, Dr. Bhajan. If there is no further question, let's move forward to the next presentation by Dr. Rao. He's going to talk about role of imaging in CT or lesion. Dr. Rao, please.
Thank you.
Thank you.
Thank you all. First of all, my gratitude to the IPCI committee and Dr. Rajesh Vijayvargiya for giving this opportunity. As you know, CTO PCI needs a success rate improving. Now people reaching almost 90% success. And the outcomes will be better if you do the success rate further increases if you use imaging in selective cases. Like in my practice, I'm a dedicated CTO operator. I use now around 30 to 40% of my cases IVUS based. The type of cases come for a retry, complex failed cases, though the usage of IVUS will be more in such type of cases. But when you take in real world the IVUS and OCT, at present IVUS rules the CTO interventions because the OCT has got its limitation of real-time imaging with the crossing is not possible. The contrast limitations are there. And I think the last lecture showed some alternatives for the contrast. So these things improve and the penetrating power of the IVUS is better. You have to look into the side branches and everything. So only advantage is the resolution and quality of image. OCT is excellent. So if further modification in technology comes, OCT also can play a major role in the CTO PCI. So in the IVUS catheters, you have to choose the IVUS catheter. Suppose you want to do a side branch, I was looking for the proximal cap puncture. I think we should go for the low profile eagle-eye catheter. Now the Philips is managing that. Bulkier other catheters may not cost, but the NaviFocus is a very good low profile tip and navigating, but it's not available in India at present. So you have to choose the 20 megahertz eagle-eye catheter for this side branch positioning and the cap puncture, proximal cap puncture. And what are the possible roles of IVUS as pre-stenting? First, most important thing, the failure or success is 85% of the cases is the wire cross. The wire cross is most crucial. Everybody knows that the IVUS helps in the wire cross. Then after stenting, stent placement, and after that, they're detecting the complications. If you put the subintimal stenting on acute and long-term complications, you have to expect and look for those things. And the late vascular responses, aneurysm formations, those things after DES, like any other case, when you go to very high pressure dilatations in these CTO cases. So pre-stenting, navigating the virus. Like you, many of us know that the osteal lesions, particularly the circ and the left main angle and the LAD ostium, these lesions are most stumpless. These things are very difficult for navigating. So osteal CTOs, the IVUS guided penetration, ambiguous cap, and next is the keep the IVUS safely in the subintimal space with a low profile balloon. You can dilate and keep. People worry about that. Nothing will happen usually if you delicately manipulate the IVUS catheter and through the two lumen. So another thing is the vessel size, the complications, whether spasm or clot, and other things, the expansion and operation of the stent. As you see, the perforation, dissection, hematomas, and definitely reduces the radiation dose and eye load. So as I told, the strut fractures and aneurysm formation, the follow-up cases. The parallel wire technique, you can keep the IVUS in the other pulse lumen and cross with the second wire. This is one usage. Everybody knows these standard figures. I'm not pressing much. Now you see the IVUS in the side branch locating here. This is RCA, very comfortably. You can keep one of the conus branch and pull back this system. Then you can find a little large luminous. Calcium is a very important sign. And with the landmarks of the side branch and main branch, you can identify the plaque and guide your second wire. This is one case. I was in a side branch and the proximal cap with a pullback. You can see at the, exactly at the 10 o'clock position, the proximal guide. You can redirect the second wire and successfully do these procedures. And this is another case. A dual injection is given and LED and diagonal. You see the diagonal stumpless LED at the diagonal. But this case can be safely done if you keep an IVUS catheter in the diagonal proximal cap and pull back with this. There's already the collateral entered, but before entering the retrograde wire, I have done the IVUS. And in this case, I can see at the 9 o'clock the nice LED stump with little calcium. So with this, then we used the septal collators from the RCA for contralateral. This thing, the crusade assisted Gaia, we can puncture the proximal cap and 7 o'clock to 9 o'clock is the stump you can see. And this case we have done the completed the procedure antegradely after finding this. This another is angiographic 3D wiring. Suppose you see in this actually recently done case like this, my wire went into the false lumen. If you carefully see the long segment LED CTO, when I went to the caudal view, and the beauty of this thing is the changing the guide wire clockwise, anti-clockwise in different two perpendicular angles. That is the success of this wiring, and which the advancement is the IVUS guided.
Just click on the pictures.
Yes. So after this, we have done this successful stenting of this case, and now the latest advancement is the Japanese have done this. Now, not many cases done. I think the IVUS based 3D wiring using the advanced Navi focus. So all IVUS is a very low profile, and you can keep in the subintimal space and pull back. A long pullback is needed for this catheter, 15 centimeters, and low profile tip and transducer helps for it. You can form a 3D imaging. Reconstruct the images, and the advantage of the tip and shaft can be and reposition the second wire exactly into the true lumen. But how far it will come into the real practice, I think it's still at the experimental model. But I think in coming next future, it will really take up, and the retrograde procedures number may come down once it is very successful. The specifications of this particular IVUS catheter is a tip is low profile and a long pullback is possible, and it's got a monorail, two monorail systems. So that's the advantage of this catheter. And then is the IVUS in the retrograde wiring, very important. Unless you see the IVUS, the wire in the correct, what is the position of the retrograde wire, and don't externalize the wire. This is the principle what we follow in the retrograde wiring. So like this, in this case, a very tough case, a retry case, we have done retrograde with a knuckle wire technique. It's the anchor balloon on the antegrade wire, and the wire pullback retrograde wire pass after the IVUS imaging. You can see the, once you see the intimal clock, the retrograde wire, then you could complete the case. This is the success story with the successful externalization of the wire. Safety, very important. And this is the four patterns everybody knows. This is the standard picture. The most difficult is the retrograde wire in the intima and antegrade and subintima. These are of the subsets. Otherwise, we can dilate with the higher grade balloon sizing and externalize the wire. These four positions we have to remember whenever do any retrograde procedure. IVUS guided is very important. So this is a standard, another IVUS guided reverse cart, just I explained you already. This is one case I have done like this ping pong, this ipsilateral collateral. We took the help of ipsilateral collateral and completed the case. And it's very important when you do this case, you have to see the wires in the both in the lumen proximal part of the LED. Don't externalize into the left main. That can be catastrophic. This is the final result we got. And another important, we have done some follow-up of subintimal stenting. This is one case I've done after 4 years. I think this case done intentionally subintimal stenting. So I've done a follow-up. You can see the two lumen, how it is contracting, and the stent in the false lumen and the vessel is patent. So this is a very funny picture, but the patient is doing well. And the imaging for the IVUS, for the ADR, people have to select where is the re-entry zone and why you are failure to re-enter and confirm the re-entry. These three things are very important. And we can do a single entry also with IVUS guided. And finally, we find a lot of spasm and things distal to the stent after CTO PCI will get confused. So IVUS solves this problem. If you don't see any plaque, this like it can be a spasm. So you can safely leave that lesion. Then the intrapulmonary hematoma. These hematomas sometimes we have to squeeze either with a cutting balloon you can do, or you can aspirate with a fine cross catheter, or sometimes you have to put another stent for this hematomas. And the edge dissections, but OCT has got the advantage of this edge dissection. So I was done OCT. Now the OCT, I actually told that OCT got excellent resolution, but at present the limitations of contrast and anti-grade injections, no dedicated operator will give anti-grade injections in anti-grade CTO PCI. So this is another limitation, but OCT is useful in ISR CTO. And so you see, this is one case done in anomalous RCA CTO. We have done in a live workshop. This one after doing this, we could deploy the BVS, 3 BVS deployed in this case. And we can run up the beautiful pictures of the deployment of the stent BVS scaffolds and the model positions. We can see in OCT better than the IVUS. And as Dr. Aksaka has told this with his courtesy that this slide shows at 6 months the follow-up. OCT shows some of the CTO PCI, the maloposition, acquired maloposition rate is observed at 6 months follow-up. This you have to be careful about this. And definitely OCT has got advantage of showing the tissue coverage in CTO PCI and the maloposition. I think resolution quality is main advantage at present. There should be technology developed also to take advantage of the IVUS. Thank you. Hope I am in time.
Yes, Dr. Rao, thanks for a very illustrative presentation of use of intravascular imaging, specifically IVUS for the CTO intervention. Just one query regarding the tip of the IVUS catheter. The Boston IVUS catheter do have a 20 millimeter tip, and how do you manage this particular catheter for your CTO intervention, or do you have the 8 millimeter or 9 millimeter tip?
I got the eagle eye catheter I use for the most of the CTO PCI. Boston one little bulky for the side branch, and the long, as you said, the tip to transverse distance is a little disadvantage. But the picture quality is superb. I can tell if you ask me I want to find the wire position, retrograde wire position, or antigrade wire position, I prefer a Boston thing.
Which company it is? Which company's catheter it is?
Now it is Philips managing the catheter.
Dr. Akasaka, any comment about future development regarding replacement of IVUS with the OCT for CTO intervention?
Yes, thank you very much. Yes, as he said, Dr. Rao said, yes, we have an Terumo catheter, the very short tip and the mechanical scan. So the Japanese interventionists prefer to use an Terumo IVUS. So, and also Terumo tried to develop the a dual sensor system, so OCT with IVUS. If we have a dual sensor system, we can use the both advantage at the same time. So before the CTO opening, we use IVUS, and then after opening, we can do the OCT to confirm the condition. It might be the ideal. Yeah.
Very nice. Thank you. And let's move forward to the next presentation by Dr. Ajit Menon regarding use of OCT in calcified nodule. Dr. Menon, please.
Sir, first unmute yourself, sir, please. No, sir.
I'm sorry.
Yes, sir. Perfect. Now you can share your slides.
Thank you very much, everyone. Thank you. A big thank you to Dr. Rajesh and the co-directors of the IPCI 2021 for giving me this opportunity. And my talk is on calcium nodules and what you look for in calcium nodules. We do know that calcium has been the pain in most of the coronary interventions, and most of us who do complex coronary interventions realize that the outcomes with calcium, which is not treated adequately, is something which is always suboptimal. And even in acute coronary syndromes, there is a fair amount of calcified plaques that are seen, and they are normally they're normally detrimental as far as getting good results in these procedures are concerned. If we look at the impact of calcium, we end up with a lot of issues in terms of suboptimal stent expansion, device delivery failures, increased complications, and of course, we spend a lot of time in the cath lab trying to get optimal results out of these patients. Even in terms of acute coronary syndromes, where we feel that most of these patients can be treated quite fast and quite easily with either direct stenting or plain balloon angioplasty and then stenting, we do realize that in a fair amount of patients, we do have the eruptive calcified nodules, or you have calcified protrusions, especially in the elderly patients who have an acute coronary syndrome. And this is seen in almost 1/3 of underlying plaque morphologies in patients with acute coronary syndromes. And again, it can be a massive source of frustration in terms of trying to deliver balloons and stents if we haven't imaged these lesions, and we find that these lesions have an underlying issue as far as the morphology is concerned. This is an elderly gentleman who had a stent put in about 10 years ago. This happened about last year in the middle of COVID, and he came with an acute coronary syndrome. And this was the angiogram, which showed a heavy calcium chunk. And unfortunately, at that point of time, we did not have an OCT. We did try to use a intravascular ultrasound. We found that the entire vessel was calcific right from the ostium, and we realized that this is a chunk of calcium which is lying in the proximal RCA. That's something which we needed to treat. But at the same time, the issue was it was practically uncrossable. We could get a field XT across, but nothing else would cross. And we did not have the option of a laser also at that point of time. So we had to take a blind rotablator wire and managed to cross it, and cut it with a 1.25 millimeter burr, and subsequently 1.5 upsized it. Gendon with a 2.5 12 NC, and subsequently a 2.5 12 OPN NC, and then a 3 into 12 mm OPN NC balloon, till we got a result. We got a decent result. But what we can also see is that we did not end up doing an OCT on this patient. But even after an aggressive post-dilation, you still see that there is some element of underdeployment of the stent or an underexpansion of the stent in the thing. But just above the segment, you have a little ballooning of the vessel. So you're a little worried to post-dilate the stent any further. But anyway, this patient is doing well, so we have no issues at this point of time. In terms of the use of OCT to guide calcified lesions, if you look at pure nodular calcium or OCT and balloon uncrossable lesions, rotational atherectomy or orbital atherectomy is the treatment of choice. in these patients. And subsequently, you need to fracture the calcium to get a good stent deployment and get a final result on the OCT. This is a lady who had a cardiac arrest during the angiography, and was subsequently posted for a bypass surgery. But because of the cardiac arrest, she backed out of the surgery and she refused to undergo a bypass surgery. So we decided to take her up for a coronary angioplasty for the circumflex into the left main. And this was the lesion that we were looking at tackling. We tried to get an OCT here again, but as was expected, we could not cross the OCT into the segment. So they decided to go ahead and use a rotablator with a 1.5 millimeter burr, and subsequently did an OCT on the vessel. You can see that the entire vessel is quite significantly calcific. And at the ostium, there's a calcium nodule which has been partially shaved off with the burr. So angiographically, you have a good result. You have a calcium nodule here which is partially shaved off with the burr. So then the left main was quite well dilated. Now here the issue was whether we should take in a larger burr or whether we should use a high pressure balloon. In retrospect, a larger burr would have been a optimal thing to use, possibly at this time. But we went up with we tried to get a open NC balloon, but that would not cross. And we managed to get a Guidezilla into the vessel, and then use an IVL balloon, and sequentially did dilatations across the mid and the ostium, and then stented the ostial circumflex. After the ostial circumflex, we recrossed into the LAD. There was a significant pinching of the LAD at the ostium. It stented it as a tap technique. I did an OCT again, which showed that there was a significant malapposition and an eccentricity of the ostial circumflex. So went ahead and used a larger balloon to dilate this, and got a good result. Unfortunately, this patient came back within a month of the procedure, and came back with a acute restenosis of the ostial circumflex. I do not have the images here, but then it showed a malapose stent at the ostium, possibly because of the calcific nodule, which we had to go in and reimplant with using a 4 millimeter balloon at very high pressures. This is another example of an ambiguous lesion on a patient who came in with an acute coronary syndrome, and this was the circumflex lesion that we saw on the angiogram. She came in with paroxysmal nocturnal dyspnea, and ECG showed no significant changes. This is the angiographic thing. So what we decided was that we weren't sure this is a calcific nodule or a thrombus. And there were some financial issues. So initially we said that we'll try and put the patient on anticoagulants for a couple of weeks and then call her back. We repeated the angiography after the period, and we found that the angiography had remained almost virtually the same. And here we managed to do an OCT. And what we found in the OCT was quite surprising. That there was a calcific nodule. There were two calcific nodules, one in the mid circumflex and one larger one in the proximal circumflex, indenting the vessel quite significantly. But when we looked at the images, we realized that the lumen area at the level of the nodule was just about 5.87, and we were not sure that we would get a good shaving on the nodule using a rotablator, considering the size of the vessel. Hence, we decided to prudently leave the calcium nodule alone, and since the area was quite large, and we treated the LAD, which had two calcific nodules again on OCT. Did a rotablator and a cutting balloon, and subsequently got a good result. What calcium nodule can cause, as far as if we do not successfully recognize it, is something which is seen here, which look like not a very calcific LAD. Diagonal bifurcation. So we decided that we just wire both the lesions and use a balloon to dilate the LAD diagonal, and use a double kiss technique to deploy the stents here. But what we realized was that once we passed a stent into the diagonal, nothing would cross into the LAD. No balloon, not even a 2 millimeter balloon would cross into the LAD. So we had to retrieve the stent out of the diagonal, and we did an OCT at that point of time. And mind you, this is a gentleman who had a stent to the ostial LAD about 6 months prior, and a circumflex stent at the same time. And this was what we found on the OCT: a calcium nodule in the mid LAD, in the mid LAD, and that is the reason why nothing was crossing into it. And in this whole bargain, what we decided, since we had already caused a significant flap in the LAD, we did not think that we would take a rotablator down. We decided to take a Guidezilla inside and just treat the LAD per se, without treating the diagonal, and provisionally treat the diagonal if there was a flow compromise. This was the diagram there. We eventually ended up treating the LAD, got a stent inside, a little under deployment in the mid segment, but we post-dilated that. But what we realized on a repeat OCT was that though the stents were well expanded at the level of the calcium nodule and otherwise, we had deformed the ostial LAD stent, and that had completely got crushed into the stent extending into the ostium of the LAD. This probably we would not have realized it if we had not done an OCT. So we decided that we should go ahead and treat the ostial LAD with another stent, ostial left main with another stent, and this was this was the result we got in with that. So here, where the non-imaging and not understanding the morphology led us to complications in terms of having to leave a diagonal alone and distorting a left main stent because of the complexities involved with trying to deliver a device into the LAD. If I were to conclude, I would say that calcified nodules can significantly lead to suboptimal stent expansion, of course, device delivery failure, increased complications, increased procedural time, and of course, increased hardware usage. Thank you very much, everyone. And once again, a big thank you to the organizing committee.
So, Dr. Ajit, any comment about calcified nodule and supplementary therapy other than the rotablation for this type of lesion? What's your experience regarding routine use of, say, cutting balloon or IVL balloon following rotablation to have a good MSA across the calcified lesion?
I think as far as using cutting balloons and scoring balloons in calcified nodules is concerned, our personal experience has been that we tend to sort of dilate the normal segment more than the calcific nodule, and the calcific nodule remains where it is. The best thing that you can do is to try and shave it using a rotablator. We talk about getting a guide wire bias, etc. But that's much more easier said than done in terms of trying to get a guide wire bias to sit against a specific vessel, especially if the vessel is a large enough vessel. If it's a small vessel, you can still probably try and do it, but it's not, without the degree of experience that you should have, it's very difficult to get a guide wire bias. But yes, you can try using a cutting balloon or an angiosculpt or one of those scoring balloons, or even an IVL. But I think in most of these cases, what you do end up doing is dilating the non-calcified segment. The calcific nodule remains where it is.
Any further comment from the chair? If no further comment, let's move forward to the next presentation by Dr. Mohanty regarding role of OCT in acute coronary syndrome. Dr. Mohanty, please.
Yeah, thank you very much. And am I visible and my slides?
Yes, you are audible and your slide is
Thank you very much, Dr. Vijay, and the organizers for this topic. It's an interesting topic, and none other than Dr. Akash chairing the session. So this is a common algorithm we always see in OCT particularly. I'll not go into detail. We get different non-atherosclerotic reasons like SCAD, spasm, microvascular disease. Other than that, we have plaque rupture or plaque erosion as a major culprit for ACS, and we identify very adequately with OCT. Calcified nodule, we recently, just previous talk, we listened to Dr. Ajit, nicely demonstrated calcific nodule, so I'll not go detail into that. But is it so easy to do an OCT in ACS? This is an analysis one can say. There are poor image quality in 22 patients out of 289 and pre-dilatation required for an OCT acquisition because of the very critical disease of thrombus inside and the total occlusion of the artery. So there was 50, so it's a significant number. And in Indian patients particularly, we get a lot of thrombus, so it obscures the findings of OCT. So it's not very easy to take an OCT run in SES patients, and we, if we can take adequate images, we get beautiful pictures. And this trial changed our practice, particularly the erosion trial, which is a limited number of patients, but a very well organized and very well designed trial, which gave us insight. If you are getting erosion, plaque erosion, then it should not be with adequate lumen, it should not be stented, and plaque rupture by and large can be treated with a stent. And if you see, the plaque erosions are around about 30% and plaque rupture are 48% or 50%. Calcific nodules are limited numbers, 12%, and majority are superficial calcium, but calcific nodule can be very troublesome, like the previous cases we saw. This is a 31-year male, 1 hour chest pain with evolved interval MI, and LVEF was 52%, managed with low molecular heparin. Next day we took him for angio. Then you can see there is a very small area of proximal LED lesion. I'll skip the runs because of shortage of time. And these are the pictures we got. One can see there is very nicely seen thrombus. In presence of such thrombus, you never know whether it's a plaque rupture or it's a erosion. It's a probable rupture, a probable erosion probably. So it will not be very sure. But if you can get adjacent pictures like this, where there is a lumen which is irregular and thrombus adjacent, then you know it's probably most likely it's erosion. So we followed up the patients, gave them antiplatelets and DAPT in the acute setting, and followed up after 2 months with normal treatment. And this was the angiogram. One can see the follow-up OCT pictures. One can see very clearly this has become really stable plaque now. This is the previous one. If you compare, the lumen is much more smoother and a very stable looking lesion now. And the thrombus which was there earlier has gone totally. There was nothing, and a very smooth looking adequate lumen with minimal plaquing. So we know erosion, you can leave it alone. This is a 62-year male with a pacemaker and admitted outside with ACS. ECG was inconclusive because of pacing, and tropi was grossly elevated. There was infraval hypokinesia. We did an angio. One can see there is a proximal RCA, huge RCA with proximal irregularities. And when we saw this was the picture. One can appreciate nicely seen cavity. There is a thrombus and a plaque rupture in the proximal RCA, such a huge one. So it was initial days of my OCT acquisition. So I thought it's a rupture, so it should be stented. Though there was an adequate lumen, there was some residual thrombus. So I stented this patient proximally, and I did a OCT. So this is a gray area where when we have a plaque rupture of 15 days old and there is non-critical stenosis, we don't have any guideline whether to stent or not to stent. This is the third case, which is very interesting. 55-year female diabetic, no other risk factor, 6 sinus syndrome, and she has a pacemaker. She gets episodic chest pain. She was admitted with episodic chest pain with some elevation in inferior leads. And there were 2 episodes of polymorphic VT on the monitor, had to be cardioverted, and the LVEF was 60%. And we did an angio where we saw there is a tight disease after nitroglycerin and nicorandil. One can see that lesion looks really insignificant, very well grown up. So this we knew is a vasospastic angina. This is a nice study by Korean. One can see there's a 67, 66 or 68 odd patients were there for SCS. They've done vasospastic angina, particularly they've done OCT. One can realize OCT, you get definite erosion in 21% of patients, and lumen irregularity suggestive of erosion in majority of the patients. So same thing we did, and these were the pictures one can get. One can get a fibroscape disruption or a typical erosion or lumen irregularity, or sometimes a smooth lumen also can cause vasospastic angina. In our patient, one can see there is some white thrombus attached to the endothelium and very irregular wavy endothelium. So this was probably erosion with suggestive of thrombus causing recurrent vasospasm and polymorphic VT. So in view of VT and instability, we stented this patient, and the patient after 3 years of post-PTCA follow-up is asymptomatic. And we did a cardiac MRI immediately to look for any sarcoid or other things which infiltrative disease causing VT. So it was absolutely normal cardiac MRI. Now, we have these guidelines: plaque erosion with adequate lumen. We know it's medical management with DAPT and acutely GP2B3 or something. Plaque rupture are usually to be stented, but gray areas, when you have a subacute presentation after 15-20 days of MI, you get a plaque rupture with adequate lumen, whether it's to be stented or to be medically followed up. And plaque erosion, particularly with adequate lumen, with these unstable morphologies like presentation of recurrent spasm, SCS, ST elevation, or ventricular arrhythmias, can be left alone or should be treated. It's very gray. And this is another patient, is a female, 64-year female, non-diabetic, no risk factor with ST elevation MI. And immediately 1 hour after the presentation, the patient settled down, no chest pain. The lab reports were very inconclusive. Troponin was positive. This is a borderline mid-LAD lesion. One can see. So we did an OCT. One can realize there is a scared normal vessel with spontaneous coronary dissection with normal adequate lumen. The lumen was very good, 1.9 or 2. So we know this is the guideline by SCC. If you have a stable SCAD, it should not be stented, better to be managed conservatively. So we manage this patient conservatively with single antiplatelet beta blocker, kept her for 3-4 more days in the hospital to exclude any ventricular tachycardia or further elevation. The patient remains stable. So we discharged the patient at this ECG. The ECG was deep T inversion. After 2 months, we did an follow-up angiogram. One can see the follow-up angiogram is looking much better. It's the index procedure, and this is the follow-up angiogram looking much better. And the OCT run was done. One can see the hematoma has reduced to the edges only. The size has come down in middle. It is absolutely normal. You can compare the previous and the follow-up OCT. Very minimal hematoma at the edges, but rest of the areas were well healed up with a good lumen. But this is another patient with 45 years, not my case, is a borrowed case, 45 years male with no obvious CAD risk factor, acute onset chest pain with ST elevation. One can see the LED is totally occluded. So the operator did a thrombosuction and flow was established. And subsequent IVUS, there is a dissection, intimal disruption communicating to the hematoma. And you can see there is a dynamic compression of the lumen. There is a free lumen here. The OCT was done. One can appreciate the hematoma here with a very compromised area, 1.5 millimeters square with ST elevation, ongoing chest pain. So here there is a hemodynamic instability. This type of patients with SCAD also should be stented or revascularized, cannot be left because there is a chances of mortality in such patients if you are not treating them. So this was the final result after the stent. So SCAD are different two varieties, so it should be recognized. And if there is hemodynamic compromise or a lumen compromise, despite of everything, should be stented. A stent is not an absolute contraindication for SCAD even. So this is SCS with SBG graft. Very little we discuss about this. Is a 62-year male diabetic hypertension, SCS with lateral lead changes with unstable angina. This was the OM graft, hazy looking graft. One can see in different views. And this was the graft with a very tight disease. I did an OCT. One can see, you can see thrombus, but if you analyze these pictures, these are different from native arteries. One usually most oftenly gets this kind of vacuolations. I like to know the opinion of Dr. Akasaka on this also. There are perivascular vacuolations. This is probably an indication of vein, degenerative vein graft. And there are multiple vacuolations one can see with normal thrombus like on other ACS in a native coronary artery. We can get Ffr like native coronary artery. And the proximal segment, you see this is looking absolutely arterialized vein graft with a very stable looking thing. But look at the middle part where there is disease, there are vacuolations all around. So this is a finding unique to vein grafts particularly. And one can see if you stent, these type of patients, you have more chances of no reflow. So we did a filter wire PTCA or used a filter wire for that. And one can see there are tissue prolapse are much more higher in this kind of vein graft because there are a lot of muck inside and very friable tissue which can usually gets into the lumen. This was the final result. And this was a vein, another vein graft. I'll just take 1 minute.
Dr. Monte, will you like to conclude the session, please?
This is the way, yeah, just 1 minute, sir. There is a valve one can see, these type of vacuolations one can see, these are the vein graft, and the final result was good, and the vein grafts are unique in this. And we stented this patient with a lot of tissue prolapse, and the vein graft got little bit prolapse of the vein graft was there. There is a valve. So my take-home message on SES is OCT can image precisely the lesion morphology in SES, not only in native arteries, also after stent deployment. Different types of plaque disruption like plaque erosion, plaque rupture, calcific nodule, thrombus can be easily identified by OCT and treated appropriately. STAD is not uncommon and can be precisely identified by OCT, and indication for stenting or not to stent is well appreciated by OCT. OCT is extremely useful for non-atherosclerotic mechanism responsible for SES, particularly in MINOCA and its prognosis and its management. SBG grafts can be imaged appropriately by OCT, and graft degeneration with other features like Ffr, plaque rupture, venous valve can be easily identified and managed accordingly. Thank you very much for your time. I'm sorry I encroached upon 1 more minute of the next session.
Dr. Mullah sir, any comment about the management?
It's a very nice presentation, Arun. It showed us all the issues with ACS. I think I don't need to give my lecture at the end of the session. You covered it beautifully. But I think what we really need to know is which patients you don't need to stent now. And that is still a bit confusing. And in those patients, how to medically treat them seems to be the only question now.
So with this comment, let's move forward to the keynote.
Can I just ask Dr. Akashaka about the vein graft OCT?
Yeah, thank you very much. It's a very interesting find. I do not have personally such experience, but they may have the valve, and if there are some trouble at the vein valve, such may relate to the such findings, I think, because the inner side is not so rough. I think very smooth. Therefore, I'm not sure, but yes, very interesting findings.
So let me invite Dr. Akashaka for his keynote lecture on precision PCI utilizing imaging and physiology. As you all know, Dr. Akashaka is a renowned intervention cardiologist with great interest in imaging. He do a basic to advanced paper regarding imaging during the coronary intervention. He is presently working as a medical director of the TAMO Japan, and with the Department of Cardiology, I had the privilege to work with him regarding the imaging for the peripheral artery disease as well. So Dr. Akashaka, please.
Thank you very much for a kind invitation. I really appreciate Dr. Rajesh and the other organizer for this opportunity. I think, yeah, today my talk is Precision PCI utilizing imaging and physiology. I'm not sure my talk is fit to your request, but almost all my talk is already demonstrated by the other speakers, I think. And this is my disclosure slide, and I try to talk with these topics. Let's start the physiology for chronic coronary syndrome. As you know, the guideline demonstrate indicate the demonstration of ischemia if the patient have highly speculated the coronary artery disease. However, if it is not, they recommend the coronary CTA because of a high negative predictive value, as you know very well. Anyway, if you try to decide the revascularization, the guideline recommend to demonstrate the ischemia non-invasively or invasively. It depends on your condition. If you if you use physiology in cath lab, Ffr Guided PCI is better than the medical treatment. This is a FAME 5-year MACE report, and there are no significant difference in any cause of death. These data may not contradict the result of ischemia trial, I think. And this is the data comparison between resting index and FFR, and there are no significant difference in the prognosis. Therefore, based on these data, FFR and resting index are recommended to demonstrate ischemia as class 1A, and FFR guided PCI is as class 2A. But we have to pay attention to cutoff value. This is concept of FFR. This is a revascularized by orange, and this is medical treatment by a blue color. The cross point is now the 0.80. However, if you develop much more in the PCI, a cutoff point becomes here, and cutoff point for indication is 0.282 or 85, I'm not sure, in the future. If you develop the medical treatment, the cross point becomes here. At that time, the indication for PCI might be 0.70. Therefore, I would like to say cutoff value of FFR of 0.80 for PCI indication at the moment might change in the future depending on the development of PCI and or medical treatment. And let's move on the resting index. There are lots of resting index as shown in this slide. There are some difference around among these indicators, but clinically there are no significant difference. Therefore, you can choose any of one. And however, there are some advantage of IFR showing angio co-registration. This yellow one dot is the IFR of 0.01. And in this case, if you put a stent, short stent, 23 meter, you can save 0.20 of IFR, and if we put final IFR should be 0.86 because of the 0.66 and plus 0.20. And if you put a longer stent, you can save the 0.27 IFR, and final IFR should be 0.93. However, as shown in this slide, if you put the longer stent more than 30 millimeter, the prognosis might be depend on the total length of stent more than the FFR. Therefore, we select the shorter stent, and then the final IFR in the distal portion is here 0.85. It's very similar to our prediction. Therefore, the final prediction of the intervention by IFR is very wonderful in the daily clinical practice. As an advantage of the IFR is the serial stenosis. A resting index can demonstrate the same degree of pressure drop at rest in the proximal site in A and AB because of the similar resting flow. As shown in this slide, flow and pressure drop should be the similar at rest. However, during hyperemia, here in the bottom, the hyperemic flow is significantly greater, and compared with this condition, hyperemic flow in the proximal site is a little bit small because of the limitation of flow in the distal portion. Therefore, the flow pressure drop and should be smaller during hyperemia in case with serial stenosis. Therefore, I would like to say the resting indices might be better to assess each lesion severity for serial stenosis. So let's move on the ACS. This is a timeline of Ffr guided landmark clinical trial in ACS. Almost all is compared with IRA only versus complete revascularization. This is the most recent data named complete trial, culprit only versus complete revascularization. Ffr guided complete revascularization is better prognosis compared with culprit only, as shown in this slide. And this is the most recent data from our MY trial. This is the comparison between angio-guided and Ffr guided non-infarct related artery intervention. Ffr guide demonstrate a lower incidence of PCI, so we can safely differ based on this result, and the prognosis by angio-guide and Ffr guide is very similar. Therefore, the safety of deferral of PCI might be only one advantage of FFR guidance, as shown in this slide. I would like to comment the INOCA only one slide. The consensus document demonstrates the importance of an identification of INOCA, as shown in this slide, by FFR and also the CFR and IMR to identify the microvascular angina with or without vasospastic angina, as shown in this slide. So in the clinical practice, we have to pay attention to the microvascular angina as well. Let's move on the imaging. As you know, this is the best cutoff value of MLA by IVUS to identify the ischemia, and it demonstrates 1.9 to 5.9. So there are no big variation. And as you know, the OCT might be much better accurate, much more accurate in the measurement compared with IVUS. However, even by OCT, it variated 1.9 into 2.0. Therefore, the simple cutoff value of MRA cannot predict the ischemia, because the lumen diameter, not only a minimum lumen diameter, but also the lesion length and supply area may relate to the ischemia and the FFR value. So how to use the imaging to identify the ischemia? This is a recently developed QFR. QFR demonstrates a very wonderful correlation. However, there are lots of scatter. But if you use this after putting a stent, and if it is very poor, the prognosis is worse, as shown in this slide, QFR less than 0.89 in demonstrate worse prognosis as shown in this slide. Therefore, without pressure wire, we can speculate the prognosis of the PCI using this system. Another system is Angiography, also IVUS derived FFR, and also the OCT derived FFR. We can use these system in the near future. And CT FFR, as you know, it is very useful to identify the before PCI, the lesion severity as shown in this slide. And this is the recommendation from the Patrick, the review, right? By CT, we can identify these many things, and only we can use the catheter for the intervention as shown in this slide. This might be a very wonderful technique to use in our daily clinical practice in the near future, as shown in this slide, right? And then let's move on the FFR CT. This is the virtual stenting, and we put a stent here and improve the FFR in the distal portion, and we can obtain the pullback curve as shown in this slide. And how to use an PCI for the mainly the optimization guideline demonstrate the imaging should be considered for optimizing the stent as class 2A, and IVUS is only recommended for the rectomy lesion optimization as class 2A, and the instant restenosis condition evaluation is very useful by the imaging. And this is a meta-analysis for the randomized trial. There are many multi meta-analysis. However, in this case, the IVUS is superior than the Angio-Guide, as you know very well. And even if you use an IVUS, you try to get an optimal result, because compared with suboptimal result, optimal results demonstrate the better prognosis even in 1 year after, also as a long term after stent implantation, as you know very well, with a bigger MSA, lower burden, as shown in this slide. Now, how to get the optimal result? You try to select a quarter size bigger stent if you use the lumen approach, and quarter size smaller if you use the vessel area and vessel diameter, and the length should be decided, the reference site, and the distal reference should be burden should be less than 50% and non-lipidic. After putting a stent, if you use an IVUS, MSA should be at least more than 5.5 square millimeter, by OCT 4.5 square millimeter, or more than 80% compared with reference area. If you have an malposition, it should be less than 400 micron in distance and less than 1 millimeter length, and the distal edge already you discussed. The degree of this dissection might be less than 60 degrees and limited within intima, and length should be less than 2 millimeters, shown in this slide. This also already demonstrated the calcium. If there are calcium, the prognosis is worse than a non-calcified lesion in this data. And because the under-expansion may occur if the calcium is more than 180 degree and the very thick, as shown in this slide, and the polymer damage can be speculated if you try to push in aggressively through the tight region with calcium, as shown in this slide. Therefore, Dr. Fujino demonstrated the scoring system using calcium angle and thickness and length, as shown in this slide. And if the score is 4, we have to try to lesion modification using ablation. As you know, there are some recommendations, as we already discussed. Balloon crossability is very important. If it is close, you can use an imaging, try to identify the calcium condition. If it is not, you try to do the rotablator or orbitalectomy to ablate. And after imaging, if you have a very thick calcium, you try to do also the rotablator for lesion modification. After lesion modification, you try to do the imaging again to speculate optimal balloon expansion. If it is, you can obtain the expansion with a fracture, you can put a stent. However, if it is not, you try to use a shock wave, as shown in this slide. It is very important to confirm the calcium fracture, as shown in this slide. Because if you try to obtain a good stent expansion, making a fracture is very important. If you have enough fracture, you can obtain the bigger minimum stent area and good stent expansion, and it makes a smaller binary stenosis and smaller TLR, as shown in this slide. And the cutoff value for predicting the calcium fracture by the cutting balloon or higher pressure of non-compliant balloon might be around 500 micron in thickness. And not only diffuse round shaped calcium, but also the eccentric thick calcium is the problem. This is one of the examples. If you put a stent simply, you may have trouble in the diagonal branch. Therefore, we did an orbitalectomy and we succeed to ablate, and then we put a stent after making a crack, and then the result is very wonderful, as shown in the right-hand side, as you know, right? And another important findings is bifurcation lesion stenting. This already demonstrated the junior, I think, in the previous session. If you have no link at the side branch orifice and you succeed to select the distal branch, the result is very optimal. However, if you select the proximal site or the link at the side branch, result is suboptimal. And in a case with suboptimal, the jail strut is significantly greater, and it may make an instant stenosis numerically not statistically significant. Therefore, junior try to expand the number up to 600. It will soon finish. And also the bifurcation region, also junior already explained, right? This is one of the examples. It might be very difficult to identify by angio. Therefore, OCT is very wonderful to demonstrate the condition. And after POT, we can identify the good distal stent cell condition without any link and easy to cross the distal cell. And after kissing balloon, we can succeed to move the stent strut to the proximal site of the side branch. We obtain a good side branch orifice. Therefore, a good result can be expected. Finally, I try to talk about the ACS. Anyway, if you have the ACS, you try to do the angiography, right? As shown in this slide, if it is the atherosclerotic lesion, you try to decide the PCI. If it is obvious, ambiguous or non-obstructive, guideline recommend the intracoronary imaging to identify the plaque evidence. If it is plaque evidence, you try to do the PCI, and if it is not, we have to diagnose SCAD or Minoka, as shown in this slide. And we can identify plaque rupture, erosion, and cultural nodule by OCT, as shown in this slide. Also, the Slom's condition, as shown in this slide. even if it is the erosion, if you put a stent, as shown in this slide, you can obtain a similar result compared with the rupture. Therefore, it is one of the treatment strategy. However, as already discussed, if you try to use heparin with DAPT, you can reduce the erosion completely, about half of the patient, and the 50% reduction in 80% case. This is one of the possibility to use the thrombolysis and DAPT in erosion. And also, they are already demonstrated spasm might be the one of the cause of erosion, already discussed, right? And also the SCAD, this is also the one of the example. IVUS might be much more safer, but you can only identify the flap here. We cannot identify entry, re-entry, but OCT demonstrate the very beautiful image, false lumen compressed, the true lumen significantly, and the image wire is in true lumen to false lumen now, and then back to the true lumen. If we put a stent in this condition, you may cross the true lumen. And then we selected the true lumen again and put a stent. We can obtain the good recovery of the true lumen. Still, there are some false lumen, but it will improve, right? The incidence of SCAD might be different in the diagnostic technique. Therefore, but as I told you, IVUS is much safer than OCT. And this is a statement from AHA. They recommend imaging technology if the diagnosis is not unclear, right? And follow-up might be the CT is the best. And also, generally speaking, prognosis is better in SCAD. Therefore, the medical treatment might be the better. But if the hemodynamical unstable condition, you can put the stent based on the imaging. I finally emphasize artery-to-artery embolization. The culprit is proximal, and the occlusion site is here. This is one of the examples at the time of the admission and occlusion site here, but after thrombectomy, we cannot identify any lesion by angio, and the occlusion site, we cannot identify any lesion, only the proximal site is rupture and thrombs. Therefore, if we try to put a stent, we have to put a stent in the proximal site, not in the distal site. And also, the Minoka is one of the cause of the AMI, about 5 to 15%, and they recommend the MRI and OCT very well, and because compared with the occlusive condition, Minoka is better. However, the event rate is significant, and we have to differentiate atherosclerotic findings or SCAD or other condition as shown in this slide, because the treatment strategy might be changed. And this is the report at the AHA last year. They did an OCT and CMR finally, and OCT differentiate the cause as shown in this slide, about 46 patients, 46%, and CMR demonstrate the cause of MI 74%. And finally, they identified 84 cases, 84% cases of the ACS as the mechanism of an ACS by OCT and CMR. This is an example of the OCT, and this is my take-home message. Finally, the identification of myocardial ischemia is very important. As you know, the superiority of physiology guided PCI compared with angio guide is already knows very well, and coronary imaging may provide us the treatment strategy of the lesion, identify the physiology, right? And PCI optimization is the most important by the imaging, and INOCA and MINOCA should be investigated by imaging and physiology in detail to improve the prognosis of coronary artery disease. Thank you very much for your kind attention.
Thank you, Dr. Akazaka, for a precise description of precision PCI. You have covered each and every aspect about the precision PCI. Any brief comment about this translation of native coronary artery PCI with the bypass graph? PCI?
Yeah, bypass graft.
Yeah. Yes, please.
Generally speaking, I think the PCI for bypass graft, we have to pay attention to the slow flow and the distal embolization. At the moment, we do not have enough data, but an OCT give us some information to use in the distal protection or not a full expansion, right, of the stent. It might be very useful.
Any comment about functional assessment, IFR, FFR for the bypass graft?
Yeah, we can also apply in a case of when the chronic condition using yes, FFR and IFR, and especially another yes usefulness of the physiology for the bypass graft. In case with a higher FFR, I mean close to 0.75 to 80, if you bypass to the distal portion, the patency of the bypass is not so good. Therefore, if you haven't enough lower FFR or resting indices, you can recommend the bypass to the surgeon. Otherwise, yes, PCI might be another strategy to do. At the moment, guideline never told about described about such result. We have to take into about the value of the physiology, even if we identify and decide the PCI or CABG.
Any further comment from the chair, please? If no further comment, let me thank all the speaker and also the chairperson and the panelists of the session. And let's move forward for the last session regarding imaging exotica, learn from the master. And may I request the chairperson, Dr. Vijay Kumar, Dr. Balbir Singh, Dr. Sangat Velu, and Dr. Prakash to chair it. And meanwhile, let me also invite the expert panelists of Dr. Mohan Mani, Dr. Natarajan, Dr. Ankur Ahuja, and Dr. Raghav Sharma. Please.
Thank you, Dr. Rajesh. I think we've had a very nice 3-day session. We're coming to the last session, and it's going to be Exotica session. So we would be happy to invite you. Now, please go ahead with your presentation on imaging in coronary aneurysm.
Fine. So thanks. And let me go ahead without wasting much of the time. So this is the first case of mine. A 80-year-old male presented with acute inferior wall MI in August 2019, no conventional risk factor. Ejection fraction was 35% and mild hypokinesia of inferior wall. Left system was okay other than the proximal LCX, which was cut off, and the proximal RCA, the infarct-related artery, is 100% thrombotic occlusion. This is the angiogram after the plain balloon angioplasty with a 2.5 millimeter balloon, a large aneurysm in the proximal RCA with thrombus, for which OCT guided PCI was done with the drug-eluting stent 3 into 38 millimeter. As there was a thrombus across the proximal segment, a graft stent was not implanted. And this is the OCT run across the RCA after putting the stent across. The mean luminal diameter of the aneurysmal segment was 8.24 with the area of 45 millimeters square. And here we comes across the aneurysmal segment. So this is the stent in the center, and then you can very well appreciate the aneurysmal segment. The proximal and the distal part of the stent is well opposed and expanded across the RC. So just out of the curiosity, I had a check angiogram done at 15 months of follow-up just to look for how much the increase in the aneurysm is, whether it has regressed or increased, whether to continue with the dual antiplatelet therapy for the long time or not. And this is the angiogram which did show it good flow, good T3 flow across the RCA, and there is an aneurysm which to a certain extent has increased compared to what it was 15 months back. And this is the fluoroscopic you can very well appreciate there is a type 4 stent fracture with the dislocation of the proximal and the mid part. It's a 338 millimeter stent across the RCA, which got fracture in the proximal part. There was certain difficulty in wiring the fractured segment, and ultimately I could very well wire it, dilated with a 2.5 followed by 3.5 millimeter balloon. And this is the OCT run. So distally, and now you see the part of the stent is eccentric, not over the wire. So distally, I did enter from the aneurysmal segment to the distal segment within the stented part. So part of the stent is outside the wire, outside my balloon catheter by which I had dilated. Let me again run it. Just see this particular part. We are now entering into the aneurysm, and the part of stent is eccentric. So this is the entry, which was somewhat difficult, and ultimately I have entered within the lumen, exit from the lumen in the aneurysmal segment, and again enter distally in the lumen of the right coronary artery. So it's a 3.526 millimeter graft stent when deployed across the right coronary, post-dilated as per the dimension of the OCT. And you can very well appreciate a part of stent, the old stent got excluded from the stented segment, this time with the graft stent. And this is the OCT run. You can very well appreciate the eclipse sign where there is no arterial layer beyond the stented segment. Let me again run it. So this is what the distal normal segment with the stent. This is the eclipse sign. You do a graft stent across it. And here comes the proximal segment. This is the run of the graft stent across the right coronary, well opposed, expanded. This particular patient had an asymptomatic 2-year follow-up. And let me go ahead with the second case, a 71-year-old ANCA positive vasculitis patient presented with antival MI in February 2020. And you see, there is a thrombus in the mid part of the LAD, and the diagonal, a big diagonal is arising from the aneurysmal segment. This particular patient had an angiography outside and was referred to the PGI, to our institute for the further revascularization strategy. After having a look on the angiogram, I started tirofiban, and it's after the tirofiban infusion, a check angiogram was done to look for. So there is no aneurysm, and there is a big aneurysm across the mid part of the LAD at the bifurcation site, and the ejection fraction is normal with no RWMA. So it's a viable myocardium across the LAD territory. So after discussing with the cardiac surgeon, it was decided to have a trial of, say, PCI. In case it do fail, then let's go ahead for the coronary artery bypass surgery. Putting a graft stent across LAD to LAD is going to decrease the flow, occlude the diagonal origin from the bifurcation site, and there is a possibility to have a retrograde flow across the diagonal, filling the aneurysm. So this was a concern, not a simple case to go ahead for the graft stenting. So ultimately, it's a 7F guide which was taken to cannulate the left coronary system. The proximal tight segment of the LAD was dilated with 2.5 millimeter balloon, and this is the result after balloon dilatation across the proximal LAD. And let's have a run from LAD to LAD of the OCT. So this is the distal segment, doing well, disease-free. Here comes the aneurysm, a big aneurysm. This is the proximal segment, which has an iatrogenic dissection following balloon dilatation. And here comes the run of the diagonal, disease-free diagonal, aneurysmal segment. And here is the iatrogenic dissection. It's a fibroathyroma across the proximal LAD. This is the IVUS run across LAD to LAD. Here is some calcification at 12 to 3 o'clock in the aneurysmal segment. This is the proximal LAD, somewhat calcified. It's a fibroathyroma, which is now evident over here. And here comes the run from diagonal to LAD. Diagonal is disease-free. And here comes the proximal LAD, which is again somewhat calcified, and the fibroathyroma. So this is what we are dealing with. I went ahead and put a 4 into 28 millimeter DS from LAD to LAD. And before that, I trapped a microcatheter in the aneurysmal segment. So this is the stent across mid-LAD. Distal to the stent, there is some dissection for which another stent 3.515 was deployed with a good flow across the LAD. The diagonal was wired. So here, if you see, there is a wire in the LAD, another one in the diagonal, and the third wire, which is on which the microcatheter is there in the aneurysmal segment. So diagonal dilated with a 2.5 balloon, and then 3 into 28 stent was deployed from LAD to diagonal as a culotte stenting. Thereafter, a coil 6 into 22 millimeter from Boston Scientific was deployed in the aneurysmal segment. And this is what the result is. As per the dimension of the imaging, the stented segment in the proximal LAD and also in the distal and the diagonal were dilated. The aneurysmal segment was dilated with a kissing balloon 2.5 east to the LAD and also to the diagonal. Port was done with a 5 millimeter, 4.5 millimeter balloon across the proximal LAD. And this is what the final result is. The part of aneurysm got occluded with the coil, and there is a residual segment of the aneurysm, which is small in nature, and possibly there was a septum between the whole aneurysm, and therefore the coil couldn't get advanced to the other segment, which was adjacent to the origin of the diagonal. And this is the OCT run, LAD to LAD. Well opposed stent across the distal LAD, distal to the stent. Here comes the aneurysmal segment with the two culotte stent can be very well visualized, and this is the proximal segment of the LAD. Let me again run it. So there are the two, and in the horizontal bar of the OCD, you can very well appreciate the coil, which is there at the 6 o'clock. And this is the run across diagonal LAD, well opposed stent distally in the diagonal, two layer of stent, two circle of stent across the aneurysmal segment, and this is the proximal LAD segment. Here comes the run of LAD by the IVUS. Let me move the aneurysm. Well opposed stent. And here comes the aneurysm. At 6 o'clock, there is a coil which is lying. Two circle of both the stent been deployed as a culotte technique can be visualized over here. Here comes the LAD, proximal LAD, well opposed stent. This is the run about the diagonal. well-opposed stent. Here comes the aneurysm. And this is the proximal LAD segment. So at 6 months of follow-up patient and the check angiogram done, we showed the occluded part of the aneurysmal, both the LAD and the diagonal is patent. There is some residual aneurysmal segment which is there adjacent to the origin of the diagonal, which has not increased with the time. And these are the various used to demonstrate the thing. This particular patient had an asymptomatic 12 months of clinical follow-up, presenting on the dual antiplatelet therapy and also for the treatment of vasculitis. Thanks for the kind attention.
Thank you, Dr. Rajesh, for those two excellent cases. I think the second case was very nicely managed with the coil and 2 stents. I think it has been described very well in the literature about using coils to particularly to manage aneurysms near the bifurcation. But it's very well demonstrated with the imaging pre and post and with the follow-up angiography. So congratulations to you. And the first case, I think the first case, there was a lot of malapposition. I think there probably the segment of malapposition could have left alone without a stent. Because the second time when you had a stent fracture, absolutely there is no choice but to use a stent graft, which gave a very good result. I think that was a good result. But in the beginning, don't you think we could have excluded the aneurysm without a stent? What is your thoughts on this?
No, I couldn't get the point. Without putting the stent, let's do the plain balloon angioplasty on.
No. What I was trying is, if we just stent the area where there is no aneurysm, leave the portion where there was a huge aneurysm. Because I just thinking that I just believe that leaving a vessel without a stent is much better than putting a large vessel. You put a malapposed stent. So that's what I was trying to tell. Just leave it like that and stent only the areas where the vessel was normal.
So it was a distal segment and the proximal segment, both were disease. Either I could have put the 2 stents, one distally,
yes,
and one proximal. That's a good idea. Yes, that could have been done, but then no. I did put a single stent from say proximal to distal LAD.
So one small comment, sir. So this is very nicely done. And one small problem here. See, IVUS or OCT is not going to show the full extent of your aneurysm. Sometimes aneurysm usually is very big. What you see is it is a thrombosed aneurysm with a lumen in between. And we had a similar case, came with inferior volume, and everything was done. Then in the end, we thought maybe we should do a CT imaging. And it was actually a 5 centimeter aneurysm. It was not a small one. So I think maybe sometimes before we do intervention, better to get a CT imaging done. That will tell you I think you were both the cases. We were able to see with IVUS, right? Except a small part in your LAD. But it is a good idea. And another good thing is no thrombus inside in your case.
No thrombus at all.
No thrombus
and also,
at all.
Vijay, it is nicely, the coil, after coiling, the aneurysm
it is
nicely shrunk and it is not extended. So it is a fantastic on follow-up.
Sometimes, as we see in aortic aneurysms, what you see is only a thrombotic part we don't see at all in the angiogram or this thing. And IVUS, unfortunately, maybe not a big enough tool show the full extent of aneurysm. Maybe a peripheral IVUS might have helped. I'm not very sure. Just the thought.
But then, fortunately, I could delineate both the aneurysmal wall with the imaging. And instead of going ahead for the CT angiogram at follow-up, I thought, let me go ahead and do the check angiogram. For the second case, it's a coil which is going to give the artifact for the CT angio. So then I prefer to check angiogram done. And for the first case, as I left the aneurysm, I just want to have a look on what's going on with the progression of the aneurysm, or whether it has regressed instead of going for the CT angio.
Yeah, and another thing, leaving such a stent in the aneurysm is one of the well-known cause of fracture actually. when the stent moves on both the sides and it fractures.
Absolutely.
And what is another interesting thing is you have a 2-year follow-up of the stent graft, which looked good. We all are always concerned about putting a stent graft and the risk of stent thrombosis. But I think you've clearly shown a 2-year follow-up after stent graft. That is also very interesting. So can I have the comments of other panelists, if any, or we'll move to the next case?
Dr. Sengutelli, can I make a comment? I'm Dr. Natarajan here.
Dr. Natarajan, please go ahead.
I fully agree with what Dr. Sengutelli told about the first case. The stent was actually from the proximal RCA to the distal RCA across the aneurysmal segment of the RCA. So I voice the same opinion that Dr. Sengutelli also said. There is going to be significant malapposition in the aneurysmal segment. So I was wondering whether in the index procedure itself a covered stent would have been a better choice. And with the inherent risk of thrombosis, like what Dr. Sengutelli said, that's what I fully endorse his opinion. In the second case, aneurysms are three-dimensional structures. It is not that it is in one part eccentrically, like what was shown elegantly by Dr. Rajesh. And his idea of coiling was truly an exotic intervention befitting the section itself, which is called exotica. But we should understand that it's a non-covered stent. So there is still going to be flow into the aneurysm. And the coils are there only in one aspect of the aneurysm being a three-dimensional structure. So, and that is exactly the reason why during follow-up, the aneurysm was still patent. The aneurysm was still there, though, as Dr. Rajesh very correctly said, it has kind of appearing smaller than the previous. I just wanted to know, being a three-dimensional structure, a coil in one aspect of the aneurysm, whether it will really create problems during long-term follow-up. That was my concern.
So regarding the first case, because of the thrombus itself, at the first go, I did not put the graft stent as there is an inherent risk to have stent thrombosis. That was the only reason not to go ahead for the graft stent, but there was a marked thrombus. And later on, of course, we did put a graft stent. Regarding the second case, yes, at the first instance, there was a partial occlusion of the aneurysm. I couldn't block whole of the segment. And other option would have been to put another microcatheter through the clot stenting to the 12 o'clock position of the residual aneurysm, put another coil, which I did not try because of, say, dislodgement of the coil across the stented segment and in the native coronaries. There was a residual aneurysm, which of course did not progress at the follow-up check angiogram, and then patient is doing well at 2-year follow-up. Sorry, 20 months of follow-up. So that's what the plan. Yes, initially when I did try to put the coil, I thought I'm going to cover whole of the aneurysm with the coil, but then it's partial coverage. But patient did well, and check angiogram also did show no increase in the residual aneurysmal segment, which was not been coiled.
Truly extraordinary cases, sir. Very good cases.
Thank you.
Thank you, Dr. Rajesh. So let's move to the next presentation. Is Dr. Matthew there? I couldn't see him. Is he there?
Dr. Matthew is not there. Dr. Sangat, let's go ahead for the next one.
Okay. Now we invite Dr. Pratap. I think Pratap, I can see him smiling. Thank you, Pratap. Please
I shared my slide also already.
Go ahead, Pratap. I thought ISR, but the moment we see you, we only see CTO, but you are showing something in the ISR.
Basically, no, the topic was actually given to me in the paper. It was in a calcium. But today morning when I saw it is actually a CTO PCI follow-up. Actually, I was really wondering that OCT follow-up or CTO PCI. So I took one case and showing it is not like so exotic as Rajesh case naturally, but let me try to show a minimum exotic case.
So Pratap, is it a combination of ISR CTO?
It is an ISR CTO.
Very nice.
That is what actually you wanted. Okay. It is a 31-year-old female, unstable angina, post-cabbage. Patient has undergone bypass surgery in 2012, that is at the age of 24 years. Cabbage done for an LMCA disease of 95% of LMCA. EMD was positive that time, and the patient was actually having echo and trival hypokinetic. This time, the patient is admitted for a CAG plus an adult PCI. Diagnosed case of Takayasu arthritis, anemia, no other vessel disease other than the coronary disease. This was the angiogram. Angiogram is actually at the admission post CABG at the age of 31. The patient came to me. I was trying to do an angiogram. I could not see anything. I was really in trouble, not able to cannulate the left system. But the patient actually has a right coronary artery. It is actually left is totally occluded, and the lima graft is also gone. So the patient is actually having a totally occluded vessel. So the point is actually, I thought I will try passing the wire from the right system to the left system. I took a caravel. You can see the caravel with the filled Fc wire. You can see the filled Fc wire is coming down, and the caravel is also there. I thought I'll take through it is excellent collaterals going to the LED system. So the wire is going up. You can see the wire going up. I know it is an imaging meeting, but it is interesting case. Anyway, the wire is going up. You can see the wire jumped up into the LED. That is actually to the distal LED. So once the wire jumped, I could easily take the caravel up. It is a filled Fc wire. Usually I take a cyan black there. The wire went inside and it is almost reaching up to the left system. So I took now the catheter. Catheter was a difficult problem. A 7 French GBU, 3.5, I tried to cannulate. And I tried cyan black, nothing is not able to cannulate. So the cannulation was so difficult. So I thought actually I will try a 7 French JL 3.5. Instead of EBU, I went with a JL 3.5. I could even take the caravel outside, but I could not take it out. So I thought I'll take a snare. And I tried snaring, again I failed. There is a different angulation and there is no chance of snaring also. Then I thought, you can see that antegrade wire. You can see that antegrade wire filled XTR. I thought I will blindly pass the wire with keeping the microcatheter there, but I failed. Then what I did is actually I tried a UB3 wire tried retrograde so that I will be getting a better control of the system rather than a filled Fc. There also I failed. So I thought the next choice is actually taking a different septal channel. So I thought actually I took a different septal channel. So I tried entering the septal channel again. I was successful in taking a septal channel again. You can see the septal channel is almost like very near to the septal artery. Then I tried. Again, I failed. But by the time what actually happened, I just passed multiple times the caravel. So caravel created a path of small. So when I injected from the antegrade, I could see a flow, a faint flow there. Once through the faint flow, I actually tried to keep my catheter there. With that catheter, I tried an XTR wire. Now this time, actually I could not. Though with this wire, I just tried an XTR wire. XTR wire entered inside, but it went into the OM branch. By keeping the wire there, I took one more wire and passed the wire into the circumflex artery. So I had two wires inside. I dilated with the balloon 2.5 into Maverick balloon. Once it is opened up, I took an XTR wire. Now you can see that I took an XTR wire. Through the XTR wire, I went into the LED. Once I wired into the LED, then it was simple. But then the retrograde system is totally removed. I have two wires, one into the OM, one into the LED. The retrograde system is totally removed. So then next is actually, I did an IVUS in this case. So this is the IVUS now. I could see that there is a plaque in the ostial LED. There is a plaque in the ostial LED. You can see it is not like a normal picture of a that's indema media. It's a Takayasu disease. I am also seeing first time an IVUS picture of this thing.
Medial involvement.
Yeah. Very interesting picture. So this is the way it is seen from the osteoproximal part. You can see there is actually the plaque in the ostial LED. You can see there is some vasa viscera there. The distal reference we measured as 3.24. So we thought we will actually put a stent of 12 and plus 9. Actually, there is a 22 millimeter. So we took a flex tom to dilate that. We could not, I don't know whether it's a cutting balloon. Cutting balloon used in Takayasu arthritis and carotid artery. So I decided to take a cutting balloon there and dilate it very well. And then I took an IVUS. Again, IVUS actually, you can see there is a dilated vasa vasorum. This is a picture. Any comment anybody wants to tell can tell, because I am not aware of these things much.
It is not very much typical of Takayasu. Takayasu, any vasculitis, you should get a loss of vessel architecture. The 3-layer structure you should not see. But here, most of the areas where you showed, you could see a 3-layer architecture.
No, but actually, if you are coming to the proximal part, Vijay.
Maybe osteum, I'm not very sure, but all the other places we can see the 3-layer architecture.
This part is actually just look like what is
yeah,
this?
maybe. And the other one is most probably a venous structure.
Yeah.
So
okay. So then I decided to get 3.5 into 26 resolute onyx stent. I position the stent in various angle and just position the stent. After that, we did an IVUS again to understand whether it's luminous. You can see that actually.
Here you can just see that 3 layers. You can see the
the distal part actually we could see. When I'm just telling about the osteoproximal part of the LMCA part, that is what I'm just.
Sure. It's very nice.
This is stent placement. This is ostial circumflex. So there is some under expansion. We cannot tell it is a huge under expansion. But even then, we just took this ostial LD is 8.28 and 10.76. We got a reasonable distal edges, actually no intersection. We took a 4 into 8 millimeter Maverick balloon and finished the case. So this was the final shot. So, but the story does not stop here. The patient actually, the angioplasty was done in January. There is a COVID vaccination was done on 5th of in the May 20th. The patient came with an NSTEMI of 25. Normal LV systolic function.
We were expecting this one.
This is what is actually I just wanted to show. So this was the point. So the total occlusion of this one. So why it was expected and what is to be done otherwise?
Yeah, it is very, very common to have this type of restenosis and vasculitis. And we have seen patient, I think, somewhere turning into left main and RC osteum. Within 2 months, he came back with a tight restenosis of both.
I have had also a similar experience. I've had a same thing treated with PCI, get a restenosis, sent for CABG at the end. So it's quite common for Takayasu arthritis to have recurrent
occlusions. But it doesn't happen in coronaries alone, even peripheral it happens.
Yeah. So this is actually when again the wire is passed, because you have to do something severe angina for this 31.
Yeah.
So the wire passing is very important because you have to take in a very, very real coaxial, otherwise you will be totally So
Pratap, at this point, would just for the sake of discussion, would what about the view of others, Natarajan, Vijay, Dr. Rajesh, and would you consider CABG, or do you think you would do again?
And the only problem is this lady might be having a subclavian disease also.
Subclavian is also disease.
And unless you are giving an arterial graft also, we are not very sure how the grafts behave in this patient.
Already the graft is done.
I'm just telling, even if you do
it's already done. Okay, second.
Post CABG patient.
Yeah. And that also we are not very sure.
And as expected, Dr. Pradap very intelligently showed the subclavian artery angiogram also in passing during the sequence of this angiogram.
No, not only that. No. See, Natarajan, what you should understand that this patient was actually undergone a CABG first.
I agree. I understood
that. When the proximal occlusion, actually I have just shown again, anyway the lima is already put and lima is occluded. Now there is another possibility, rima LAD is the second possibility. And otherwise a vein graft. So these are the possibilities. And we just came, this patient came, we did actually, the wiring is done. I put a wire into the circumflex also. These are all not big things. The 2.75 into 12 millimeter balloon, I dilated. I just wanted to show the OCT. This is a pre-OCT. So the pre-OCT is showing this leg. lot of intimal hyperplasia.
Yeah.
There's a lot of intimal hyperplasia. This is after balloon dilatation. You can see the ostial LAD shows a 1.93, the tightest LMC MLA of that part, and is totally diseased. And throughout, this is the picture of the OCT picture.
Yeah, aggressive neointimal growth.
Aggressive. It's only 3 months. And actually, we prepared the patient even with a flextome initially.
Yeah.
So we did again a flextome here, dilated very well. And then I did an OCT after that, before doing anything. Actually, we opened up. I could not see this is very well opened up. Then what I did is actually a 2.7512 Maverick balloon into circumference and a 4x20 magic touch. Just I thought this time I will be a balloon and then this is the final angiogram. And we did an OCT run again, the final OCT run. We got an MLA distal is actually, MSA distal is 6.76. The 9.7 is the area we got. The area.
Anand, can I request others to mute your mics, please?
Yeah, please. So we got a 9.94 is the area distally, and we got a very reasonable expansion, but I cannot tell that the patient will come back again. This is the picture of the OCT picture again. Very well opened up. So the OCT imaging in CTO has a limited role. During CTO intervention, to understand the expansion, apposition, and edge dissection of the stenting can be identified. During follow-up, to understand the reasons for ISR and solution for which can be identified by OCT. Thank you very much.
So what was drugs he is on? Is he on any immunosuppressants at the time?
Yes, this patient is on Visalon only, but the ESR is only 4.
Okay, so disease is not very active.
No, nothing.
But then Tachyosis arteritis, even if as elegant an operator as my very good friend Dr. Pratap does, is known for malignant progression. Whoever does the case, the vaccination, COVID vaccination is just a coincidence, I personally feel. And as Dr. Vijay rightly said, do not go only by ESR. There are other macrophage dependent phase reactants, etc. This patient needs to be aggressively immunosuppressed with drugs like mycophenolate, etc. You should use real expert immunologists also to help you in this case.
Is actually on a rheumatology follow-up. No, Natarajan patient is on a rheumatology follow-up for a long time for the TACAS otherwise also.
Maybe no, the patient needs more further aggressive treatment from the Tachyosis arteritis point of view also. You having done such an elegant job, I will be very happy if this patient continues to have a patent left main even after many years. And to that effect, what I wanted to stress was you have to be too very aggressive in this patient beyond just steroids is my personal opinion.
Yeah, that's a good point, Natarajan. I think that's fine. Thanks, Dr. Pratap, for sharing one nice case showing a good case of ISR and CTO. So let's move on with the IOPTICO study from Dr. Vijay Kumar.
Sir, I think we skipped the talk, so we just listened to it many times. I don't think it makes any sense. Maybe Chief can present his case and we'll come.
Okay, can I request Dr. Ajit to give his presentation on ACS, please?
I think a lot of things have been said by ACS. I'm well beyond time. I'm just going to show one simple case where we show you what we should not do in a case why we should not intervene. And this is something which I've always been talking about. And this case is a nice follow-up, so it tells you what not to do. This is a 27-year-old gentleman, came with non-ST elevation MI. His troponin was 0.89. Family history of CAD, active smoker. And we stabilized him with low molecular weight heparin, aspirin, and clopidogrel, and took him up after 24 hours for the angiogram. And you can see in the angiogram, and you please be looking at this angiogram very carefully, you can see a lesion, obviously, right at the ostium of the LAD. The vessel is a bit large and ectatic, but you can see a lesion right at the proximal ostium part of the LAD. So there's disease there. This is about 2 years prior. And when the angiogram showed a non-flow limiting disease, and it was just non-ST elevation MI, we tended to treat the patient only medically. We didn't do any imaging at that time. So we thought this was a thrombotic osteoproximal LAD with some thrombus. You could see the septal was full of thrombus also. We just kept the patient on dual antiplatelet therapy, high dose statin, low molecular weight heparin for about 72 hours, and he was kept on medical treatment. 2 years later, he came back and he continued to smoke, and that is important for us to understand. And now you can see that there is a proximal ectasia again, but the lesion has shifted. It is more towards a diagonal and not towards the proximal ostial part. And you can see the shift of the severity of cystinosis from proximal to more or less proximal mid of the LAD. Again, we continued the antiplatelet therapy, knowing very well there is a lot of thrombus there, and low molecular weight heparin, and we underwent 24 hours later. Now, just to tell you, we are now looking at all these parameters because we always feel that investigating at the time of the index procedure, we think that, oh, there is a plaque erosion or there is a plaque rupture and there's some thrombus formation, and we think everything is local. But the problem is that atherothrombosis is a systemic problem. And many of the systemic problems can cause, we also know the natural history of plaque erosions and plaque ruptures. Almost all of us will be having erosions and ruptures daily in our coronaries, but they don't thrombose. And only when they thrombose and close the vessel is when you get non-ST elevation MI or STEMI. So the natural process of natural thrombolysis in our body endogenously is looking after our system very well. It is only at a particular time when things go wrong, especially when there is an inflammatory state, especially when there is a prothrombotic state, which is very often seen in our patients, that in our young patients, that they may clot and create a problem. Now look at this patient's lipoprotein A was high. We know that lipoprotein A is a factor which is not only proatherogenic, but it is prothrombotic, because it affects the endogenous fibrinolysis. Being a smoker, his homocysteine was high. We looked at most of these young patients. We are now looking at many of these anticoagulants and many of these activated proteins and factor V ligands. And we found that except for lipoprotein A, which is high, and the homocysteine, which is high, this patient was otherwise okay. But obviously now we have a systemic inflammatory state, which possibly because of smoking and a higher hyperlipidemia. So after the 2 to 3 days of anticoagulation, the patient was brought back. And you can see obviously the vessel is looking clearer even between the 2 days. And you can see the typical, we have seen these pictures again and again of a possible erosion because there is red thrombus all through in the proximal and mid LAD with the adequate lumen. I'm showing this very simple case, it's nothing exotic, because we would have tended to put the stent in the wrong place if we had started off on the first time by blindly not knowing imaging and thinking the lesion was in the proximal LAD, and the patient would get a problem in the mid part of the LAD later on. So it's important, in my opinion, and we have multiple cases like this. I don't want to show more pictures in the interest of time, that we now tend to treat these patients very systematically with medicines. And we are using now rivaroxaban and after 1 month, the patient is on a rivaroxaban and a single antiplatelet. Again, with the use of atorvastatin, because this patient has lipoprotein A, which is high, we did use atorvastatin, and because the homocysteine was high, we use folic acid. But if the LDL levels are very low, and they don't have homocysteine issues, I think we may even leave these patients on rivaroxaban alone in the long term. We don't have large data, but Vijay is doing a systematic follow-up. I think is about 38 to 39 patients like this with anticoagulants. I just wanted to show this case to show you how we should not stent many of these patients because you will stent the wrong place and without knowing what is underneath. Thank you very much.
Thank you, Rajit. It's a wonderful case to clearly demonstrate the importance of imaging and to understand what is going on inside, and most of the time avoid a stent in such situations, particularly in young patients. So, is there any comments or any points for any other panelists or chairpersons? Dr. Balbir, you want to say anything?
Yeah, Ajit, One problem is that when there is a red thrombus and the thrombus burden is so high, so it becomes very difficult to remove that thrombus and look for a rupture or erosion. You're at loss, you don't know, behind the thrombus there may be a rupture, and you basically at complete loss what is to be done. I agree the approach is correct that you try to lyse the thrombus and take the patient back to do another OCT. But how many patients agree to get a second procedure is also a question. So in the index procedure, if you find a red thrombus and you're not able to remove it fully, you're at loss to decide whether there is a rupture or erosion. And what do you do in such a circumstances?
So I think one thing which I look at is the Timmy flow and the lumen. If the lumen is less than 2, the vessel will close on you after what you have best done on the table. So I would possibly think, because the deferred stent strategy did not show any better outcomes in those patients. But if the lumen is large, and this patient had a very large lumen, I think 6.4 or something. So clearly we can leave these patients alone because the flows are pretty good and this vessel is not going to close on you. Initially, we used to do angiograms and do OCTs. Even Vijay has a small series of follow-up OCTs at 6 months. And they all look great with just anticoagulation and small. We used to use warfarin before, and now we have shifted to rivaroxaban. And I think that it's an interesting group of patients. And I agree with Ike Jiang that erosion 1 study showed clearly that if you stent these patients, they're going to create problems rather than not stent these patients. So I think in short, whatever it may be underneath, maybe it's a erosion or a small plaque rupture. If you're not sure what is underneath, and if the thrombus is large and the lumen is good, it may be better just to leave the patient on medical treatment. Now, what is that optimal treatment? I think if there is a lot of red thrombus, I would tend towards anticoagulation. You could use warfarin or rivaroxaban. If the patient's lipids are absolutely normal, I think, it's very, when I mean normal means, let's say LDL is below 50, I don't think there is even need of a statin. It may be just a systemic inflammatory state or a local endothelialitis, which is very common in plaque erosion. And this could be because of smoking, sometimes other inflammatory disorders, this could be not requiring many aggressive antiplatelet therapy in many of these forms. So I think that at the end of the day, we don't have an answer, but I think at this point of time, we treat medically. It could be anticoagulant plus 1 antiplatelet, or I'm not sure whether it is dual antiplatelet sometime with anticoagulant, and then after that something. But a follow-up angiogram is going to be very important, and a follow-up CT should be good enough. We don't even need an angiogram and OCT.
Dr. Ajit, actually, every case you require an anticoagulant, or you can just go with antiplatelet alone?
Well, Vijay could possibly clarify how many patients we've done. He's been leading this work, yeah.
I think it is, initially we thought anticoagulant is very important in this type of patients. The problem here is, see, hardly you see any plaque here. And if this case is a very nice case, because you see that if you carefully see, the first time the lesion was proximal, right? And that site is ectatic now, and the distal there is a plaque lesion now. It is a long segment of ectasia is thrombosed in the proximal part of first time and the distal part now. And I'm very sure if we are going to bring him back anyway, when we do OCT, there will not be any plaque at all. This may be a different subset to erosion, rupture, calcified nodule. This is a subset, most probably whatever patients who had COVID vaccination or COVID infection, these are the type of patients highly likely to get thrombosed. Because already there is a substrate inside that is slow flow. So if you take virtuous triad, there's 3 things, right? Endothelial damage and slow flow means. And the third thing is systemic hypercoagulability. So these are patients, the slow flow is always there. When you get some inflammation or something which it triggers an additional insult, they get thrombosed. And most of these patients, there is absolutely no plaque. And it is damn sure that it's not rupture, sir. Because we have done many of these OCTs on these patients. And the rupture means you should have plaque anywhere. So if you see that OCT in other parts of the vessel and absolutely no plaque. So this is no plaque rupture. And whenever you have your lumen is big and you can safely leave this patient, so you are just to do something to prevent further accumulation of thrombus. And this thrombus nicely clears during follow-up.
Okay.
Dr. Ajit, one question, if I may be permitted.
Yeah, go ahead.
So two things are very important to know that when to intervene in coronary artery aneurysm, intervention-wise. Two questions are very important. I think we have got some insight from the car registry that has shown, I think Dr. Vijay will agree that they have shown that with the oral anticoagulant, they have I think they have taken around 400 patients and have shown that with the oral anticoagulant, there was some reduction in MACE as far as unstable angina myocardial infarction is concerned. But my question to Dr. Ajit is when to intervene. Like we don't have any data regarding the, okay, at this size, we should go for intervention, like we should go for, surgical or maybe PCI. So what is your usual practice? Let us suppose you have got a proximal LAD with an aneurysm of a particular size, when you will intervene.
You mean to say a coronary artery aneurysm, when to intervene? It's a question?
Yes, sir.
So, well, one thing is that we need to be very clear what is the cause and what is the problem. The patients may have incidental small aneurysms during angiograms, and you don't need to intervene in any of those patients, number one. Many times you see small aneurysms in the left and right, which you don't need. The second is, this is an aneurysm which is a true aneurysm or a pseudoaneurysm. Many of these patients may have an infected pseudoaneurysm, which may be usually because of infection in a previous stent, because of re-sterilization and stuff like that. This is usually, there is infective endocarditis there. These patients should undergo a surgical treatment and removal of that infection, because you put something in there now, after that, there are going to be more problems. Finally, if the aneurysm is creating documented ischemia, either at the site or due to embolization from that area, that's when you decide to intervene. Or if the aneurysm is very large, like what Vijay said, we had one case which looked about a small aneurysm on the angiogram, but when we saw the CT, it was almost all over the mediastinum, the whole aneurysm, 5 centimeters size. So those patients need surgery. Now, smaller aneurysms like what Rajesh showed can be fixed ideally with a stent graft if the vessel size is large, because stent graft problem is that it may occlude after you put a stent graft. So if the vessel is large, then you aggressively give dual antiplatelet, they may be good. But again, imaging is important that you fix the vessel well and see that you have a follow-up. And finally, I wouldn't put a metallic stent, simple metallic, especially long stents within aneurysm, because again, two things. One is the chance of it having a fracture, because the stent is wobbling along inside that aneurysm and could break, and could also create a nidus for clotting.
And anybody think that if we had M-Guard stent, maybe it may be an ideal thing to use it in this type of aneurysms, right? So it can create a flow modulation. Aneurysm may regress, but unfortunately, we don't have it anymore.
Dr. Ajit, if I may be permitted, it is always exciting to listen to you, because you look at the patient as a whole and not just treat the coronaries, you treat the patient. And that is clearly demonstrated in the case that you showed. Only two questions I wanted to ask you. Why the preference for rivaroxaban and not some of the other NOAC, number one? And number two, if the patient were to present with STEMI, let us say, this patient had the luxury of an end STEMI, so you could cool off for a couple of days and then take the patient to the cath lab, look at the OCT, and then defer a stent, etc. What would be your approach if this young patient who's a smoker, let's say he's 30 years of age, comes with a massive ST elevation MI? How do you approach?
So this we have published before, that even with STEMI, the approach is the same. You go in and look at the vessel. If it is an occluded vessel, you suction it with thrombosuction. We have used intracoronary lysis in many patients, and they start improving on the table, and many of these clots start disappearing on the table. And then you look at the lumen and the flows, and you see that the lumens and the flows are getting it's a large thrombus. You should not stent, because if you put a stent, two things will happen. One is you'll push all that other thrombus down distally, and that will create no reflow in those patients. And that's not a very bright idea. The moment the TIMI flows improve and you've done your thrombosuction or you're given your intracoronary lytics and things start improving, it's better to just cool down the patient a bit. As long as the lumens are good enough. If the lumen is very small, then it's likely to close on you. And that was the problem with the deferred stent strategy, that if you didn't look at the image and did that, we would land into trouble. So I think the most important thing is to have two things: good TIMI flow, good reasonable lumen, more than 2 millimeter square, and most importantly, be sure that there is not more plaque, and is that which you can easily image and see that it's not large plaque and less thrombus, but more thrombus and less plaque. That much at least you can see. As Vijay said, if the distal vessels show no coronary artery disease, it's only say a proximal DID proximal. It's very likely that this is either an erosion because of an endothelial problem at the local site, typically of smokers.
And why the choice of rivaroxaban?
Well, we were using warfarin until a few years ago. It's just that we now got NOACs. It could be any of these, anticoagulants. Rivaroxaban once a day is easy, but you should. I'm not sure. It's not the 2.5 BD dose of Compass that you use. Here we need good anticoagulation. It's like an atrial fibrillation dose that you would use at least initially to get the clot cleared. I think, Rajesh, we could close the session. I think we had an interesting 3 days. Rajesh?
Yes, thank you very much. And as a customary, let me give the vote of thanks to each and everyone. It was a remarkable 3 days of IPCI scientific meeting covering all the topics related to intracoronary imaging and physiology. The meeting was well attended across the globe. There were about 150 national faculty and 18 international faculty who could join the meeting. There were about 300 attendees in the fellows course and more than 500 attendees for rest of the session of the IPCI digital platform. There were a few hundreds of unaccounted attendees on YouTube and Facebook as well. On the behalf of organizing committee, I would like to thank each and every one of you who spared their precious time to attend this meaningful event and enlighten one another by sharing their respective experience in different fields of imaging and coronary physiology. Each of the national and international speakers, chairperson, and expert panelists show their sincerity and dedication with respect to their assigned role and responsibility so that the content remain interesting and of utmost scientific value. I'm thankful to all of them. This could not be possible without the active support and guidance of course co-director. I really feel privileged to get an opportunity to host the IPCI 2021 and thankful to IPCI core committee members, Dr. Ajit Mulasari, Dr. Sangat Velu, and Vijay Kumar for it. The commitment, support, and participation of all the eminent course co-directors is really commendable, including that of Dr. Ashok Seth, Dr. Balbir Singh, and Dr. Simon Matthew. Like always, the support of all our industry colleagues is crucial and important right from the coordination level till the conclusion. And I, on behalf of organizing committee and the course director, extend my sincere thanks to all the industry colleagues for their dedication, support, and passion to make this successful program. Words are not sufficient to thank all the fellows and colleagues from the Department of Cardiology, PGI, for extending their uninterrupted support for the meeting. A special thanks to my team, including Dr. Ganesh, Dr. Atit, my secretarial staff, Mr. Amit, and others, including Suvinder Singh, Punit Sharma, Prince Chaudhary, and Nikhil Sharma, whose uninterrupted 24/7 support could make the thing possible in the beautiful way. I'm also thankful to Peter Anand, the digital network was provided by him, and it was a very good quality audio visual without any technical hitch and interruption. I wish and hope that this unique meeting will go on for years, reach to the newer heights, and continue to reach the spread and knowledge of science to all the interested and enthusiastic medical personnel. With these words, I would like to conclude the meeting and wish you all the happy Sunday. Thank you very much.
Thank you.
Thank you.
Thank you.